Sir,
Hello?
yes, sir. I am audible to you, sir.
Yes,
Morning,
yes. How about? ठीक है, एक टाइमर लगा दो ना.
sir, है सर certain timer. जूम पे आप देखिए सर टाइमर लगा हुआ है ऑलरेडी.
नहीं, अभी जूम पे है क्या?
हाँ.
काउंटडाउन का टाइमर वो बोलेगा.
हाँ सर, है सर.
वो मेरे को क्यों नहीं दिखाई दे रहा है यार फिर?
सर आपका उसमें गैलरी व्यू होगा और स्पीकर भी होगा सर. फिल्म में सर.
आईपैड से मैंने लॉगिन किया है, इसमें समझ में नहीं आ रहा है. ठीक है, देखता हूँ.
Right. Yes, sir.
Can we start? Pankaj. Good morning, friends, and welcome back to the third and the final day of the 8th edition of Hyderabad Intensive Care Symposium. And I hope you all had a great, last 48 hours of learning and interaction with the faculty, and hope that we will continue the same for the last and the final day. To take the proceedings further, the first session, or the theme for the first session, is about the paradigms shifts that have happened. As we all know, that dynamic intensive care is a dynamic specialty, and we often see a lot of ideas, thoughts changing over a period of time. And to take you through some of the great shifts that have happened in the way we have thought about intensive care, I invite the first speaker of the day, Dr. Sunil Garg, who is going to speak to us about the paradigm shifts in the practice of stress ulcer prophylaxis. Over to you, Dr. Sunil.
Good morning, everybody. My name is Dr. Sunil Garg. I'm a senior critical care physician at Simon Healthcare, New Delhi. So today I will be talking on stress ulcer prophylaxis. In short, it is called as SUP. So what is stress ulcers? They usually start to develop within hours following the onset of serious illness or major trauma. Most commonly sites are the body and fundus of the stomach, and they are typically shallow, not deeper. And most likely etiology is deficient mucosal protection rather than hypersecretion of acid, which is a less common factor. Stress ulcer can lead to GI bleeding ranging from minimal to clinically important, and PPI and H2 receptor antagonists are often administered prophylactically to decrease the risk of stress ulcer development and further bleeding. Although about 75% of critically ill patients who do not receive stress ulcer prophylaxis develop stress ulceration, only a minority of these ulcers bleed. So, a very important to remember is majority of patients develop ulcer, but minority of these ulcers bleed. And recent studies have questioned the efficacy of stress ulcer prophylaxis. That's why we are talking here. So come on, the categories, definition and incidence. So category, basically we have divided into three categories. Number one is stress ulceration without occult bleeding. The definition is fecal sample with stool blood test is positive and the incidence is 15 to 50%. Number two is stress ulceration with overt GI bleeding. So the patient will present with either metastasis or bloody nasogastric tube aspirate or melena, but the incidence is only 1.5 to 8.5%. Number three is stress ulceration with clinically important GI bleeding. And the definition is overt GI bleed plus one or more of the following within 24 hours. So what was the definition of overt GI bleed? That was the hematemesis, bloody nasogastric tube aspirate, some melena, plus decrease in systolic, mean arterial blood pressure or diastolic blood pressure of more than 20 millimeter of mercury. Orthostatic hypotension, that means there is a drop of more than 10 millimeter mercury of systolic blood pressure. Or postural tachycardia, that means if a person is standing, so there is an increase in pulse rate of equal to or more than 20 beats per minute, or drop in hemoglobin by equal to or more than 2 gram per deciliter, or there is a received transfusion of equal to or more than 2 units of packed red cells, or need for vasopressors or invasive intervention, that is endoscopy. So this is type third, and the incidence is, by luck, it is very less, that is 1 to 3%. So what are the risk factor of stress ulcer? So this was the article which was published way back in 1994 in NEJM by Deborah J. Cook. So basically, this was a multi-center prospective cohort study of 2,252 critically ill patients. And the biggest risk factor identified in this study were positive pressure ventilation for more than 48 hours and bleeding diastasis. That means patient is having any bleeding diastasis or coagulation disorder. And the incidence of stress-related GI bleeding when these risk factors were present was 3.7% versus only 0.1% in patients with no risk factors. So in 1994, these biggest two risk factors were identified, and here we are sitting in 2023, and even after 29 years, these are the two biggest risk factors which are still persisting and still in the literature. So talk about other risk factors. So basically, the major risk factor we talk about the positive pressure ventilation and coagulopathy that we have already discussed, and the history of GI ulceration or bleeding within past year, acute traumatic brain injury or spinal cord injury, or major thalmar injury. But there are some minor risk factor also, which is sepsis, intensive care unit stay more than 1 week, or occult GI bleeding for more than 6 days, or patient is on steroids, or there is a use of antiplatelet or NSAIDs, or there is a renal failure, or patient are on RRT, that means renal replacement therapy. The patient is of hepatic failure, there is history of peptic ulcer disease, or patient is on extracorporeal life supports or organ transplantation. However, no single variable is an independent predictor of clinically important GI bleeding. The decision to use prophylaxis should be tailored to the individual patient. So coming on SUP, that means stress ulcer prophylaxis. So basically, this was the article which was published in JAMA in 1996, and as per this article, there is a strong evidence of reduced clinically important GI bleeding with ACE2 receptor antagonist. At that time, PPI was not available. So they have compared it with ACE2 receptor antagonist versus sucralfate. So they have concluded that sucralfate may be as effective in reducing bleeding with lower rates of pneumonia and mortality compared to ACE2 receptor antagonist. Then the second article, which was published in July 2017 in Critical Care Medicine. This was a pilot RCT in meta-analysis. So it was for evaluating the safety of withholding proton pump inhibitor for stress ulcer prophylaxis in critically ill patients, right? And surprisingly, there was no significant increase in risk of upper GI bleeding, mortality, or infections in patients who were not given proton pump inhibitors. This was a study which was a very famous study, was published in New England Journal of Medicine in 2018, which is called a SOAP ICU trial. Right. So stroke ulcer prophylaxis ICU trial by M. Krag. So this was an European parallel group blinded RCT, which was done in 3,298 patients in 33 ICUs of Europe and UK. So in Europe, they have covered the Denmark, Finland, Netherlands, Norway, Switzerland, and obviously the UK. So this evaluated patients who were in ICU and were at risk for important stress-related GI bleeding. 20% of these patients had coagulopathy and 79% were receiving positive pressure ventilations. So if you look at the first article which was published in NEJM in 1994, and the two biggest risk factors for overt GI bleeding was coagulopathy and positive pressure ventilation, right? So they compared pantoprazole with placebo, and clinically important stress-related GI bleeding was 4.2% in placebo versus 2.5% in pantoprazole group, with a risk ratio of only a risk reduction of only 0.58. But no p-value was presented, and more patients in PPI group required transfusion than in placebo group. This was surprise. Actually, we couldn't go inside to look at this. And no increased incidence of infectious events, that is the composite endpoints of nosocomial pneumonia and Clostridium difficile infection between PPI and placebo. And 90 days mortality rate was also same in prophylaxis group versus placebo group. So this was a basically landmark trial, which was actually published in 2018, and it actually put up the PPI or SUP, that is stress ulcer prophylaxis, in questions. So this was another article which was published in 2019. It was actually a systemic review basically, and they were unable to refute a relative change of 20% of mortality. The occurrence of GI bleeding was reduced, but they lack firm evidence for a reduction in clinically important GI bleeding. But they have concluded that effect on SAE, HRQL, pneumonia, myocardial ischemia, and Clostridium difficile enteritis remain inconclusive. So now the question is, for stress ulcer prophylaxis, what agent should I use? So there are a lot of agents, that is a proton pump inhibitor, histamine 2 receptor blockers, and the sucralfate. So the choice should be tailored to the patient needs, comorbidities, potential risk factor for pneumonia and Clostridium difficile infections. So this is an article which was published in JAMA 2014. It was a large propensity match cohort study of patients who were on positive pressure ventilation for more than 24 hours. The sample size was very huge. That was around 35,000 patients. And pneumonia was more in PPI group versus S2 receptor blocker group. And this was statistically significant with p-value of less than 0.001. And Clostridium infections was also pretty high in PPI group versus H2 receptor blocker group. So that was here also the p-value was significant, right? So here basically the PPI came into the questions because the side effects were more, and if you look at the efficacy was coming same. So this was another article which was actually Cochrane meta-analysis of a teen study which was published in Anism in 2018. Oh, sorry, I wrote it by mistake. This was in Cochrane library. So they have concluded that PPI were more effective in suppressive gastric acid than H2 receptor blocker, right? So basically, they didn't conclude the side effects. A peptic investor, again a landmark trial which was published in JAMA in 2020. So basically, this was an RCT which was done in 26,982 patients, roughly 27,000 patients, critically ill patients who were receiving positive pressure ventilation. So there was statistically significant decrease in GI bleeding in patient taking PPI versus H2 receptor blocker with statistically significant p-value. And Clostridium difficile infections were basically, you can say, were almost same in PPI versus H2 receptor blocker group, and the pneumonia was almost same with 6.5% versus 5.8%. So this was peptic investigators. So PPI may be more effective than H2 receptor blockers in preventing GI bleeding, but there is an increased concern of pneumonia and Clostridium difficile infections. PEPTRIC trial largely dispelled this concern after finding no increase in Clostridium difficile infection or in pneumonia. So I can go back for this slide. If you look at, this is the peptic investigator which was published in JAMA 2020. So Clostridium infection was 0.3% in PPI versus 0.43 in H2 receptor blocker, while the pneumonia was 6.5% in PPI versus 5.8% in H2 receptor blocker group. So it was statistically not significant, right? So PEPTRIC trial supported by the SOAP-ICU trial, which found no increase in incidence of infectious events between PPI and placebo. And 3 meta-analysis also didn't show an increase in risk of infectious complications between PPI and H2 receptor blocker. So given these data, we prefer an oral PPI to a H2 receptor blocker in high-risk patients who can receive enteral nutrition to decrease their risk of clinically significant GI bleeding. We do not use IV proton pump inhibitor unless a patient is actively bleeding from a stress ulcer or cannot tolerate enteral nutrition, because the cost of IV PPI is very high compared to oral PPI. And in rare cases in which PPI and H2 receptor blocker cannot be used for prophylaxis, sucralfate may be considered as an alternative. So look, coming on the indications we have already actually looked on our second or third slide. So major risk factor and the minor risk factors. However, no single variable is an independent predictor of clinically important GI bleeding. So decision to use prophylaxis should be tailored to an individual patient. What is the role of enteral nutrition? So very much asked to the students basically in the exams also. This was the study which was again published in Critical Care in 2018. Basically, it was a meta-analysis. And basically, they concluded that prophylaxis provide no added benefit to patients who are already on enteral nutrition. no statistically significant difference in the rate of GI bleeding if you are not giving those patients PPI who are receiving enteral nutrition. No effect on duration of positive pressure ventilation, incidence of Clostridium difficile infections, and no effect on ICU length of stay or overall mortality. So, to conclude by this article, the patients who are on enteral nutrition, even you have not to give enteral PPI or enteral H2 blocker agents, right? So early enteral nutrition is recommended and it promotes you can say the gut integrity, decreases infectious complications and the morbidity and the mortality. Because there are no data from prospective RCTs or EN as a sole means of stress ulcer prophylaxis, we believe that EN should not replace prophylaxis in high risk critically ill patients. No national or society guidelines recommends the routine stress ulcer prophylaxis in non-critical care settings. You talk about any guidelines like American Society of Health System Pharmacists, Danish Society of Anesthesiologists and Intensive Care Medicine, Surviving Sepsis Campaign, Danish Society of Intensive Care Medicines, right? So all guidelines recommend stress ulcer prophylaxis to be administered to patient with critical illness with additional risk factors for clinically important stress-related GI bleeding, which are those factors: coagulopathy, need for mechanical ventilation for more than 48 hours. So I have already said in the first slide, the article which was published in 1994 in NEGM, the two biggest risk factors were coagulopathy and need for mechanical ventilation. So here they are also same. Requirement of renal replacement therapy, established liver disease and elevated scores of organ failure. So why we want to avoid PPI actually? Because the complication of long-term PPI use are the bone fractures, hypomagnesemia, Clostridium difficile infection, acute kidney injury, chronic kidney injury, and pneumonia. So what is the optimal duration of PPIs? Basically, it is unclear, but while most experts agree that prophylaxis should be used if risk factors are present, there is limited agreement on when to stop. A practical approach would be to evaluate indicator associated with a high risk for developing stress ulcer. And once these stresses have been mitigated, prophylaxis could possibly be de-escalated, like the antibiotic could be de-escalated. So reducing inappropriate PPI use after discharge. PPI are often initiated in the hospital settings and up to half of these new prescriptions are continued at discharge. This is the irony actually. An excess risk of long-term adverse events and need to implement interventions that lead to discontinuation of inappropriate PPI use. That is education for providers, development of clinical guidelines and pharmacist-led interventions. So bottom line is, SUP does not reduce mortality rates, but on the other hand, it decreases the risk of clinically significant bleeding and does not increase the risk of Clostridium difficile infection or pneumonia. We believe that prophylaxis should be considered in critically ill patient with risk factors for stress ulcer. Frequent assessment, reassessment, and de-escalation of therapy are warranted when the patient is at lower risk of bleeding. Thank you very much.
Unmute, sir, please.
Thank you, Sunil, sir. It was a
Hello, good morning all. The next lecture is going to be on DVT prophylaxis by Dr. Pragyan Rotre. He is the head of the department.
Pragyan Kumar Rotre, sir, HOD Critical Care of Care Hospitals, Bhubaneswar. Over to you, sir.
Greetings of the day. At the onset, I would like to thank Dr. Srinivas Samvidham and Dr. Ghanshyam for giving me this opportunity. And it's always warm to come back to HICS again. And it's my second outing in the HICS. And thank you, Dr. Ghanshyam and Dr. Samvidham again. The topic given to me is really interesting this time. Why has the paradigm of DVT prophylaxis changed? And it's one of my favorite topics. So we'll touch down few of its salient points in coming few minutes. DVT is, of course, a clotting of blood in deep vein of extremities, occurs most commonly in lower extremity of pelvis. Of course, it can occur in upper extremity as well. Roughly 4 to 13% of DVT cases occur in upper extremity. It's not that rare. It's a common, rather very common, yet preventable condition. Leading contributor to increased length in hospital stay. Leading cause of preventable hospital death worldwide as per a lot of studies as well as US major studies they have found out. Highest risk is in critically ill and spinal cord injury patients. There is a lot of immobility there. Of course, 60 to 80% of these patients go into these complications. Post-ortho case, it has been documented in 40 to 60% of cases. Post-general surgery, obstetric case, 15 to 40%. And a lot of area surgery like bariatric surgery, urological surgery, they also contribute a few percentage of for this DVT prophylaxis, DVT, having this DVT. Incidence, as per the last record in 2014, it's 6 lakh cases per year. And in a study of critically ill patient, it occurs in 10 to 30% of the medical or surgical intensive care in patients within first week of admission. Approximately 60% of trauma patient had DVT within first 2 weeks, most of which are clinically silent. The silent is a keyword here because it silently kills. 60% of DVT occurs in post-hospital discharge period, but only 4% receive DVT after discharge, which we'll be discussing in coming few slides. The major paradigm changes in DVT prophylaxis lie around the risk assessment and what to be given among all the drugs available in our kitty and whom to be given. And there is a very, very salient point, which is major paradigm shift in this sort of DVT prophylaxis is extended prophylaxis, which we will discuss in detail. Pathogenesis, I would go much deep into it. As we know, stasis, vessel injury, hypercoagulability are the key of the varicose triad. Majorly, I'll discuss hypercoagulability, increasing age, malignancy, cancer therapy, estrogen therapy, acute medical illnesses, inflammatory bowel disease, nephrotic syndrome, myeloproliferative disorder, paroxysmal nocturnal hemoglobinuria, a lot of inherited and acquired hemothromophilia. A lot of these things contribute to the pathogens and risk factor of DVT prophylaxis. Of course, there are a lot of risk assessments surrounding it, and there are a lot of prediction scores. I can name few among medical patients, like Padua prediction score, improved risk assessment model, modified Wells criteria, revised Geneva criteria. Out of this 4, Padua prediction score and improved risk assessment model after extended prophylaxis, while modified Wells criteria and revised Geneva criteria are mostly for the hospital DVT prophylaxis, and last 2 like Padua and improved risk assessment for post-hospital discharges. And surgical patients, they can undergo Caprini score and Roger score. So there are a lot of thought about it. Previously, we used to think there has to be a universal DVT prophylaxis, but looking into the complications like bleeding, it has been formulated that let us go away from universal prophylaxis, rather let us focus on risk assessment wise DVT prophylaxis. That's why scores are for, if your score tells that you need DVT prophylaxis, we should be giving DVT prophylaxis. Let us discuss some of the scores at the onset. Padua prediction score, active cancer, previous VT, bed rest, thrombophilia, they contribute 3 points each, while recent trauma, elderly age, they contribute 2 score, while heart and respiratory failure, AMI, acute infection, obesity, ongoing hormone treatment, all this contributes to 1 point. So if your score is more than 4, then you are a high risk of venous thromboembolism. And coming to the next one, the improved risk assessment model, where you can find that if there's a prior venous thromboembolism, you get a 3 score. Diagnosed thrombophilia, you get a 2 score. Current lower limb paralysis, 2 score. Current cancer, 2 score. Immobilized for last 7 days. Stay in ICU or coronated for and more than 60 days, they score 1. This is a very, very important model to predict whether patient require prolonged DVT prophylaxis following hospital discharge or not. Modified Wells criteria, we all are very aware of. This is a basic criteria which we have been taught from MBBS days. First was Wells criteria, then it went into modified Wells criteria. The scoring system more or less same as the previous one: cancer, paralysis, recently bedridden, localized tenderness, entire leg swelling. And if a score is more than 2, there's a more likely of probability DVT, so this patient needs DVT prophylaxis. Coming to revised Geneva criteria, I won't go deep into it. Same thing, risk factors like age, previous DVT, surgery, active malignant conditions, unilateral low limb pain, hemoptysis, heart rate more than 75 to 94, or more than 95, all have been given a scoring system, and with this scoring system, we decide whether patient has a low probability of DVT, intermediate probability, or high probability of DVT. Accordingly, we decide what to be given and how long to be given. And there's another score called Caprini score, which again can be given a lot of points. Like if there's things are present, we can give 1 point. If other risk factors, then we can give 2 points. And accordingly, we divide the points. If scoring system is more than 9, then there's a very, very high risk of DVT. If score is 5 to 8, there's a moderate risk. If 4 or 4, it's a low risk category. In general, VT prophylaxis should be conditioned in patients who are older than age, who have limited mobility for a few days and have at least one thrombotic risk factor. If you have all these things, it means that you need a venous thromboembolism prophylaxis. Of course, all patients admitted to intensive care units are considered as high risk for VT, but again, we need to do a risk assessment before blindly starting VT prophylaxis. Of course, whenever there is a risk of DVT, you are starting a drug that always carries another risk called bleeding risk. So DVT risk should equally be balanced by the bleeding risk that comes along with the DVT prophylaxis treatment. The cumulative incidence of major and non-major in-hospital bleeding within 14 days of admission is roughly 3.2%. Active gastroduodenal ulcer contributes a major part of it. And platelet count less than 50,000 is an independent risk factor. Other bleeding risk factors include increasing age, hepatic renal failure, intensive care and stay, presence of a central venous catheter, rheumatic disease, cancer, menses, etc., etc. There are a lot of scoring system like a bleeding risk assessment that has been retrospectively done from improved study. And there are a lot of scoring. Again, this is a very improved. We call it as improved bleed score, where a lot of points are given to renal failure, male versus female patient, age, current cancer, rheumatic disease, cardiovascular catheter, ICU stay, hepatic failure. And if all these scores come to more than 7, you form a very high risk of bleeding and major bleeding risk of 4.1. If this risk factor is very high, then you should think twice or thrice before starting a DVT prophylaxis for a prolonged duration or a shorter duration. Even that is why we need to understand that even there is a chance of DVT risk, starting a DVT prophylaxis is very much essential. At the same time, you should always keep in mind the bleeding risk is also there and do an assessment for bleeding risk as well. What are the type of thromboprophylaxis available to us? Of course, intermittent pneumatic compression, graduated compression stocking or GCS, venous foot pumps, we won't be discussing that. And pharmacology like unfractionated heparin, low molecular weight heparin, fondaparinux, vitamin K antagonists like aceclidine and warfarin, and newer oral anticoagulants. This is a major paradigm shift in newer oral anticoagulants that we will be discussing a little bit in more detail. Mechanical thromboprophylaxis, where we need to give at a high risk of bleeding or anticoagulation is contraindicated. And definitely there should be always an inclination to change to pharmacological agent whenever the bleeding risk is acceptably low or it has been reversed. And this mechanical thromboprophylaxis has been a lot of time assessed in stroke patient, mostly patients with interstitial hemorrhage. This is a very beautiful study we call as CLOTS trial, one very famous study. The interpretation that data do not lend support to the use of thigh-length GCS in thigh-length compression stocking in patients admitted to hospital with acute stroke. So we need to understand that compression stocking doesn't help in low GCS patients. And this is another called CLOT3 study, which shows that IPC is an effective method of reducing risk of DVT and possibly improving survival in a wide variety of patients who are immobile after stroke. And this another CLOT of the CLOT and CLOT3 study came. If you do not have assessed, do not have the courage to start the chemical pharmacological prophylaxis in this high-risk patient, IPC can be given. It is a little bit better than anything else. The European guidelines recommend against the use of graduated compression stocking alone without pharmacological thrombolysis prevention. That only graduated compression stocking doesn't help much. And use of intermittent pneumatic compression or graduated compression stocking is a better modality whenever there is some risk of DVT lies over there. But more importantly, American guidelines do not support the use of combination therapy over either pharmacological therapy or compression therapy alone. So there are a lot of studies that my patient is at very high risk of DVT. Let us give mechanical and pharmacological together. A lot of studies, guidelines have shown that it doesn't help, which I'll be giving in one or two lines. I would like to quote the SSB guideline 2012 with the 2.7.2 score this time. The acutely ill hospitalized medical patients at increased risk of thrombosis who are bleeding or at high risk of a major bleeding, we suggest the optimal use of mechanical thromboprophylaxis with graduated compression stockings or intermittent pneumatic compression. So although we have a lot of debate over whether to be given GCs or not, but SSB 2012 guideline says that we can start it at per the SSB guideline. Coming to adjunctive mechanical to pharmacological prophylaxis. So whether we should be giving mechanical thromboprophylaxis to pharmacological thromboprophylaxis, that I told in last few slides back. Recent study that don't show much benefit if you add a mechanical to already somebody getting a pharmacological thromboprophylaxis. This is another beautiful study where said that adjunctive intermittent pneumatic compression of venous pulse, they have concluded that among critically ill patients who are receiving pharmacological thromboprophylaxis, adjunctive intermittent pneumatic compression did not result in significant lower incidence of proximal lower limb deep vein thrombosis than pharmacological thrombosis alone. So it means that even if I add a mechanical thromboprophylaxis to a pharmacological thromboprophylaxis, let us say heparin or low molecular heparin, it doesn't decrease the incidence of deep vein thrombosis even compared to using a pharmacological thromboprophylaxis alone. So taking into account the cost factor, it is not required to add another mechanical to a chemical thromboprophylaxis. What are the agents we have? We have unfractionated heparin, we have low molecular heparin, we have fondaparinux. And there's the same SSB guideline which says that recommendation are for low molecular heparin or unfractionated heparin in a BID dose or TID dose, or fondaparinux can also be given. So what we need to understand that typical anticoagulants are provided as fixed dose, but it is metabolized at a different rate. So studies have shown that majority of the patient receive inadequately from a fixed dose anticoagulant strategy. So patient level factors predict the rapidity of anticoagulant metabolism, hence making dose adequacy a potential sensitivity. So weight-based enoxaparin dosing significantly increase the proportion of patient with adequate anti-factor Xa levels. So a lot of times we give blindly a fixed dose of low molecular heparin, but studies have suggested if you give a weight-based, there is much more impetus to this prophylaxis treatment. A lot of methods have proven that unfractionated heparin in a BID dose is almost equivalent to TID dose in relative risk reduction of DVT, P, or death or MHC grading. Coming to NOACs, there's a new drug that has come into picture. So newer oral anticoagulants, evidence has suggested that they exert more benefits on VT prophylaxis, and none of the individual NOACs increased hemorrhages compared with the non-NOACs. So if you compare warfarin, aceclidine with a lot of NOACs like dabigatran, rivaroxaban, endoxaban, they do not increase chances of bleeding more compared to this non-NOACs. More importantly, rivaroxaban is recommended in patients with lower bleeding risk, and apixaban is recommended in patients with higher bleeding risk. This is a understanding from this beautiful study which has recently published in 17 January 2022. So NOACs DVT prophylaxis effectiveness lack study in medical and surgical patient, but in orthopedic patient, a lot of studies have come into picture which I'll be depicting in coming full slide. They have found that dabigatran, rivaroxaban, and apixaban are at least equally efficacious as low molecular heparin with a less bleeding complication. Coming to the thing I was going to discuss in a little bit more detail, extended thromboprophylaxis, that is thromboprophylaxis for up to 45 days following an acute hospitalization for medically ill patients. So how an anti-thrombotic guideline clearly states against the routine use of extended thromboprophylaxis, but a lot of studies have come into picture where they've shown that rivaroxaban is non-inferior to low molecular heparin when you give for a longer duration. Coming to rivaroxaban versus enoxaparin for thrombolysis after hip arthroplasty. So a once daily dose in 10 mg rivaroxaban was significantly more effective for extended thromboprophylaxis than once daily 40 mg subcutaneous dose or in patients undergoing elective total. So into elective total hip arthroplasty, we have found that rivaroxaban is almost equivalent to enoxaparin. There is a very beautiful study called EXCLAIM study, which says that maybe net clinical benefit with use of extended duration of enoxaparin in patients with severe immobility aged more than 75 years and female sex after amending major protocol which led to difficult depression result. So using enoxaparin in acutely ill medical patients with recent reduced mobility may potentially lead to a reduction in incidence of late VT. So this is the first study which came into which showed us that if you give a little bit longer duration of DVT prophylaxis, there is a less chance of DVT. And this is another trial which indicates that rivaroxaban is non-inferior to enoxaparin at 10 days for efficacy, but superior at 35 days. So for NOACs, extended prophylaxis gives much benefit compared to our routine low molecular heparins. So coming to this another trial, all is not good. This is a trial about betrixaban in acutely ill medical patients. This trial we call it as APEX trial, which failed to show that extended duration betrixaban was superior to short duration enoxaparin at preventing thrombotic complication. That is why lately betrixaban and rivaroxaban has been FDA approved for DVT prophylaxis in orthopedics patients. But extended therapy practice, there is a very high risk of bleeding because you are going to give after hospital discharges, a patient is going to get it at home. So for a prolonged duration, more than 4 weeks or so, there's a very high risk of bleeding. That's why risk stratification is very, very important. So that's why improved score and PRADO score I have mentioned in the beginning, they should be risk stratified, accordingly counseled, and accordingly it should be started after case by case selection. There is now an evidence-based clinical benefit as well as regulatory approval for both betrixaban and rivaroxaban in key patient subgroup at high VT and low bleed risk for extended post-discharge DVT prophylaxis. But there has to be evidence-derived algorithm, which I'm going to depict now, which has been published in few journals, which can help us to decide whether patient requires extended DVT prophylaxis or not. So first, to start with, does the hospitalized medically ill patients have any of the following risk factors like acute GI bleed, history of bleeding within 3 months, dual antiplatelet therapy, bronchiectasis pulmonary cavitation, active cancer? If it goes no, then only we go towards extended prophylaxis. So did the patient receive in-hospital thrombolysis? If yes, then only we go to the next factor. And after you get a yes, do a VT risk factor assessment. If risk factor comes positive by doing an improved VT score and PRADO score, then only you start the patient for a total of 31 to 39 days of betrixaban, rivaroxaban, which has been recently FDA approved for extended thromboprophylaxis. This is SCP guideline 2012. I won't be going deep into it. You must be knowing in a lot of conferences, always a lot of DVT treatment protocols very much comes from these guidelines only. One important point is underuse of VT prophylaxis. Of course, as a lot of studies have shown that a recommended pharmacological prophylaxis is done only in 50.2%, and low risk patients are at time over prophylaxis. Like somebody not requiring, we do give them prophylaxis, increasing the risk of bleeding. Canadian hospitals have shown that 1/4 of acutely ill medical patients receive prophylaxis despite 90% had indication in it. So hardly 25% receive it when 9% indicated it. So underuse is also a very, very important point over here. So need of that is proper risk assessment, appropriate DVT prophylaxis, close consideration to adverse effects, correct drug selection, appropriate dosing, patient levels monitoring, individualization, and extended thromboprophylaxis in selected patients. Further research definitely required to do what should constitute preventable VT across medical and surgical patients, and we need to evaluate and test best methods to prevent missed prophylaxis dosing to improve compliance. We need to compare VT risk scoring prospectively against specific pharmacological and mechanical prophylaxis. There's a lot of things we can do further. So to conclude, a major paradigm shift around universal prophylaxis versus risk stratified DVT prophylaxis. Mechanical prophylaxis is inferior to mechanical plus pharmacological, and mechanical plus pharmacological is almost equivalent to pharmacological. So whenever there is a chance, always give pharmacological prophylaxis. If your bleeding width is terribly high, you can consider giving mechanical, but never consider combined effect. NOACs are definitely better. They have lesser side effects, equal efficacious, but in selected cases, nowadays it is now recommended for orthopedics like total hip replacement and total knee replacement. Extended DVT prophylaxis in selected cases, mostly in total hip replacements, can be given for a duration of 30 to 40 days, but it should be done after risk stratification and judging the side effect profile. Underdosing is a very, very important point. Overdosing is another paradigm shift, and a right dosing is the most important part, which we see in low molecular heparin quite often. Thank you. Thank you again for your patient hearing. Thank you so much.
Thank you, sir. That was a great lecture. Next, we go on to the next topic. Hello.
Audible, sir. Sir, please continue.
Am I audible?
Yes, sir.
Next, we go on to the next topic. The PEEP titration by Sunil Karanath, sir. He's the chairman of Critical Care Services, Manipal Health Enterprises, and the head of the department, Critical Care Medicine at Manipal Hospitals. Over to you, sir.
Good day, everybody. So I will be talking to you over the next 15 to 20 minutes on why has the paradigm of PEEP shifted. Now, what do we mean by PEEP? PEEP, otherwise called positive end expiratory pressure, is nothing but the positive pressure that remains in the airways at the end of the respiratory cycle, that is at the end of exhalation, which is greater than the atmospheric pressure in mechanically ventilated patient. Now, how do we define a paradigm? It is an important change that happens when the usual way of thinking about or doing something is replaced by a new and different way. So essentially what I'm going to talk about is what is the change or the normal pattern of things that have changed in the way we look at PEEP and the way we manage PEEP in patients in the intensive care unit. Now, a fundamental patient who is on positive pressure ventilation, a typical example of a volume control ventilation would look like this. The important terminologies to be aware of is the peak inspiratory pressure, plateau pressure, driving pressure, and the positive end expiratory pressure. This part of the graph represents the PEEP, that is number 4, as you can see. And the application of PEEP is the minimum pressure that is existing at the end of exhalation, as you can see. And on top of the PEEP, whenever inhalation takes place in positive pressure breathing, the pressure builds up on top of that. So that is the minimum pressure that is always present and helps in determining the functional residual capacity and a whole lot of other parameters that we will be talking about. Now, some of the things that we know about PEEP is the beneficial effects of PEEP. It was first described by in this landmark paper by Ashbog et al., who in a series of about 12 to 14 patients described the syndrome of acute respiratory distress syndrome in adults, and also described one of the effects that they described in it was the use of PEEP. Now, how does PEEP work is something which we need to understand before we look at how the paradigm has shifted. In this ventilating graph, as you can see, at the end of expiration, application of positive pressure breathing is what is called as PEEP, which helps in keeping the alveoli aerated and prevents complete deaeration of the alveoli and hence atelectasis or collapse. Now, if you talk about a person who is not having PEEP, or what we call a ZEEP or zero end expiratory pressure, at the end of the breath or at the end of exhalation, you might find that there is a contraction or there is complete collapse of the alveolus. Now, this is what we want to prevent. Some of the problems that are encountered in patients who do not have adequate PEEP or who do not have adequate end expiratory pressure is what we see here. There is collapse, there is which results, or there is atelectasis, which results in what is called as atelectotrauma. Because of the constant collapsing and aeration, there is shear stress, which results in biotrauma. There could also be volutrauma because of the atelectatic portions and the remaining non-atelectatic portions being very, very small. And therefore, you have the concept of what is called as baby lung, wherein those parts of the lung which are aerated get excessive volume, causing volutrauma, and a whole lot of other trauma that can result because of the positive pressure ventilation. Now, this is what we want to prevent, and by embarking on what is called as open lung strategy, which is accomplished with the use of PEEP. Some of the negative effects of PEEP are raised intracranial pressure, which can be present in patients who have these positive, or who have PEEP or moderate to high levels of PEEP. There could be excessive stretching of the non-injured parts of the lung. There could be effects on the right heart by increasing RV strain and causing cor pulmonale. There could be effects on LV as well by precipitating LV failure, particularly because of the increase in the transpulmonary pressure across the LV wall. And also, of course, in a hypovolumic patient, it could actually compromise venous return and further cause a decrease in the cardiac output, and therefore resulting in hypotension or hemodynamic instability. It's the way we look at PEEP has changed, and Gyatanani described this as in one of his papers as the best PEEP is never existing. To pretend and claim that we may find a PEEP level that avoids intratidal recruitment, derecruitment, providing in the meantime the best compliance, best oxygenation, and lowest dead space without causing hyperinflation and affecting hemodynamics reflects a wishful dream that has nothing to do with the reality. So in other words, application of the PEEP has to be optimal and pragmatic, and hence continuing to look for a single best PEEP may not be the most optimal strategy. So this is one of the shifts that we have noted over the last 2 decades, with better understanding of PEEP and better understanding of our way of ventilating ARDS patients. Now, coming to the setting of PEEP itself, this has also undergone paradigm shift over the last many couple of decades that we have known ARDS. The first scientific way of managing ARDS was by the ArtsNet study, which was a proper RCT multicentric study, which showed a class 1 evidence to say that low tidal volumes are the way to go, and the low tidal volume was described as 4 to 6 ml per kg. Now, this study used PEEP tables, which was PEEP in connection with the FiO2. So essentially, FiO2 PEEP tables were used to actually determine the level of PEEP that are going to be used on these ARDS patients. Now, the advantage of this was that it was simple, however, was not based on titration and had a lot of variability in response. So essentially, this was a one-fit-all solution, which was obviously not the way to go. And there was a variability in response when these response to PEEP, depending on the type of ARDS, extent of ARDS, and how the ventilation was delivered. The next importance of PEEP is of titration of PEEP is the oxygenation response. So in this strategy, we try to titrate PEEP to get the best oxygenation. And what we try to do, as you can see, is constantly increase the PEEP till the most optimal saturation is obtained. Now, the advantage of doing this, or the idea of doing this, is to ensure that the most recruitable part of the lung gets recruited, and you increase the PEEP to the point that wherever there is a collapsed or alveoli, you would actually remove the shunts, allow a proper aeration, either partial or complete recruitment of the alveoli. So essentially, it was targeting oxygenation without looking into very many other strategies, such as, is there barotrauma occurring, is there appropriate response occurring, what is the plateau pressure, etc. On this strategy, there was no data on mortality, though there was adequate data to support improved PaO to FiO2 ratio and improved oxygenation. Now, looking at the recruitment, or looking at the level of PEEP, moderate, high, etc., there was again there was data to support that PF ratios improved, but there was no data to support that there was definite improvement in mortality. However, when looking at pooled data from multiple studies, there was some suggestion that higher levels of PEEP, especially when the delta PEEP or the change in PEEP was more than 0 on the positive side, or there seemed to be some improvement in the adjusted probability of death, which was not so much when the PEEP was on the lower side, or when the delta PEEP, as we would call, was less than the positive side or less than 0. So essentially, a change in the PEEP, which was much higher, looked like had better benefit than just a very high level of PEEP. So what mattered seemed to be the delta change rather than the application of a high PEEP at all. Now, a couple of large studies, the LOVES trial, EXPRESS trial, all showed that there didn't seem to be mortality benefit. However, definite evidence of improved oxygenation, better PaO to FiO2 ratio was seen. When we actually looked at data from, looked at survival data or data of hospital discharge, there didn't seem to be any better outcomes with the use of higher PEEPs or lower levels of PEEPs. Now, this was in contrast to the fact that we did notice that there was enough data, there was enough literature to support that there was higher levels of PaO to FiO2 ratio, or better levels of oxygenation with higher levels of PEEP. In this context, this study published in the JAMA in 2008 showed that whenever PEEP was applied, looking at with adequate monitoring of the plateau pressures, also there didn't seem to be much benefit in terms of improved mortality. However, there was definite benefit in terms of better lung recruitment, better compliance, and also a better PaO to FiO2 ratio. So all in all, when a systemic review of these multiple trials was done and subjected to a meta-analysis, it did look that although ventilation with high PEEP in the ICU with the ARDS didn't reduce in patients with high PEEP, didn't improve the mortality, but there was certainly benefit in terms of improved hypoxemia and better PaO to FiO2 ratio in patients who are in the high PEEP arm, in patients with ARDS and those patients without ARDS. The next strategy was that evolved over time was PEEP guided by the use of driving pressures. What is driving pressure? This is nothing but a measure of the lung static compliance or the tidal volume that is delivered based on the difference between the P plat and the PEEP. So essentially, this red arrow that you see indicates driving pressure, or the pressure that is needed to expand the lung or to inflate the lung during inhalation or during positive pressure inspiration. Now, on analyzing data from the ArtsNet trials, it was found that those patients who had decrease in the driving pressure with the use of increasing PEEP indicated that their lungs were recruitable, and they seemed to have better outcomes or better mortality. On the other hand, those patients in whom increment of the PEEP didn't cause any change in the delta PEEP didn't have any change in the mortality. And finally, those patients who had no change in the driving who actually had worsening of the driving pressure or increase in the driving pressure with change in PEEP or with no change in PEEP showed that there was increase in their mortality. So essentially, it's summarized to say that those patients who had improvement in the delta PEEP or driving pressure with increasing PEEP meant that they had recruitable lungs and did better. And this analysis revealed that a delta PEEP of more than 14 was associated with poorer outcomes and longer ventilatory stays. The next strategy was, which has evolved over time, is PEEP guided by transesophageal pressure. Now, what is the concept here? The concept is that transpulmonary pressure is the difference between the airway pressure minus the pleural pressure. So when somebody is on positive pressure ventilation, the intra-alveolar pressure or the airway pressure is the one which inflates the lung, while the counter pressure that comes from the pleura is the pressure which opposes this inflating pressure. And the difference between these two pressures, which is the inflating pressure, which is the airway pressure, and the pleural pressure, which is the opposing pressure, is the transpulmonary pressure. And it is this transpulmonary pressure which determines the lung compliance. The esophageal pressure is, when you measure the esophageal pressure, in many instances, we know that the esophageal pressure is a very close approximation of the pleural pressure, and hence the indirect measurement of the pleural pressure using the esophageal manometer or the esophageal pressure a transpulmonary pressure was determined, and this strategy was used to set the PEEP. So the basic fundamental setting or the fundamental strategy that was used was to set the PEEP level at or below the pleural pressure at end expiration, and it was assumed that this would prevent alveolar collapse during expiration. A multicentric trial, which is published in the JAMA by Bettler et al., didn't show that there was a change in mortality, change in secondary outcomes with this strategy, or it was found that using the conventional empirical high PEEP FiO2 strategy against the esophageal pressure guided PEEP, there was no change or no difference in any of the outcomes, including composite score of death and ventilatory free period. The next strategy which was employed is the image guided PEEP titration. This study, which used CT to determine the compressive forces or to calculate the the CT derived PEEP and correlated that with lung recruitability, there absolutely seemed to be no correlation at all. So the upper scatter diagram shows the scatter of the lung recruitability, while the lower one showed the CT derived PEEP, and there seemed to be absolutely no correlation between the two. So it was based on this study, we know that the PEEP required in patients who had whose lung recruitability was determined on the CT didn't show any correlation with the actual clinical recruitability of the lung. The next modality that was used, or imaging modality that was used, was lung ultrasound. Multiple small studies of single center studies, especially in prospective and retrospective observational data, have shown that the lung ultrasound at the bedside was much better in terms of prediction of the lung recruitability using lung ultrasound than the CT. And there was significant correlation between ultrasonic re-aeration score and the lung recruitment that was measured using the pressure volume curves. However, one major problem was inability to determine hyperinflation, and hence the lung ultrasound cannot be used as a sole method for PEEP titration. Other methods are the use of electrical bioimpedance guided PEEP titration, which seem to be beneficial and may have a role to play in the future. So in short, the summary of the paradigm shifts that have happened over the last 4 decades of how we have looked at ARDS and how we have used PEEP is that at the outset, by the first landmark paper by Ashberg, which showed that PEEP as a therapeutic strategy for open lung ventilation or open lung strategy was beneficial. The pros and cons of its use we learned over time. The first RCT, which or a big, large multicentric RCT, where PEEP was titrated against FiO2 based on pre-specified tables, which had its own pros and cons. The second one was the use of tables with limitation of plateau pressure as a guide, which seemed to be useful to prevent secondary damage of the lung based on the indiscriminate application of PEEP. Then moving on to using driving pressures for defining what we call as optimal PEEP, and moving to the era of individualizing PEEP guided by imaging modalities or electrical impedance, and most important, currently used imaging modality, which is easy to use, short learning curve, is use of ultrasound. Thank you.
Thank you so much, Dr. Sunil Karan, sir. We have 3 questions actually for Dr. Sunil, sir. Hello?
Yeah.
Sir, three questions, sir. Sunil Garg, sir.
Yes. Go on.
Sir, for a cardiac patient who is on dual antiplatelet, sir, for the risk, they have the risk of GI bleed. And what are the indications for SUP for those patients? Hello?
I think the question is for Sunil Garg.
Sunil Garg, sir. Yes.
Yeah. Right.
Yeah, tell me, please.
Sir, for the cardiac patient who is on dual antiplatelet, sir, there is a risk of GI bleed. And what are the indications for SUP for those patients?
Oh, basically, if we talk about the older trials, like which was published in 1994. So basically, the one biggest risk factor was positive pressure ventilation, and second biggest risk factor was bleeding diastasis. So bleeding diastasis actually are the coagulopathies, but they doesn't cover the patient who are on antiplatelets. So a patient who is not on mechanical ventilation, not is having any bleeding diastasis, but are on antiplatelets only, we will not consider those patients as a high-risk patients. And even if you look at the indications of starting stress ulcer prophylaxis, we can say this is a minor risk factor, not the major risk factor. So again, the decision will be yours. Like if a patient is not on ventilation and only having antiplatelets, not having any bleeding diastasis, it's up to you whether you want to start it or not. But the final conclusion from our side was a patient who is having biggest risk factor, that is the mechanical ventilation, bleeding diastasis, you should start on oral, and not in any other patient.
Thank you, sir. The next question is for Dr. Pragyan, sir. Hello?
Yes, carry on.
Sir, do you think like NOACs can replace low molecular weight heparin in the future of ICU, sir, for DVT prophylaxis?
Yes, that's true. That's definitely. Now there are definite indications and guidelines for post orthopedic patient, like total hip replacement and total knee replacement. And in acutely ill, medically sick patients, it is a little bit dicey because of the problem of antidote actually. So we have some sort of antidote for low molecular heparin and unfractionated heparin, but the antidote for NOACs are although available, but not plentifully available in the market, not readily available. That is why it is dicey. So in coming futures, when we have good and economically viable antidotes available in the market, then definitely it will also come into guideline. Definitely, this is the future.
And one more question, sir. Patient who has a complete heart block and who has underwent a PPI. Later, patient was posted for permanent pacemaker, a TPI initially, and posted for temporary pacemaker. But between that, he has been stopped from the anticoagulants, and patient has developed a DVT. So, what's your call on it, sir? Should we continue between TPI and PPI before taking for PPI 24 hours apart? They have stopped the anticoagulant, but patient has developed DVT in between.
Definitely, this is we face not quite a lot often, but we have experienced that a few times. So more important is whenever somebody on TPI with a DVT, definitely the DVT prophylaxis should continue. Only it should be stopped 6 or 12 hours before the PPI placement. Then you can come out to low unfractionated heparin, which has a very short half-life. So you can stop it just before 12 hours of putting a PPI. And post PPI also, depending on the surgical intervention, how they have done it, we can again restart it. Definitely, it should be surrounded by a DVT prophylaxis, around PPI placement.
Thank you so much, sir. So thank you so much.
Thank you again.
Thank you.
Sir, shall we move on to the next topic, sir?
Yes, Sampath.
Sir, the next topic would be 10 tips to monitor respiratory mechanics, and it will be briefed by Dr. Jose Chaku, sir, a senior consultant from Narayana Health City, Bangalore. Over to you, sir.
Hi, everyone. I'm here to offer you 10 hot tips during monitoring of ventilation mechanics. Now, before we start, what does ventilation mechanics mean? It is just all about the basic measurements, including flow and pressure. And from these parameters, you get derived variables such as volumes, compliance, resistance, and so on. And what's the importance of monitoring all this during mechanical ventilation? That's what we're going to look at. And by the way, tidal volumes are not actually measured by the ventilator. They're actually calculated from the flows. So the basic measurements are few, and from that, you get several derived variables which come in very handy for you. So without further ado, let's go on to what are these important tips. That's in my opinion, of course. First tip is, it's important to measure airway pressures, as you all know. What pressures do you measure? The plateau and the peak pressures, of course. Why do you measure those? If you look at this pressure to time graphic, this is, of course, volume controlled ventilation, constant flow, and variable pressure. And you see a peak pressure, and then it settles down to a plateau level. Suppose your patient has a decrease in compliance, such as, say, severe ARDS, severe pulmonary edema, severe pneumonia. What happens to the pressures? This is, as I mentioned, is as applied to the volume control mode. You will see that loss of compliance results in an increase in both the peak and the plateau pressures. So just remember, poor compliance, the peak and the plateau pressures rise. Now let's consider the problem with just increased resistance without any change in the compliance. A lung that is well compliant, but there is some problem with resistance, such as, let us say, a blocked endotracheal tube. What do you get here? The pressure to time graphic is different. The peak pressures will rise if there is an increased resistance to flow, but if the compliance is normal, or the compliance does not rise, the plateau pressure will be the same. It will not rise. So to summarize, if it's a compliance problem, your peak and plateau pressures will rise. If there is a resistance problem, the peak pressures will rise, the plateau pressure will not rise. So this, of course, as I mentioned, applies to constant flow, volume control mode in the pressure to time graphic. Tip number 2, we mentioned about plateau and peak pressure, but even more important is something called the driving pressure, which I'm sure most of you are familiar with. Driving pressure is nothing but the plateau pressure minus PEEP. So why is it so important? We all know the ArtsNet study from more than 2 decades ago, which suggested that a tidal volume of 6 mils per kilogram may be the optimal tidal volume in most patients with ARDS. That is a very strong evidence-based recommendation. But you will ask the question as to why do you give a uniform tidal volume of 6 mils based on the body weight in a condition where the lung involvement may be highly variable? You would argue that the tidal volume should actually depend on how much lung is being ventilated, which is the baby lung, and how much lung is involved with the disease process, which is not receiving ventilation. So you might argue that the tidal volume that you choose may depend on the volume of the lung that is actually ventilated. And that's what delta P or driving pressure actually tries to get at. So driving pressure is just plateau pressure minus PEEP, and it is the tidal volume divided by compliance. Or in other words, it's a tidal volume titrated to the compliance of the lung, which you might argue makes more sense than the application of tidal volume based on body weight. At least that's what Amato and colleagues, way back in 2015, they looked at 9 randomized controlled trials, including more than 3,500 patients, and they came up with some very important findings. First of all, they found that if you keep your PEEP levels constant, but the driving pressures rise, even if the PEEP levels are constant, if the driving pressures rise, the mortality rises. So even with constant PEEP levels, higher driving pressures means higher mortality. Then let's look at another scenario. PEEP levels keep increasing, as in this case. But you see that the driving pressures are similar. So even if the PEEP levels rise, if you keep the driving pressures constant, the mortality does not rise. So that was a very important finding from this paper, and that's why we attach so much importance to driving pressure these days. The PEEP levels do not matter. Even the peak pressure levels may not matter, but the driving pressure is the pressure that decides on how many of your patients with ARDS are going to survive or not. So that's what this paper found. So it's a very important parameter to measure by the bedside, the delta P or the driving pressure, which is just PEEP plat minus PEEP. It's an easy enough measure. And you can measure plateau pressure with volume controlled ventilation by setting an inspiratory pause, which is possible in most ventilators. If you set an inspiratory pause of 0.2 seconds, at least 0.2 seconds, You get a continuous readout of the plateau pressure. Or if you're using pressure controlled mode, you'll have to use inspiratory hold to measure plateau pressure. But whatever method you adopt, if you just ask your bedside nurse to measure the driving pressure every hourly, you will do well for your patient. And you might well decide on if your patient lives or not. So driving pressure, how much is good? Although we don't have an absolute number to go by based on evidence at this point of time, a rough ballpark number is 15 centimeters of water. So keep the driving pressure 15 or less. The driving pressure, I would mention again, is just the plateau pressure minus PEEP, and you keep it below 15. Third tip, volume controlled ventilation, as I mentioned, can be useful in several different situations. Of course, most of us are used to pressure controlled or pressure regulated volume controlled modes. But then volume controlled mode does cause increased peak pressures, that's true, but the mean airway pressures are lower with volume controlled ventilation compared to pressure control. And there is a lot of information you can get even if you switch transiently to volume controlled mode with similar tidal volume, similar rate. And one of those things, one of those parameters that can help you is the stress index, which is based on the pressure to time graphic on volume controlled ventilation. Now, if you see something like this, a uniform slope of the pressure to time graphic, that is pretty much normal. But if you see something like this, a curve that is concave upwards with a spike, it means your lung may be over-distended. You may need to cut back on the tidal volume and the pressures. And third, if you see a gradual rise, and then if you see the pressure curve plateauing out, this means there is probably tidal recruitment, and you may be able to recruit the lung better, perhaps by increasing the PEEP levels. So that is the stress index. Here you call the stress index is 1, which is normal. This is a stress index of more than 1. This is less than 1. If you see this, it means too much distension. If you see this slow rise and plateau, it means tidal recruitment is happening. Look at the loops. What are the loops? The flow volume and the pressure volume loops. That's the pressure to volume loop. That's the flow to volume, inspiratory flow, expiratory flow. That's the inspiratory pressure, and that's the expiratory pressure. So what exactly do you look for in the pressure to volume loop? This is the normal pressure to volume loop. As I mentioned, this is the inspiratory curve, that's the expiratory curve. And the gap between these two is called the hysteresis, as you see here. Now, if you see this peculiar peaking of the pressure to volume loop on your graphic, it means that you are using too much pressure, or there is over-distension of the lung, which is causing this peaking effect, like a hungry bird looking for its prey. That's the peaking or beaking effect, which means that you're using too much pressure and you may need to cut back. Tip number 5 is to look for asynchronies, patient-ventilator asynchrony. There are several types of asynchronies, and there are several studies which have shown it's fairly common to get asynchronies of various types, and it happens in more than 50% of mechanically ventilated patients. We all know the asynchrony, which is very common, of failure to trigger. The patient tries to draw in a breath, but the ventilator does not support, particularly in COPD patients with auto-PEEP. But there are 2 other asynchronies that you should be aware of. The first is called double trigger. In double trigger, you see two consecutive breaths, one after the other. And this happens because the set inspiratory time is lower than the patient inspiratory time. In other words, the patient goes on inspiring, but the ventilator has come to the end of its inspiratory phase. But because the patient goes on inspiring, it is recognized as another breath, and the ventilator triggers a second breath, and that is double triggering. A similar kind of picture is the pressure to time, the flow to time graphic, or the pressure to time graphic will look very similar, but it happens in patients who are deeply sedated. And sometimes some case reports suggest that even in brain dead patients. It's called reverse triggering, in which an inspiration is immediately followed by another inspiration because of diaphragmatic stimulation. The first inspiration stimulates the diaphragm muscle, and then it results in a second inspiratory effort, and you get two inspirations one after the other. So that's the reverse triggering. So you need to be aware of these triggers, and it may be appropriate to paralyze patients, particularly with ARDS. The problem is if you keep on double triggering, it is double the mechanical load on the patient. And you're actually doubling the rate and doubling the mechanical strain of breathing, and that can harm the lung. So look out for asynchrony, particularly double triggering and reverse triggering. Another very important thing to monitor is the auto-PEEP. We always see in COPD patients, many of them have a prolonged expiratory phase and they cannot empty the lung completely. It leads to air trapping within the lung and the generation of positive pressure much more than the PEEP that you set. And how do you identify this? First, from the flow to time graphic, this is of course volume control constant flow. You can see very clearly that the expiratory phase does not touch the baseline, and that means there is auto-PEEP in this case. And the second important loop to look at is the flow to volume loop. This is normal, the normal inspiratory phase and the normal expiratory phase. But if there is auto-PEEP, you see slowing as well as you see that the expiratory curve does not touch the baseline. There is a gap between the baseline and the expiratory flow. And you can see that expiratory flow is also lower than compared to this. So if you see lower expiratory flow and the flow failing to return to baseline, that again means your patient is generating auto-PEEP. Tip number 7, very important, is to look at whether your patient's lungs are recruitable. We are all after titration of PEEP, increasing the PEEP level, get the alveoli to open up, the so-called open lung ventilation. But then the question is how much PEEP is right? There are patients in whom the alveoli may be recruitable, and there are some who have rock-hard alveoli in whom you cannot recruit whatever the level of PEEP you may apply. And in that case, it is very important to recognize as to how much recruitability exists in your patient's lung and titrate the PEEP accordingly. And one of the tricks is to use ultrasound by the bedside. This patient came to us several weeks ago. He had severe traumatic brain injury, went on to develop ARDS, and his lungs at its worst looked like this. That's of course with a PEEP of 5. You see it is a very densely consolidated lung with air bronchograms and a tissue-like appearance. So what did we do? We increased the PEEP to 10. And you can see towards the dependent lung, you can see more air coming through. The air bronchograms are becoming more prominent. White streakish lines are becoming more prominent. That is actually a good sign. It means there is more aeration. We stepped up the PEEP to 15, and you can see that apart from a little bit of lung here, which is still hepatized, most of the lung is recruited. And finally, at a level of 20 of PEEP, almost the whole lung has recruited. You can see B lines. They're almost discrete here. So that means recruitment has worked in this case. So very important tool, ultrasonography. But there are problems with ultrasonography. Although you can see with your own eyes if the lung is actually getting recruited, it does not tell you if you are overinflating the normal lung, which is not good at all. So is there a better method to look at whether your lung is getting overinflated? There is indeed a method that you can use, which is based on the recruitment inflation ratio, which has been studied by Laurent Brochard and his team at Toronto. It's a very useful technique that I would recommend strongly. We've been using it in our practice as well. You need to set a low level and a high level of PEEP. So in your patient, suppose your patient is severely hypoxic with a PF ratio of less than 150 or so, you set the high PEEP to 15. Of course, assuming that your patient is hemodynamically stable and you feel that it's appropriate to raise the PEEP to this level otherwise. So set the PEEP to 15, wait for 20 minutes, record the set tidal volume and the expired tidal volume at this level of PEEP, which is 15 centimeters of water. So after 20 minutes, you drop the PEEP down to 5 centimeters of water. Sorry, it's not 15, it's 5. So 15 for 20 minutes, drop the PEEP to 5. And as you drop the PEEP from 15 to 5, you get a huge tidal volume, which is actually called the drop volume. It is the volume of the recruited lung between 5 and 15 of PEEP. So you record this volume, which is the drop volume. Suppose you've set a tidal volume of 400, you might get a drop volume in excess of 750 or so. So you record that, and you record the PEEP plat at the low PEEP level. So what have you? You set the PEEP at 15, record the set tidal volume and expired tidal volume at 15, wait for 20 minutes, drop the PEEP to 5, and then record the drop volume, which will be a very high tidal volume, and the PEEP plat at the lower level of PEEP. And then you simply put this onto an online calculator. This again is by the Laurent Brochard team. And you straight away get what is called this recruitment to inflation ratio. And the recruitment inflation ratio, if it is more than 0.5, that suggests that your lung is recruitable and there is no over distension. If the recruitment to inflation ratio is less than 0.5, it means there is over distension and the lung may not be recruitable. So you can use a combination of ultrasonography and the recruitment to inflation ratio and decide on the level of PEEP. Ultrasound tells you if the lung is recruitable, and the recruitment to inflation ratio will tell you if the lung is getting over-distended. So combination of these two. If you see the lungs getting recruited with a recruitment inflation ratio of more than 0.5, then go for it. Increase the PEEP levels. The last tip is, we are all familiar with the PRVC mode. A lot of us believe firmly that it is the go-to mode under all circumstances. It is a kind of set it and forget it kind of mode. But then, is there a problem with it? In fact, PRVC is an adaptive mode of ventilator support, wherein the machine, we set the tidal volume. It is actually based on decelerating flow, like in pressure control ventilation, but you set the tidal volume, and the machine goes by the tidal volume generated and adapts the pressure based on the tidal volume. Suppose the tidal volume is, say, you set the tidal volume of 500. And if the volume that the machine senses is only 300, it will increase the pressure appropriately. The tidal volume is 500, it will sense that and reduce the pressure appropriately. So that may sound like it is very appropriate to do. And that's something that you would perhaps think is appropriate to leave it to the machine to decide what is the best pressure. But then there is a problem in patients who are spontaneously breathing. The problem in patients who are spontaneously breathing is that their spontaneous efforts may be very forceful. Like you may have a gasping patient who may be struggling to breathe, but the tidal volumes are high. They may draw in huge tidal volumes, but at the same time, they may be struggling with full use of accessory muscle. So what does PRVC do in that situation? So that's the patient who is breathing large tidal volumes with accessory muscle use in obvious discomfort. But PRVC senses high tidal volumes, and what does it do? It cuts back on the pressures. It cuts back on the support. So in other words, what it really does is it senses these vigorous spontaneous efforts and reduces the level of support, which is exactly what you do not want in this situation. You would want to support these patients at a higher level. So beware of this problem. PRVC in spontaneously breathing patients may not be the appropriate mode, because the harder you breathe, the more you struggle, the less support it delivers. So just to summarize, there are several important parameters to monitor in ventilation mechanics. Driving pressures are extremely important, particularly with low tidal volume ventilation. Keep the driving pressures 15 or lower. Look at the stress index on the pressure to time graphic if you're using volume control mode. You might even switch to volume control just to look at the stress index. If the stress index suggests tidal recruitment, you might increase the beat. And if you have a concave upwards wave, it suggests that there is overdistension. Look at the loops. The main indication for following the loops is to look at expiratory obstruction and also to look at overdistension of the lung, wherein you get the beaked appearance. Look for asynchronies. Asynchronies are associated with poor outcomes, especially failure to trigger, auto trigger, and double trigger. Recruitability is best assessed with ultrasound, but ultrasonography may not tell you if your patient is getting over-distended, and that's where the recruitment to inflation ratio would help. A ratio of less than 5 means you're inflating too much. More than 5 means there is room for more recruitment. And finally, beware of PRVC in spontaneously breathing patients, because it just may not deliver enough support. Thank you. Thanks very much for listening.
Thank you, Dr. Jose Chacko, sir. There is a question for you from Dr. Satyamurthy. The question is, when a patient is paralyzed, I see that the peak airway pressures and the plateau pressure rises as compared to when patient was on assisted breath. Can you just explain this and how to interpret it?
Yeah, we very often find this phenomenon. It entirely depends on how vigorous the spontaneous efforts are. You may have a patient who's gasping for breath, absolutely struggling. And in spite of the struggle, they may draw in large spontaneous tidal volumes. This is exactly the problem that you describe in what's known as self-inflicted lung injury, wherein you draw in huge tidal volumes, and that actually causes injury to the lung. So in this situation, obviously, if you paralyze them, ventilate them, you won't get as much tidal volume, which is actually the way to go, because you don't really need that kind of tidal volume. Because remember, spontaneous tidal volumes are as bad as tidal volumes delivered mechanically. So the injury related to spontaneous tidal volume generation in patients who are struggling, gasping for breath is equally bad. And that's why you would do well to cut their breathing efforts using muscle paralysis or deep sedation and take over the ventilation.
Thank you so much, sir. With this, we'll move on to the next session, neurocritical care by Dr. Swagata Tripathi, madam. She's an additional professor in the ICU in for AIMS Bhubaneswar. Over to you, madam.
A very good day to all of you. It is indeed a privilege and a pleasure to be a part of this conference, and I thank Dr. Srinivas and the entire team for giving me an opportunity to speak about the sonographic assessment of cerebral hemodynamics. I am a neuroanesthetist and a neurointensivist, and this area is of special interest to me. Being a general critical care physician, as all of you understand, the sonography in critical care has had a boom in the recent years. From the ultrasound of the chest, the lungs, the heart, and the abdomen, we have been moving towards the brain in the recent years. Therefore, we will be looking at how ultrasound in the form of transcranial Doppler is used to assess the hemodynamics within the brain and how, if time permits, this can allow clinical management of the patients. The application of transcranial Doppler is huge in the ICU. So the routine basic Doppler is different from the transcranial Doppler in that the phased array transducer is a 2 megahertz transducer to allow for deeper penetration, and you can use a B mode and the color Doppler together so that you can visualize the blood flow in the vessels as well as the architecture and the structure of the arteries together at the same time. So this transcranial Doppler is used to look at patients with traumatic brain injury, assessing non-invasive ICP and estimating the cerebral perfusion pressure, in assessing for autoregulation or loss of autoregulation in injured tissues, to look at the compliance and the cerebrovascular dynamics, and to predict outcomes in these patients. It is cranial Doppler, especially made so that it can penetrate thick skull bone. On top of that, we use special areas of the brain, the skull, where the bone is thinner to allow for better insonation. These areas are known as the acoustic windows, and there are the 3 commonly used acoustic windows, which can be the transtemporal window, the transorbital window, or the transforaminal window. We most commonly use the transtemporal window because the anterior circulation, the MCA, the ACA, and parts of the ICA are visualized over here. The ophthalmic arteries are best seen through the transorbital window, and the transforaminal window helps us to look through the foramen magnum into the intracranial parts of the vertebral artery and the basilar arteries. Where we are putting the probe and the depth at which we are insonating a vessel, the velocity of the blood flow in the vessel, and whether the spectral waveform is above or below the baseline will tell us which vessel we are insonating. So once we have put the Doppler probe and gotten a spectral waveform, the initial step of interpretation is to check if all the insulated vascular segments have been correctly identified and labeled. Like I said, the flow signals that are directed towards the probe will look above the baseline. That would be the MCA, the PCA-P1, and those that are directed away from the probe will be the ACA, the vertebral, and the basilar arteries. So once we have identified the vessels, the second step would be to analyze the components of the cardiac cycle of the Doppler waveform and look at when the systole initiates, the shape of the waveform after the systole has initiated, the magnitude or the peak systolic velocity, the dicrotic notch, and the end diastolic velocity. The spectral analysis parameters will give us calculated variables of the pulsatility index, and the spectral pattern will give us more information. The shape of the waveform, for example, a systolic acceleration, the delayed systolic acceleration, or a post-stenotic waveform will indicate a significantly decreased and slow flow to the insonated vascular segments due to a proximal vascular stenosis or due to an occlusion, which is compromising the fusion. Methods that inform us about the cerebral hemodynamics that are derived from transcranial Doppler is the flow velocity. The spectral waveform that is derived from the transcranial Doppler has three components: the peak systolic velocity, the mean flow velocity, and the end diastolic velocity. The systolic velocity is predominantly dependent on the cardiac output and does not have much to do with the cerebral hemodynamics. The end diastolic velocity, however, has been found in various research to be associated to a greater extent with cerebral hemodynamics, and there is a greater fall in diastolic flow velocity when there is a reduction in CPP due to rising ICP. So these flow velocities are commonly measured modalities in clinical and experimental environments, and there has been a lot of attempt to investigate the relationship between cerebral blood flow and CSF dynamics, and several mathematical and dynamic models have been derived from flow velocity, blood pressure, intracranial pressure, and other inputs, which are easily derived from transcranial Doppler. After the flow velocity, the other basic direct derivative from flow velocity that we can get from transcranial Doppler, and that has been studied the maximum, is the Gosling's pulsatility index. This provides information about the downstream cerebral vascular resistance. It describes the qualitative and the quantitative changes in the morphology of the waveform that is derived from the transcranial Doppler, which results from cerebral perfusion pressure changes. Pulsatility index is basically the relationship between the difference of the systolic flow velocity and the diastolic flow velocity and divided by the mean flow velocity. In normal conditions, it ranges between 0.5 to 1.9. It may increase in certain conditions to more than 1.9, especially when there is a distal occlusion or constriction. A proximal stenosis or occlusion will decrease the pulsatility index to below 0.5 due to the downstream arteriolar vasodilation. Large studies have recently reported normative values of TCD, which are a little different. And there has been a call that different laboratories which are using neurosonology should build their own indices for the normative values of PI. Because the pulsatility index is a ratio, it is not affected so much by the angle of insonation and also by inter-observer variations. So after looking at the basic methods, in the next 4 to 5 minutes, we'll quickly go through what are the advanced methods that are provided to us by the transcranial Doppler, with which we can interrogate the cerebrovascular changes better non-invasively. We must remember that many of them are still experimental and under research, but it's good to know what's happening out there. The transcranial Doppler can non-invasively estimate the cerebral arterial blood volume inside the brain, and from that we can derive relative changes in the compliance of the arterial compartment of the brain and that of the CSF compartment. This has been most widely studied in patients with traumatic brain injury. We know that the origin of the plateau waves that we see in the ICP traces during increased ICP is because of intrinsic cerebral vasodilation, which there is a rise in cerebral blood volume and parallel rise in ICP. So this forms the vasodilatory cascade hypothesis, and these changes are associated with a rapid rise in the compliance of the arterial bed due to the vasodilation of the cerebral resistance vessels during this plateau wave and the reduction of the compliance of the cerebrospinal compartment because of the increased cerebral blood volume. These have been checked and proven experimentally by using transcranial Doppler, thereby leading to the belief that it can be used to predict changes or correlations between the compliance of the arterial and the CSF compartments. The tau, or the cerebrovascular time constant, is another non-invasive TCD-based index. It is defined as the time to establish a change in the cerebral blood volume after there occurs a sudden change in the arterial blood volume in one cardiac cycle. Of course, it is a time unit, so it is measured in seconds and derived by multiplying the compliance of the arterial bed with the cerebrovascular resistance. It has been seen in normal human beings to be inversely related to changes in arterial blood pressure, changes in cerebral perfusion pressure, and in the levels of end-tidal carbon dioxide. Abnormally, usually tau shortens. In a recent study, it has been shown that patients with traumatic brain injury have shortened tau indices, but as the severity of the TBI increases, the tau significantly shortens even more. Similar for patients with carotid artery stenosis. In these patients, the tau is shorter, and how much short it is correlates with the degree of stenosis. In subarachnoid hemorrhage, it has been seen that if you're measuring tau, you can pick up a shortened tau much faster before the clinical or TCD indices, the basic indices that we spoke about, will indicate vasoconstriction in subarachnoid hemorrhage patients. Critical closing pressure and wall tension are new advanced methods again. It is defined as, we're talking about the critical closing pressure, as a threshold of the arterial blood pressure below which the brain microvasculature collapses and the cerebral blood flow ceases. So we can think of it as the ICP plus the wall tension wants to collapse the cerebral microvasculature, and it's only the blood pressure that's holding it open. So with the TCD, the critical closing pressure can be assessed non-invasively by comparing the pulsatile waveforms of the cerebral blood flow velocities and the arterial blood pressures, and other indices that are even more predictive of hypocirculation to the brain can be obtained from the critical closing pressure. It has been seen that a diastolic blood pressure below the critical closing pressure is associated with loss of measurable blood flow and brain ischemia. Autoregulation has been studied extensively with TCD because it is something that allows individualistic patient management in the ICU. TCD calculates the mean flow index that correlates the mean flow velocity and the CPP. If this correlation is negative, it means that the autoregulation is preserved. A positive correlation means that autoregulation is impaired. It has been strongly associated with mortality at 6 months in TBI patients, indicating this autoregulation. The SX index, which correlates the peak systolic velocities with the CPP, has been recently found to have stronger association with outcome than the mean flow indices. One must remember, however, that the TCD interrogates the MCA territory better than the posterior circulation, and perhaps autoregulatory changes in the posterior part of the brain where the injury is there may not be best detected by transcranial Doppler. Also, again, the transcranial Doppler measures the flow velocities as a surrogate to blood flows. So it is only when the true vessel cross-sectional area is remaining constant that we can have a close association and replace one for the other. So these are pitfalls of using transcranial Doppler. It has been used widely to interrogate non-invasive intracranial pressure. However, research has shown that there is a lot of variability and wide confidence intervals when we measure number of non-invasive ICP and are correlating it to the invasive ICP. We know that ICP is correlated to PI, but it is not specific to raised ICP. Perhaps this is the reason why it has failed to assess non-invasive ICP numbers. However, despite this limitation, research shows that TCD-based changes in the trends of non-invasive ICP can still be predictive of what is happening inside the brain and allow the tracking of the non-invasive ICP changes in real time in different settings where there may actually be contraindications to doing invasive ICP measurement. Well, time is short, but I would just like to remind you that over the last 12 to 13 minutes, we have spoken about how transcranial Doppler and the derived indices have helped us to look at various clinical indications to detect, to treat, and to prognosticate conditions where there are cerebral vasospasm, dysregulated cerebral auto-regulation in patients with ischemic stroke or in TBI patients. Always to remember, it is work in progress. Normative values and clinical cutoffs are still to be finalized and written in stone. With that, I come to an end of this talk. These are the main references that I have looked at and some of the exciting societies. No conflict of interest here, which I found on the net, which anyone interested can look at in greater detail. Thank you so much. Have a great day.
Thank you so much, madam. That was a great lecture. Next, we would move on to mechanical ventilation in brain injury.
Sampath, there is a question about using SIMV, PRVC in a spontaneous injury patient.
Yes, sir. Shall we go ahead with the questions now or after the
No, just we'll answer that question because of the George is not online. So, SIMV as a pure mode without an assist support or without any backup ventilation is no longer recommended. A pure SIMV mode is more or less given up for intensive care patients. You may still use it in elective post-operative patients, but for intensive care patients, whether you use an SIMV with pressure support or volume control is a matter of choice. It does not confer any advantage over the other support modes of ventilation. But using a PRVC as a backup means that you still are worried about pressures, you still are worried about the tidal volumes. So it's better not to use an SIMV PRVC because the clinical condition of the patient seems to warrant a more controlled mode of ventilation. So such patients may actually be either on a pressure control or a volume control or a PRVC, not on a SIMV mode. We'll go ahead.
Thank you, sir. Next topic. Hello.
Audible, sir.
Next topic would be mechanical ventilation in brain injury. And to talk about it, we have Dr. Deepa Devaprasad, sir, who is a consultant and head critical care department, Apollo Hospitals, Chennai. Over to you, sir.
To one and all, and thanks once again to HICS for inviting me to talk in this very important scientific session for critical care. I'm going to talk to you about mechanical ventilation in brain injury, and I have 15 minutes to do the same. I'm going to divide my talk into situations in which we mechanically ventilate our patients, which would be neuromedical patients and neurosurgical patients. Among neuromedical patients, we ventilate patients who have stroke. It could be hemorrhagic or ischemic. Patients who are in status epilepticus or refractory status epilepticus and therefore need mechanical ventilation. Patients who are post-cardiac arrest survivors who possibly have hypoxic ischemic encephalopathy and therefore need ventilation. And I also talk about neurosurgical patients who could have TBI, either isolated TBI or TBI as a part of polytrauma, aneurysmal subarachnoid hemorrhage and tumors. This roughly completes the gamut of patients with brain injury who will receive mechanical ventilation. And I would want to stress the fact that data about what parameters to target are available among neuromedical patients for patients who have hypoxemic ischemic encephalopathy. And among surgical patients, we have data for traumatic brain injury. And we will use this data to extrapolate it to the rest of the patients under the neuromedical or the neurosurgical section. And I think that would be a reasonable approximation. Let me start in the form of an MCQ. And I hope all of you would keep answering as I pose these questions to you. And I'm going to talk about neuromedical patients, post-cardiac arrest patients first. Now, if I were to ask you what would be your preferred oxygen concentration for post-cardiac arrest patients, would it be an FiO2 of 100% for 4 hours, it would be 60% FiO2 for the entire duration of mechanical ventilation, or whatever FiO2 to target a saturation of 94% on pulse oximeter, or none of the above, or any of the above. I'm sure most of you would answer that the correct answer would be an FiO2 that is titrated to get a saturation of 94% on the peripheral pulse oximeter. Staying on post cardiac arrest, if I ask you what would be your preferred PCO2 target for post cardiac arrest patients, is it between 25 to 30, 30 to 35, 35 to 40, or 40 to 45? Most of you would answer either 35 to 40 or 40 to 45. Let me put this very clear to you. For all patients who are mechanically ventilated with brain injury, our targets would be PCO2 in the normal range, which will be 35 to 45. The lower range of normal, 35 to 40, is preferred for most patients, except for patients with post-cardiac arrest, where the higher limit of normal, 40 to 45, is the recommended PCO2 target. And this is as per the AHA guidelines, not based on great evidence, but this is the guidelines that the AHA wants us to maintain. So for most patients, it is 35 to 40. And for patients in post-cardiac arrest, the target would be 40 to 45. Now, if I want to maintain good oxygen and a reasonable carbon dioxide, I would need to increase PEEP, and I need to increase my mechanical ventilation minute volume. And all of these would affect either directly or indirectly, because these patients need adjuncts to mechanical ventilation. We would need to sedate these patients, and these would indirectly affect the hemodynamics of the patient. So what are the hemodynamic targets that we use for these patients? Will the target be a CPP? Will it be an ICP or MAP? We all know that we are all bothered about the cerebral perfusion pressure, because that's what is determinant of the oxygenation of the brain tissue. And that is usually expected to be between 50 to 60. And we get this data from patients who are being treated for traumatic brain injury. So that is the model from which this particular data is being extrapolated. So 50 to 60 millimeters of CPP. But we don't actually measure CPP directly. We in fact get a measure of CPP indirectly from the MAP and the ICP. But that also brings a peculiar problem. We don't use ICP monitors for all our patients. In fact, the recommendation to use ICP is only for a particular subset of patients with traumatic brain injury. But for the vast majority of neuromedical or neurosurgical patients, there's no definite recommendation to always use ICP monitors, which means we are mostly left to maintain an adequate MAP and presume that by maintaining an adequate MAP, we'll be able to maintain a CPP. Clearly, low MAPs are being associated with poor outcomes, and higher MAPs have been associated with better outcomes. And we always want to keep the MAP so that the CPP will be somewhere between 50 to 60, which means it will be 80. 80 MAP is a reasonable MAP that we want to maintain in patients with cerebral injury. And remember that this MAP can drop if I'm going to increase my PEEP too much, if I'm going to increase my minute volume too much, and or if I'm going to use sedation too much, and therefore this also needs to be paid attention to. Coming back to our oxygenation targets in post-cardiac arrest, we did mention to you that in post-cardiac arrest, the AHA recommends that you target a saturation of 94% or higher based on the pulse oximeter. But we need to understand that in patients who receive cooling, even 35 to 36, which is what is probably now used in the vast majority of patients, you may have a peripheral inability to pick up the saturation. In these patients, you would use an ABG and look at the PaO2 and roughly keep the PaO2 at 60 millimeters of mercury. But I would like to stress the fact that most of trainees, or sometimes in some units, there is this tendency to use high FiO2s, which is reasonable only when the CPR is ongoing and has to be avoided at all points later on in the care of patients with post-cardiac arrest, because we know that high FiO2s affect neuronal apoptosis and thereby increases mortality. And on the contrary, low FiO2s are very beneficial because they improve neurological outcome. And these studies that were initially done in rabbits and mice model have also been done in humans, where small studies have shown increased mortality with high FiO2s. If I were to tell you that 30% FiO2 is very safe compared to 100% FiO2, you'll not be surprised. But some of you may be surprised when I tell you that there have been studies which have shown that 63% of FiO2 has increased mortality compared with 45% FiO2. Just 63% versus 45%. If you're going to decrease it from this to this, you find that you're going to drop the mortality. And therefore, I would stress the point that in post-cardiac arrest patients, come to the lowest FiO2 possible to maintain this saturation, which is 94% or higher. And there are only two factors by which I can keep this particular saturation. And this is by keeping an FiO2 adjustment, which I want to keep it to the lowest possible. And the other is by keeping a reasonable PEEP. So if I want to keep the lowest FiO2, probably have to keep a reasonably high PEEP, maybe 5 or 8. And there's always this controversy of what PEEP I should use in patients who are brain injured. And this is because we all have this theoretical knowledge that PEEP increases intrathoracic pressure, and as a consequence, it impairs central venous return, and this leads to increased ICP. And CPP and CBF, which is cerebral blood flow, may be impaired by PEEP because it decreases the MAP even without an alteration of ICP. And I would explain this better in a slide that I have subsequently. So PEEP can increase ICP, and PEEP can impair cerebral blood flow by dropping the MAP. And therefore, there's always this tendency of not using adequate PEEP, especially in the neurosurgical ICU, especially among neurosurgeons, especially in patients with TBI, where they say that I don't want PEEP, I want ZEEP, I want low PEEP, I want PEEP of 0, ZEEP, I want a PEEP of 3 because I don't want to raise the ICP. At this point, let us stress that a PEEP of 5 to 8 will be inconsequential in raising the ICP. It will not impair the cerebral blood flow because it will not have high consequences of decreasing the MAP. However, if you're going to use very high PEEPs, maybe 12, 15, there may be an effect on decreasing the MAP and increasing ICP and therefore reducing the CBF. And therefore, when you're using high PEEPs, it may be reasonable to have an ICP monitor. However, I'm not recommending that if you're using higher PEEPs, use an ICP monitor. I'm just saying that if you have an ICP monitor in place, then if you are having a problem of titration of PEEP, probably titrate the PEEP and also fine-tune the ICP and see whether there's any correlation with the PEEP and the ICP. At this point, I'll have to tell you that at this point of time, there is no evidence to using 0 PEEP or low PEEPs. PEEPs of 5 to 8 is adequate among the vast majority or all our patients who are being treated in the neuromedical or the neurosurgical ICU. And we have one more important reason of why to use an adequate PEEP. We now know the concept of driving pressure and how driving pressure increases hospital mortality in patients, be it ARDS patients or be it non-ARDS patients. We know that with increased driving pressure, you have increased mortality. If you're looking at a driving pressure of say 15, this is a mortality. But if your driving pressure is 25, the mortality is increased, both in ARDS and non-ARDS patients. And what is the driving pressure? Driving pressure is nothing but the pressure difference between the plateau pressure and the PEEP. If I were to decrease my PEEP and make it 0 PEEP, clearly I'll be increasing my driving pressure, which means I'll be clearly contributing to an increased hospital mortality. So that's one more reason why we should not be ventilating our patients with less than adequate PEEP. Definitely no ZEEP, no low PEEPs. 5 to 8 should be adequate in most patients. remembering that if we are increasing PEEPs to very high levels, they may have an effect on ICP and cerebral blood flow. And at that point of time, it may be reasonable to monitor these parameters while increasing your PEEPs. We did talk about ventilation, and I put this slide just to explain the concept of hyperventilation in patients with post-cardiac arrest. So what do we do by hyperventilation? By hyperventilation, we increase our tidal volume and respiratory rate to increase our minute ventilation, and that causes driving out of carbon dioxide, which causes hypocapnia. And when you have hypocapnia, you do have your decrease in your intracranial pressure. And how is this decrease in intracranial pressure obtained? That is obtained because you do have a decrease in the cerebral blood flow. And this contributes to the decrease in the ICP. And as a consequence of this decreased cerebral blood flow, you will have global and regional ischemia. In patients who are hyperventilated, by increasing the minute volume, you will definitely have, with higher minute volumes, you will definitely have higher pressure. So increased intracerebral pressure is definitely a consequence of hyperventilation. And this may theoretically reduce the coronary perfusion pressure, reduce the cardiac output, and reduce the MAP. And that's how it can reduce the CPP independent of the ICP. This is what we did talk about in the PEEP as well. So as a consequence of hyperventilation, you may have a decrease in the CPP, and you may have a decrease in the ICP as well. But this decrease in ICP is because of a reduction in cerebral blood flow causing regional ischemia, which may not be all the time beneficial. On the contrary, if I were to hypoventilate the patient, I would obviously cause hypercapnia and acidosis as a resultant of the acute respiratory acidosis from hypercapnia. And if I'm going to hypoventilate patients long enough, I may also cause some degree of hypoxemia, which is also bad. And therefore, AHA recommends that in post-cardiac arrest, we ventilate to keep a PCO2 of 40 to 45%. And I did tell you that in all other situations, we ventilate to get a PCO2 of 35 to 40. So just a diagrammatic representation to say that if I have hypercapnia, we find that there is a increase in the cerebral blood flow. And if I have hypocapnia, which is what we do if we hyperventilate the patient, you may actually decrease your ICP, but it also decreases your cerebral blood flow, and this causes ischemia. And therefore, clearly, I don't want to hyperventilate the patient and cause hypocapnia. And this will be a very, very striking image if you are going to look at it. This is an image which shows the consequence of hyperventilation in patients with TBI. If you're going to look at this post-impact, we find that in patients who are hyperventilated in TBI 6 hours post-impact, if you're going to hyperventilate them for a PCO2 of 25%, 25 millimeters of mercury, you find that the cerebral blood flow is reduced to less than 20. All the areas given by red shows a cerebral blood flow of less than 20. And if you're going to ventilate them to normal PCOs of 38, you find only some regions have reduced cerebral blood flow of less than 20. Clearly, I don't want this, so definitely I'm not going to hyperventilate this particular patient. So hyperventilation is only a temporary rescue measures until other methods of reducing ICP are on board. So we did talk about all the evidence on hypoxemic ischemic encephalopathy. Let's just talk about the evidence on TBI. Clearly, in TBI, hypoxemia correlates to mortality because it causes permanent damage and leads to high morbidity. Then what is the optimum saturation goal? In patients with post-cardiac arrest, the saturation goal was SpO2 of 94%, and that's the AHA guideline. And according to the BTF, British Trauma Foundation guidelines, the optimum saturation goal in patients with TBI is 90% SpO2. 90% SpO2 is the target goal. So adjust your FiO2 so that you at least have 90% SpO2 on your peripheral pulse oximeter. Obviously, talking about hyperventilation, we did tell you that it's only in the context of a rescue measure. Otherwise, no hyperventilation, and you will ventilate patients to have a target of 35 to 40. And we did tell you that there is no benefit. In fact, there is harm when you use low PEEPs and ZEEP, and therefore use therapeutic PEEPs. 5 to 8 centimeters should suffice. Talking about TBI, we need to understand that you need to do sedation vacations appropriately and stop neuroparalytic agents appropriately. Otherwise, you're going to have high extubation failure rates in patients with TBI, which is up to 40%. And there's no evidence that tracheostomy early on helps. And I'm not going to talk about it because this is an entire talk on itself. So I can't end before talking about this dangerous crosstalk between brain and the lung. When you have thoracic trauma and brain injury, you find that the patient who has thoracic trauma and TBI, the brain is injured and the lung is injured. Patients with aneurysmal subarachnoid hemorrhage, you know they have neurogenic edema or pulmonary edema of the lung. And obviously, patients who are ventilated and sedated for a long period of time develop pneumonia and atelectasis. Patients who are under barbiturates or hypothermia as a rescue for ICP, as a protective measure for brain injury, will have some complications of the same in their lung. Hyperolemia and hypertension, which used to be a treatment for aneurysmal subarachnoid hemorrhages, will increase the lung water, and neuromuscular blockade will increase weaning failures. Let's also look at how brain injury causes lung injury. And these are studies which shows patients who do not have brain injury who develop ARDS and patients who have brain injury who develop ARDS. Clearly, when you have brain injury, you have more extravascular lung water. So if you have brain injury, you become sicker with respect to your lungs because you have extravascular lung water that is increased. So brain injury causes more lung injury. Likewise, lung injury causes more brain injury. And this is a study which shows that if you look at the marker of neuron-specific enolase, which is a marker of brain injury, among controls, patients with ICH and patients with ARDS and patients with ARDS and ICH. Can you see patients with ICH? This is the neuron-specific enolase level. Patients with ARDS, neuron-specific enolase levels goes up. Patients with ARDS and ICH have the highest neuron-specific enolase levels. So clearly, if you have ICH, you also, or lung injury, you also have brain injury because it releases neuron-specific enolase. So there's a lot of organ crosstalk between the brain and the lung. If the brain is injured, it increases the extravascular lung water. If the lung is injured, it damages the brain, and you know it because there is increased serum neuron-specific enolase. So in conclusion, what will be my mechanical ventilation strategies in brain injury? Intubate the patients early to protect the airway and reduce the risk of deterioration, especially when surgery is planned early. The oxygen targets would be 94% in patients with post-cardiac arrest. In all other patients, it would be 90, and that is a recommendation that we get from the TBI guidelines. If you can't measure the peripheral saturation, go for the ABG and keep it around 60 PaO2. The carbon dioxide targets for post-cardiac arrest will be 40 to 45, and for TBI and the rest, it will be 35 to 40. So there is no role for hyperventilation except as a rescue measure. Tidal volumes will be 6 to 8 ml per kg. Keep an adequate PEEP 5 to 8 because of what I explained, especially the consequence of higher driving pressures if I decrease my PEEP and how it will have an adverse effect on mortality. We know that oxygen prevents hypoxemia, but more the oxygen is not better. PEEP cannot be ZEEP, and hyperventilation should be used only as a rescue therapy. We all use control mode and assist control modes of ventilation, but remember that spontaneous modes of ventilation as not a weaning mode, but as a ventilatory mode can also be used in patients in brain injury, provided they are not under too much of sedation, provided the GCS is reasonable enough and a minute ventilation is good enough that their PaCO2 and the PO2s are within the accepted normal levels that we've spoken of here. Thank you all for your patient hearing, and I have to acknowledge Dr. Gautam Kumar, who helped me with some of the images and the slides there. Thank you for your patient hearing, and thank you once again for the opportunity.
Thank you, Dr. Varaprasad, sir. The next topic would be fluid therapy in brain injury. And the speaker would be Dr. Pratima Ramachandran, madam, who is the coordinator, senior critical care consultant, Apollo Super Specialty Hospital, Chennai. Over to you, madam.
Good day, everyone. I am Dr. Pratima. I am a coordinator and senior consultant at Apollo Specialty Hospitals, OMR, Chennai. Thank you for having me on this day, and happy to join HICS 8 once more. Thank you so much. And my topic is fluid therapy in brain injury as a part of the next session in the neurocritical care. So what do we do with fluids? Why do we even give fluids? So first are always the basic concepts, blood-brain barrier. Why is blood-brain barrier very important? The brain is highly dependent on a continuous and regulated supply of oxygenated blood and a highly regulated continuum lined by the blood-brain barrier. So brain is very dependent on the blood-brain barrier, and it is a physical support, and it is a big metabolic wall which separates the contents of the blood vessels and the brain interstitium and the cells. So everything together, it forms a transport medium and a metabolic wall. So when it is intact, it is good. It is a specialized interface. It helps and acts as a solute exchange barrier between the circulating blood and the brain environment. It limits the entry of immune cells, pathogens, and toxins, and is permeable to oxygen, water, and small lipid-soluble molecules. I mean it when I say only oxygen, water, and small lipid molecules. Not everything can cross this barrier. So autoregulation, yes, it is very tightly controlled, and we all know that when there is a blood pressure change from 50 to 150, the cerebral perfusion pressure and the cerebral blood flow is maintained very, very tight, and it is all auto-regulated, and the cerebral perfusion pressure and the blood flow keeps going in a very regulated way. So what happens when there is a lot of issues, and what are the factors which affect the relation between fluid management and cerebral blood flow and oxygen? This is what our talk is about. This is all the session is about. When we administer fluid, it depends on the tonicity and volume, which indirectly has a huge impact on the blood-brain barrier, CSF circulation volume, inflammation, autoregulation, venous impedance, and in fact, the systemic circulation also. And all these things, if it is not done in a proper way, it might lead to cerebral edema, and in turn, it irritates the brain, and the cerebral blood flow and the oxygenation is tampered. So brain is happy if supported well. We all know that there is an intracranial pressure, cerebral blood flow, and oxygen delivery, which is equated to the metabolism. So brain is happy when it is supported. But what happens if it is injured? There is a variable degree of altered mental status. The patient presents in a clinical state in conjunction with very limited neurological exam. We really don't know what's happening when the brain is going into a big injury. And there is a primary insult which causes an inflammation, edema, and ischemia. And there will be a downstream injury which causes a secondary brain injury, and which is missed in almost all the unresponsive, sedated neurocritical care patients. So we need to be very, very cautious about what fluids we give and how we manage the fluid in a neurocritical care. When the brain gets hurt, there is a lot of things happening. There is excitotoxicity, there is mitochondrial dysfunction, edema, impaired oxygen diffusion, impaired autoregulation. In turn, the blood flow falls, and energy dysfunction, continuous inflammation, everything happens. And during the days, if it is not maintained well, in the first initial hours, there is a lot of neurodegeneration and very poor neurological outcome. When there is a dysfunction of a blood-brain barrier, there is a paracellular transport of restricted components and neutrophils. There is a lot of tight junction proteins which get lost. And there is transcytosis movement of large molecules. The molecules of like serum proteins increases across, the movement increases across the endothelial cell. Inflammatory response goes on, and there is an interstitial fluid is increased. So when the interstitial fluid is increased because of inflammatory response, it results in a vasogenic edema. And when there is more of activation of cellular membrane, ion channels, there is intercellular water accumulation, which is a cytotoxic edema, which increases the brain edema. So vasogenic edema occurs when there is an increase in interstitial fluid, and cytotoxic edema when there is an intracellular water accumulation. So everything causes alteration in the blood flow and oxygen delivery, and this will depend on the severity and the regions affected. So as I already mentioned, cytotoxic edema is the inflection of fluid inside the brain cells, and vasogenic when the fluid is more into the interstitial space. So when there is a lot of things happening in somebody's head, there is a big secondary injury going on. So we all know that there is a Monroe-Kelly doctrine, and we are working as per this in any part of the neurocritical care. This is what comes into the primary doctrine of management. So when it is in a normal state, yes, the brain is happy. And when there is ICP increase, slowly it starts compensating. And when there is a decompensation is when the problem starts. We know that it just goes on, and there is a decreasing compliance, and there is a collapse of the microvasculature. So MAP minus ICP, which is the arterial pressure, mean arterial pressure minus the intracranial pressure, marks the cerebral perfusion pressure. We all know that if there is too much of edema, as we can see in this picture, there is a constriction and there is very less flow to the brain, and the increased MAP, even if we increase it so much, and if the ICP goes up, the cerebral perfusion pressure is not adequate. So the intracranial pressure goes up, cerebral blood flow goes down, and the metabolism and oxygen delivery doesn't match each other, and there is a big issue going on in the brain and continuous damage happening. So these are the common scenarios we see in the neurocritical care. And these are the various fluids. We have a lot of fluids in our shelves in our ICU. So what do we use? What is the universal principle? We all know that the crystalloids, isotonic particularly, allow water to distribute equally over the time in the intravascular and interstitial space. Colloids support the plasma oncotic pressure, and it minimizes the extravasation of intravascular fluid into the interstitium. So if we want to expand the intravascular fluid volume effectively, we use colloids. And in some time when we give colloids, there is we can resuscitate with a smaller fluid volume. So there are a lot of types of fluids. We have isotonic, hypotonic, hypertonic, lot of tonics in our ICUs. So when do we use fluids in brain injury? Do we really have to use it? Yes, and we use it in 3 different times: when we want to resuscitate a patient, and as a maintenance fluid, and osmotherapy. So these are the 3 things which we have to concentrate and think about what drug or what fluid we are giving, and why are we giving, and what fluid is essential or helps with the brain outcomes or neurological outcomes. So resuscitation, what are our goals? We need to rapidly reverse the hypovolemia. We know that if we do not restore the intravascular volume, it is going to be deleterious to the patient. And we have to avoid the hypotension and maintain a good cerebral blood flow, limit the cerebral ischemia and the hypoxia. In turn, we have to avoid the intracranial hypertension. So we need to balance it properly. We need to reverse the hypovolemia, and we have to have a alert mind to avoid intracranial hypertension and prevention of unplanned complications. So which IV fluid are we going to give? As I already mentioned, optimizing this cardiac output and balancing between optimization of the cardiac output and minimizing the tissue edema is going to be difficult. And we know that because the brain is injured, the autoregulation is disrupted. And usually in resuscitation of trauma or any acute issue, crystalloids are the first line of use. And in evidence, as per evidence, we know that the close attention to cumulative fluid balance is very, very important in whatever injury to the brain. And particularly in the first 96 hours, we need to have a very close attention to the cumulative fluid balance. And with all these things in mind, we need to achieve a key perfusion target of a resuscitation is that the systolic blood flow blood pressure should be 90 and cerebral perfusion pressure should be maintained at 60. So about the resuscitation, what fluids do we use? And as per the SMART study, which just matched the balanced crystalloid versus the saline in critically ill adults, we did have a small traumatic brain injury group, subgroup, in which we saw that when all these groups pointed towards betterment use of balanced crystalloid, we can see that in particularly the traumatic brain injury group favors and better mortality, better outcome is when we give more saline. So we need to have a watch in traumatic brain injury. Not all patients critically ill are benefited by balanced crystalloids. And then albumin versus saline, what do we give? Do we really use albumin for resuscitation versus saline? What do we prefer? In the SAFE study, of course, when we saw in the small subgroup, when these patients were assigned to receive albumin and other group was assigned to receive saline, we can see in the survival curve that the probability of survival at 28 days and 24 months, we can see that there is more deaths or very bad outcomes in albumin. So albumin is a caution in traumatic brain injury, very evidently. So why would this happen? It might be an albumin leak across the damaged blood-brain barrier, and there will be greater net flux of fluid. It is just pulling the fluid into the intravascular from the intravascular to the interstitial space. And when this happens, the increased cerebral edema happens, and when cerebral edema increases, there is an intracranial hypertension and increased mortality. Then we go to the synthetic colloids. Okay, we saw the crystalloids, we saw albumin. What about the synthetic colloids? There is no specific study for traumatic brain injury or any brain injury as we consider systemic colloids. But in the CHEST study, which was done in 2012, we have seen a study which compared the HES, hydroxyethyl starch versus a saline, and we did see that there is an increased requirement of renal replacement therapy. The AKI was high and the mortality also was high in the group which used the HES 6%. So yes, that was for the resuscitation. What about the maintenance? Maintenance, we know that it depends on the volume status. So but how do we define hypovolemia? Hypovolemia is the intravascular volume that is insufficient to sustain minimally adequate cerebral perfusion and oxygenation. Yes, it was easy. Euvolemia, yes, we can say that when the cerebral perfusion is sustained in a very good way and in adequate with adequate brain oxygen, yes, it is euvolemia. But how do we define hypervolemia? Whatever is hypervolemia in the intravascular space or in rest of the body is not what is hypervolemia we mean in the brain injury. So it is less straightforward. So what do? We have various guidelines and various recommendations for SAH. When there is a subarachnoid hemorrhage, the guidelines say that maintenance of euvolemia and a normal circulating blood volume is recommended to prevent the delayed cerebral ischemia. Yes, and prophylactic hypervolemia before we do this angiographic spasms is not recommended. We do not give large volumes of hypotonic fluids, and isotonic crystalloid is the preferred agent of volume replacement and maintenance. This is for the SAH. And what about the acute ischemic stroke? Daily fluid maintenance of patients estimated is 30 ml per kg body weight. We do not overload them. We use isotonic fluids rather than hypotonic, and hypovolemia should be corrected with IV normal saline. So again, normal saline. So normal saline seems to be quite safe in all acute brain injury patients. Yes, that is with the resuscitation maintenance. Then we go into the osmotherapy. What is osmotherapy? We infuse a hyperosmolar fluid with an intention of producing an osmolar gap. And this helps in transferring the brain parenchymal fluid into the vessels. So brain cells are literally dehydrated, and whatever fluid is moved or transferred into the intravascular is excreted in the urine. So this is how we give the osmotherapy, and this reduces the blood viscosity, which improves rheology, resulting in constriction of the pile arterioles. So this is what we use. Okay, what is this? Is it the salt versus sugar discussion always? So salt is a 3% or 23% sodium chloride versus 20% to 25% mannitol. So this is comparable, and we know that one over other is not going to help. Mannitol is given as boluses, and hypotonic saline is given as infusion. So we have institutional protocols for the dose and how we give. particularly in hypertonic saline. It can be used for treating hypovolemia also, and resuscitation is better with hypertonic saline. But for osmotherapy, it each has its own good and bad things. So we need to go as per our institutional protocol. And we have many guidelines and many studies which saw through this. And whatever we have inferred is that the hyperosmolar fluids are effective in reducing the ICP, yes, but there is no firm evidence that the hyperosmolar fluids have different efficacy in reducing the ICP. So we need to go by the use of ICP monitoring and to observe the effect of therapy. There is no evidence that the hyperosmolar fluids improve the outcome. So everything is taken with a pinch of salt or sugar. So pun intended. So on the horizon, we have more fluids coming up, and we have hypertonic saline with adenosine, lidocaine, and magnesium. There are modified hemoglobin-based oxygen carriers coming up, which has reduced nitric oxide scavenging and oxygen-free radical generation. And sodium lactate is yet another fluid coming up, which seems to be more of a friend than a foe to the brain. So emerging concept is that we need to have a very careful way of fluid management in the brain injury. We need to avoid the hypovolemia, and as we know that the spectrum should be within the situation where both hypo and hypervolemia are avoided with volume status monitoring. And we need to make sure that this is considered, and the successful prevention of secondary brain insults are also seen. So that is what we need to make sure that we give a proper fluid intake. So how do we conclude? So intravenous fluids either resuscitate intravascular volume or to maximize the cerebral perfusion and minimize secondary brain injury. There is an overlap between these indications. No outcome benefit has been reported for any colloid and any 4% or whatever fluid we use. It is not going to help with the outcome benefit. So always hypervolemia kills, hypovolemia kills. So we need to have a very clear basis and protocol of how much fluids we give. Osmotherapy is good. It helps in reducing the intracranial pressure, and but the impact on patient outcome is unknown. Both volume and composition impact the secondary brain injury and the patient outcomes. So we know that fluids are also drugs. We need to be prescribing it with a physiological rationale, clinical supporting evidence, and awareness of the adverse effects. So we make sure that we do not overuse or underuse fluids. Always we use with a clear institution protocol or a very clear ICP monitoring, and the clinical outcome is very, very important. Thank you so much. Thank you so much for giving me this opportunity.
Unmute, sir, please. Sir, unmute, please.
Hello. Due to shortage of time, we have cancelled the tea break. We have a question for Dr. Varaprasad, sir. Dr. Varaprasad, sir. Any targeted oxygenation for a pregnant female with traumatic brain injury?
Targeted? Sorry?
Any targeted oxygenation for a pregnant female with traumatic brain injury?
Targeted oxygen for pregnant female. So for pregnant female, the BTF guidelines doesn't make the recommendation. They still make it 90, but usually we try to keep it between 90 to 95.
Thank you so much, sir. Thank you so much. We would move on to the next session. We would move on to the next session. So the topic is cerebral perfusion pressure targeted therapy makes a difference. And the class would be taken up by Himanshu Prabhakar, sir, Professor, All India Institute of Medical Sciences, New Delhi. Over to you, sir.
Good afternoon. First of all, I want to thank the organizers for inviting me to deliver a talk on cerebral perfusion pressure targeted therapy makes a difference. Now, monitoring the brain after injury plays a very crucial role in early detection of secondary adverse events, assessing the response to treatment, and optimizing the cerebral functions. And in this regard, intracranial pressure and the cerebral perfusion pressure are most commonly used modalities in neurocritical care. The cerebral perfusion pressure describes the pressure driving blood through the cerebrovascular bed, and it's calculated by the difference of the mean arterial pressure and the ICP. So what is optimal CPP range? According to the Brain Trauma Foundation guidelines, the target CPP value for survival and favorable outcomes should be between 60 and 70 millimeters of mercury. This is level 2B evidence. There is another level 3 evidence also, which suggests that any aggressive attempt to maintain CPP above 70 millimeters of mercury with fluids or pressors should be avoided because of the risk of adult respiratory failure. So in the absence of high-quality evidence for a single CPP target, the use of more dynamic, individualized CPP has been proposed by the researchers. So what is this individualized CPP? To determine the optimal CPP at an individual level, both cerebral autoregulation and cerebrovascular reactivity need to be considered. Various studies have evaluated the use of continuous monitored pressure reactivity index, written as PRX. And this pressure reactivity index is calculated as a correlation coefficient between the slow waves of mean arterial pressure and the intracranial pressure at a sequential time averaged points over a defined period. Negative values where the arterial blood pressure is negatively correlated with ICP, or values around 0, they indicate intact autoregulation. And positive values suggest disturbed reactivity or impaired autoregulation. So how do we calculate this optimum CPP or the individualized CPP? This is based on the observation that the pressure reactivity and the CPP exhibit a U-shaped relationship with time, as you can see in this graph. The pressure reactivity is at its lowest value where the cerebrovascular reactivity is preserved, and this corresponds to the cerebral perfusion pressure optimum. So clinicians can now personalize patient care using models for predicting the optimum CPP and ICP thresholds. Despite the widespread use of ICP and CPP-guided therapy, there is no high-quality evidence for outcome benefit. A 24 hours period of dynamic monitoring seems sufficient to determine an optimal CPP. It has been noted that hyperperfusion has been associated with higher mortality and hyperperfusion with more severe disability. Prospective evaluation of the optimum CPP is still awaited, although a recommendation has been made with only moderate quality of evidence. There is an ongoing feasibility study to assess the use of optimum CPP-guided management, and the results are awaited. So with this information in the background, we can conclude that the advances in monitoring have led to the possibility of personalized medicine with individual targets such as the optimum CPP. But prospective validation is still lacking. Individualized targets may have a stronger association with the outcome than the current consensus-based thresholds. Further management of acute brain injury will rely more on the individual approach, with continuous inputs from multiple monitors, better predicting the secondary injury rather than ICP or CPP in isolation. Thank you.
Thank you so much, Himanshu sir. The next topic would be, is clinical assessment good enough for ICP monitoring? And it would be taken up by Dr. Babu K. Abraham sir, Senior Consultant, Department of Critical Care Medicine, Apollo Hospitals, Chennai. Over to you, sir.
Hello, everyone. I'm Dr. Babu Abraham. Over the next 10 minutes, I'll be discussing about ICP monitoring and how clinical assessment is good enough to diagnose raised ICP. I will be covering ICP monitoring in general, the clinical neurological assessment that we use to monitor and diagnose ICP. I will talk about the sensitivity and specificity of these clinical signs. We'll look at the studies that compares how invasive ICP monitoring fares at bedside with clinical monitoring, and we'll conclude. Raised intracranial pressure, as all of us know, can lead to cerebral ischemia, brain death from brain herniation. An ICP greater than or equal to 20 millimeters of mercury has been shown to be associated with poor outcomes. Ventriculostomy is the gold standard used for measuring ICP. However, it comes with a few drawbacks, like it requires expertise. Not everyone can do it on the bedside. It's associated with complications. And there is no evidence that using an ICP monitor to drive our treatment would decrease mortality. On the other hand, clinical assessment is more of physiological monitoring of neurological status. It is not continuous, it has to be done sequentially, and if we don't do it frequently, we may miss the important point of time when the ICP is going up. And it becomes more informative once the patient is stated. For example, if a patient is hypotensive and there is decreased perfusion to the brain, he may show all signs of a raised ICP could show, which gets completely reverted back with good resuscitation and the blood pressure picking up. Neurological signs can also be affected by temperature, both hypothermia and hypothermia, and pharmacological agents that act on the brain. The three important neurological signs that we use to monitor ICP are the assessment of conscious level, the assessment of symmetry of motor response, and the pupillary size and reaction to light. So on bedside, three signs have been studied. They are the pupillary dilatation, motor posturing by using the GCS motor score less than or equal to 3, and decreased level of consciousness with a GCS of less than or equal to 8. Now, let's look at a meta-analysis and see how these signs fared in diagnosing raised ICP. This meta-analysis contained mostly patients with severe traumatic brain injury and some arachnoid hemorrhage, two conditions that we very clearly know is associated with high incidence of increased ICP. So these conditions can be said to be having a high pre-test probability of having raised ICP. And under such conditions, pupillary dilatation was shown to have a low sensitivity of 28% and quite a good specificity of 85.9%. And if you look at the ROC curve, the overall diagnostic accuracy is just moderate. The second clinical sign is the presence of motor posturing with a GCS of less than or equal to 3. And again, the ROC curve shows that the diagnostic accuracy is not too brilliant. The sensitivity and specificity sitting at 54 and 63 respectively are also not very good. And as I said, the diagnosis certainty is low. Now let's look at the level of consciousness. The GCS less than 8 had a high sensitivity but a low specificity, and that too did not have a very good diagnostic certainty. So this meta-analysis concluded that intuitive physical examination in isolation. So if you take any one of these clinical signs and use it for diagnosing raised ICP, it did not have enough sensitivity to correctly detect the condition. However, let's look at these three signs together. And remember that if you have conditions that have a high pretest probability, like severe TBI or subarachnoid hemorrhage, a test like a low Glasgow Coma scale less than 8 has a very good sensitivity. So you can suspect raised ICP in anyone with severe traumatic brain injury or subarachnoid hemorrhage, and this can be a very good screening tool. And if the same person has pupillary dilatation, it has a very good specificity in indicating that there could be raised ICP, and this has got a moderate diagnostic ability. So combining these two signs gives us a better post-test probability of diagnosing increased ICP in conditions like severe traumatic brain injury and in subarachnoid hemorrhage. Now let's look at how clinical signs fared when compared to invasive ICP monitoring. Here is a study which is published in the NEJM in 2012. It's a multicentric RCT. They compared invasive ICP monitoring against clinical assessment with CT scan in severe traumatic brain injury patients. And what did they find? Okay. The primary outcome was a composite of 21 components, and there was no difference in either group. Not only that, if you look at the Kaplan-Meier curve, there was no difference in mortality on 14 days or 16 days, irrespective of whether you titrate your therapy based on invasive ICP monitoring or clinical assessment. And the authors concluded that in severe traumatic brain injury, care focused on maintaining monitored intracranial pressure at 20 millimeters of mercury less was not shown to be superior to care based on imaging and clinical examination. Why did I bring this up? The meta-analysis that I spoke about also looked at CT scan in traumatic brain injury and subarachnoid hemorrhage, and they clearly showed that the CT scan that has an obliterated basal cistern has a very good sensitivity of 85% for picking up raised ICP. And if it also had a midline shift of greater than 10 millimeters of mercury, it had a very good specificity of diagnosing raised ICP. So combining clinical signs with CT scan findings of obliterated basal cisterns and midline shift gives us quite a high diagnostic probability of diagnosing raised ICP in conditions like traumatic brain injury and subarachnoid hemorrhage, which have high incidence of raised ICP. I would like to tell a word of caution. Conditions like metabolic encephalopathy, hepatic encephalopathy, where the incidence of raised ICP may not be as high as in traumatic brain injury and subarachnoid hemorrhage, which means the pretest probability may not be high. These observations may not we may not be able to interpolate it to such conditions. So to conclude, no clinical signs in isolation has a sensitivity or specificity in diagnosing raised ICP. However, in conditions with high pretest probability for raised ICP, like severe traumatic brain injury and subarachnoid hemorrhage, a combination of decreased GCS or less than 8 and dilated pupils could give you a good post-test probability of diagnosing raised ICP. And if you combine it with a plain CT of head that shows obliterated basal systems and a midline shift of greater than 10 millimeters, that could be a more accurate diagnosis of ICP. What I would like to highlight is that ICP monitoring using an invasive monitor has not been shown to be superior to either clinical examination or CT scan imaging. Thank you.
Thank you so much, Dr. Babu Abraham, sir. The next one would be the consensus. It would be taken up by Dr. Ritesh Shah, sir, Director, Critical Care Unit, Sterling Hospital, Gujarat. Over to you, sir.
Hello everyone, I'm Dr. Ritesh Shah. I thank HICS organizing team, especially my friend Dr. Srinivas and Dr. Ghanshyam for this wonderful opportunity. Today I'm going to talk about the consensus approach to ICP management. Now, intracranial components, which consists of brain parenchyma, that is 80%, CSF and blood, each 10%, and the approximate volume is around 1400 to 1700 ml. So whenever it is actually in the equilibrium, but whenever some pathology happens or pathology is there, because of that, it exerts its mass effect. First, CSF takes the hit, but if it goes beyond its compensation, definitely it's not only CSF, but the blood volume also takes up the hit, and up to a certain extent it gets compensated. But once it goes beyond, then it causes displacement of the normal brain parenchymal structures as well as raised ICP, and if it goes too much, it causes herniation. It is called Monro-Kelly doctrine. Now, I won't go into much of details of causes as well as signs and symptoms, but why to address raised ICP? Because it aggravates if the secondary brain injury and causes cerebral ischemia, edema. There is some neurochemical interplay of excitatory neurotransmitters, free radical injuries, and ultimately all of this can cause the brain, make the brain injury irreversible, which is our primary motto to prevent it. So there are treatment principles. First of all, treatment of the primary cause, prevent secondary brain injury, intervene in terms of maybe decrease cerebral blood volume or give some space for brain to expand or decrease the fluid component, and we have to monitor ICP as far as it is possible. First of all, the approach consists of resuscitation, certain general measures, and certain specific measures. Now, resuscitation is the key. We have to take care of hemodynamics and ventilation. So for that, first of all, airway, we need to protect the airway, intubate the patient, but even if patient is unresponsive, beware of the laryngoscopic reflexes, because bucking or coughing against laryngoscopy can increase raised ICP. So give some sedation if at all it is possible. Literature suggests that beta blockers and lidocaine can be used to blunt the response, but beware of bradycardia. As far as breathing is concerned, avoid hypercarbia, avoid hypocarbia as well. Target PCO2 around 30 and avoid routine hyperventilation. And we have to hyperventilate only transiently in refractory hypertension. If there is cerebral herniation, acute neurological deterioration, till as a bridge, we have to use it as a bridge to either recovery or intervention. And caution, you cannot keep PCO2 less than 25 and always monitor jugulus venous oximetry or brain tissue oxygen whenever it is possible. Hypotension, anyway, we avoid hypotension, but treat hypertension cautiously, because hypertension can cause increase in cerebral blood flow and ICP. It can cause intracranial hemorrhage in already hemorrhagic stroke patient, and we can utilize labetalol alpha agonists as well, but avoid vasodilators, that is nitroglycerin. There are certain general principles like we have to keep head elevation 30 degrees, keep head in neutral position, avoid or reduce excessive flexion or rotation of the neck, avoid restrictive neck strapping and bandages like tracheostomy or whatever, which can occlude the venous outflow. So the idea is to smoothen out the venous outflow. Fluids, keep patient euvolemic. There is no need to restrict fluid in ICP all the time. We have to keep hemodynamics as a first parameter that avoid hypotension. It can cause secondary injury. But two things, avoid hypotonic fluids and keep serum osmolality more than 280 milliosmol per liter as far as possible. A fever we need to treat very aggressively because it increases cerebral metabolic rate by 10 to 13% per degree Celsius increase. So it thereby increases ICP. So prevent treat hyperthermia as far as with the help of antipyretics and mechanical cooling whenever needed. Sedatives and analgesics we need to use because it decreases ICP by reducing the cerebral metabolic rate of oxygen consumption. It reduces ventilatory asynchrony, reduces venous congestion, reduces the sympathetic responses of hypertension and tachycardia, as well as it also helps in controlling seizures in certain pathological situations. Multiple agents are available. We won't go into the details, but yes, midazolam, lorazepam are one of the kind of popular agents. Anti-seizure therapy, we know like the Brain Trauma Foundation protocol that yes, in post-traumatic seizures, we need to use phenytoin early, but it doesn't help us in preventing late post-traumatic seizures. And seizure, and anyhow, we have to prevent because again, it increases cerebral metabolic rate, cerebral blood flow, and thereby increases ICP. In refractory seizures, we have to use barbiturates, the popular agent is thiopenton. We know the dose 5 mg per kg or 30 minutes followed by 1 to 4 mg per kg per hour. But we have to monitor hemodynamics and we have to see whether it should not cause hypotension. Because of thiopenton, patient remains sedated, so difficult neurological monitoring, and it can cause respiratory depression. If in non-intubated patient, we have to keep a close watch. Therapeutic hypothermia, I would say prevent hyperthermia rather than actively inducing hypothermia because it also can cause shivering, cardiac arrhythmias, sudden electrolyte imbalance, and it precipitates sepsis also. And whenever we use hypothermia, 32 to 34 degree nowadays, 34 to 36 is also okay. The idea is to prevent hyperthermia, and whenever we do hypothermia, then rewarming should be gradual. Steroids, big no-no, except in brain tumors and CNS infections. Now I'll come to specific principles, and the common base is osmotic therapy. It decreases ICP by reducing brain water. So it lowers ICP in 1 to 5 minutes once we start it, and then we have to repeat it every 6 to 8 hours. We have to monitor serum osmolality, and it should be kept below 320 milliosmol per kg, and beware of the side effects that it also can cause hypotension with rapid administration. If we stop it, there might be rebound increase in ICP. There is some association with volume overload, can cause definite electrolyte imbalances, and it can cause renal failure, especially in presence of hypotension. So mannitol is one of the key factors that we use routinely. Hypertonic saline is an alternate agent. The availability is 3 to 23.4%. It requires central line to administer, but we have to monitor sodium. It should not be more than 160 milliequivalent per deciliter. It remains within the vascular compartment a little bit longer than mannitol, and useful in treating the hypovolemic patient also, that takes care of also. And it does have somewhat better coefficient, reflection coefficient than mannitol, but it is not free of side effects. It can cause coagulation abnormalities, hyperchloremic metabolic acidosis, and with rapid infusion, it can also cause osmotic demyelination. But we are using it for brief period, so usually it is not a problem. There are other agents like furosemide. It is just to potentiate the effects of mannitol. Standalone, it is not useful, and beware of dehydration and hypokalemia by diuretics. Glycerol and urea, it controls ICP by osmoregulation. It equilibrates between brain and plasma levels, which occurs more quickly than other agents, but it is less effective and relatively weaker osmoregular agent. CSF drainage in certain patients we use here, remove the water part, that is CSF drainage, but the rate of drainage should not be more than 1 to 2 ml per minute, and for 2 to 3 minutes at a time. A lumbar drain is contraindicated because of risk of transtentorial herniation. By an abrupt drainage may lead to obstruction of the catheter opening by brain tissue, as well as it can precipitate recurrent hemorrhage. So beware of that. Last but not the least, whenever we are against the wall, timely, I would again stress, timely decompressive cranectomy is necessary. Removal of a portion of the skull vault. Hemicranectomy is preferable rather than bilateral. In multiple situations, decompressive cranectomy always helps, at least to tide over the crisis. So, but the key factor is time. It is not free of side effects that, it can cause herniation through the skull defect, spinal fluid leak, later on wound infection, epidural and subdural hematoma, and later on we have to deal with subdural hygroma. So timely decompressive cranectomy is the key to manage ICP. There are a lot of studies, I won't go into much of details, but to conclude my talk, early recognition of raised ICP is important. If delay in recognition, it can increase mortality and or worsen neurological outcome. ABC remains the basic principles. Avoid hypotonic fluids. Keep cerebral metabolic rate as low as possible by any means that you can think. ICP monitoring always helps whenever you can do it. Osmotic therapy helps to get the window for intervention or for recovery. Timely decompressive cranectomy can definitely change the prognosis towards better one. It can improve outcome, and treatment of the cause is the key. Thank you very much for patient listening.
Thank you so much, Ritesh sir. There are no questions and queries, so we are moving to the next session. The topic is critical care research in India, the barriers and opportunities. It is an oration by Dr. S.K. Todi sir. He's a medical advisor and director of critical care medicine, HOD Department of Academics and Research, Amri Group of Hospitals, Tukharia. Over to you, sir.
Hello, friends. First of all, let me thank Dr. Srinivas and the scientific committee for asking me to give this oration in HICS 2023. When Srinivas asked me to give this oration and to choose a topic, I could think of critical care research in India as the most suitable topic. As you all would agree that we have done a good job in increasing awareness of critical care, increasing education in critical care, training in critical care by various courses, having conferences, seminars, webinars, etc. But we have not done much progress so far as research in critical care is concerned in India. We have barriers and we also have opportunities. So I thought that let me take up this topic for the oration for this year in HICS. When I looked at the PubMed and looked at the critical care research done in India in PubMed, you see there was a spike of publication during the COVID era. But prior to that, the research which was published in index journals were very few. Even till today, even post-COVID, we have around 2,000 publications which have critical care as the mesh word. On the other hand, if you compare this to China, it's almost 4 or 5 times the publications that we have. So, and you see, even pre-COVID era, they had a lot of publications. So I think it is very, very important that we should be more proactive in publishing. So what are the barriers in our critical care research? Let me discuss 5 barriers which I think are important in doing research in critical care, especially in our country. First is there is a lack of protected time. Now, what is this? So basically, it is a time which we can devote to research. At the same time, we'll be paid either fully or at least substantially if we would have devoted this to our professional duties. Now, it is almost impossible in the private sector to have protected time in our country. And we meet during conferences and meetings, and we talk about research, and we all think that we are going to do research. But when we go back to our hospitals, in our ICUs, we get so busy with our clinical practice, we don't get much time of doing good research. And that is where we are lacking. Even in a public hospital, in the government sector, where in most of the Western countries, you see most of the big publications have come from the government sector, where they do get protected time. By talking to my friends working in the government sector, even they have so much of workload, and even they do not have protected time. So until and unless there is some protected time given to the professionals, it will become very difficult. So what is the way out? One can say that, okay, if we give so much of time to research, if some incentive is given so far as the increase in minimum guaranteed amount, or if they have increase in their position in the government sector, then that might be another way of incentivizing this process. So I think that is the first thing which we are lacking. We require a protected time in order to do serious research. Second, research is not a one-man phenomenon. If we require a research team, we require a team which consists of at least the data entry person, we require a research statistician, we require a team for manuscript writing, analysis. So it's a teamwork. And by and large, in private sector, in most of the places, there is no research team. And it's basically a one-man phenomenon. And we keep on having our friends and other colleagues in order to join us to do a research, but everybody is busy in their own work. So until and unless we get an infrastructure and a research team which is being devoted to a particular project, it will be very difficult to get a very serious research from a subject of interest. So I think that is the second big issue that we are lacking in our country, that we don't have that kind of an infrastructure of data entry operators, statisticians, research assistant, in order to help us in doing serious research. Third comes funding. You see, in most of the Western countries, there are funding available from states, there are funding agencies. We do have funding agencies like ICMR, but if you go through the website and the sort of funding which is being done by most of the funding agencies, first of all, a substantial portion of this goes to the public hospitals. And private hospitals get fund, but very rarely. And the amount is also not substantial. And the private sector itself, there is lack of funding. So when we talk about investigated, initiated research without any industry participation, having a fund to do a serious research is a big problem. So private establishment do not find any incentive of investing money in doing research. But I have a feeling that this paradigm need to shift, and the administrators need to be aware that if a good research is being published, from their organization, it will attract more talent in their organization, which will ultimately will lead to better patient care and will ultimately will gain name for that organization, which I think is the probably the most ethical way of marketing a private concern. So research if you look at in the long run, will definitely help even a private sector organization. For public sector, I think it is very, very important that they should be asking for grants and funding from institutes like ICMR. But critical care funding is unfortunately very much lacking. And I have seen most of the funding going to communicable diseases, tuberculosis, and others. But hopefully, if we require more advocacy in getting critical care funds from these kind of funding agencies in order to have good research in critical care in our country. The fourth is the lack of training. You see, we are all clinicians. During our medical schools, we were not taught seriously about how to do clinical research. Those of us who are passionate in this field, we do workshops and do small training programs that sometimes help us in knowing how to do a clinical research. But a serious clinical research requires some amount of training. And I think hopefully with this new medical curriculum, the junior doctors who are gradually coming out of medical school will be more trained in clinical research, the nuances of clinical research, in order to take this agenda forward. So training in clinical research is also is very much required in order to do research in our country. And last barriers, which I think is ethical and legal issues. You see, almost it has become a mandatory to publish any study to go through these ethical committees. Now, at the present moment, I would say critical care research and getting an informed consent with a very stressed out family, and basically the knowledge of the families and the surrogates of the patient, because most of the time patients cannot give informed consent. The families know-how is very poor so far as research is concerned in our country. And they are so stressed about because of various reasons, including economic, and asking them for an informed consent becomes very difficult. And asking an informed consent by the senior most consultant to give time also becomes very difficult. But ethically, that is what is required. ICMR and others have made a very strict guidelines for ethical research, which is good. At the present moment, our research standard is I think is in its infancy so far as critical care is concerned. But the ethical standard that we are applying to our research field is of the highest probably we are supposed to meet the highest standard of ethical research as being practiced in the West, which is discordant, because the sort of research agenda that we have now, West was there about 15, 20 years back. At that point, even their ethicals were not that much stringent. But now we are faced with a very high standard ethical thing, which are being, we are supposed to follow those. And that I have found become a very difficult. For example, even if we want to do a prospective observational study, we don't talk about even interventional study. It becomes very difficult to get it through ethical committee because of the informed consent and all being involved. So many of the investigators, they get disheartened because the time which is required in getting all this becomes very difficult. So even very multi-center studies in our country, we don't get ethical committee permissions from many of the big centers. So we are not able to pursue many of the studies. Now, as so far as the randomized studies are concerned, there is a lot of legal issues involved, and nowadays these legal issues and the compensation clause has become so stringent. So until and unless a research is backed up by a big industry, it becomes very difficult to conduct research on funding from a small funding from an organization. So I think these issues also become a big barrier of doing research in our country. So basically, the 5 barriers that we are seeing is lack of protected time. We require a dedicated time, but during that time, the investigator need to be reimbursed for the time, which is not there. So basically, it is the passion of the investigator at the present moment. The investigators do not have a dedicated research team with data collection, with a statistician, research coordinator. So that's why research in private and government sector is very poor. We don't get adequate funding from central agencies, which are more focused towards communicable disease, cardiac diseases, rather than critical care. We are not trained. We don't have a very trained workforce in research which can be tapped, because the remuneration which goes into research is very poor. A nurse who will do a research nurse will get much less paid if for the same qualification she has if she goes into a clinical nursing stream. So that's why to get good manpower and to retain them in research becomes very difficult. And as I mentioned, there are a lot of ethical and legal issues which are involved. So given these barriers, I would like to highlight these 2 compendiums which we published when during our annual Congress. The first time was in Calcutta in 2013, and the next was in Mumbai. You see, we looked at all the research being done from India in critical care over 5 years, 2008 to 12, and then 13 to 18. As you all know, many of our research, what we found that more than 80% of our research is in the abstract stage. They are not published in index journals. First of all, because of the various reasons I mentioned, investigators do not have time to write manuscripts. So we thought, but at least they are research, though abstracts, and presented in international congresses. So why not gather, apart from the published PubMed Index journal published research, all the abstracts which were presented in our annual congresses and international congresses. So we collected the entire volume of critical care research. And this is an eye-opener, because, if you search colistin, for example, in this compendium, you will probably find the largest data on colistin in patients, clinical problems faced by patients, but they are in abstract stage. Each study is of small sample size, and so there is no big multi-center interventional randomized study. But small collectively, if you look at the compendium, you'll find a lot of data on different aspects of our problem. So I think we have the right notion, but because of the barriers I mentioned, we are not able to publish an international standard research at the present moment. We also have 5 opportunities. As I mentioned about 5 barriers, we also have 5 opportunities. Now, what are those? First and foremost, We have very large patient population, as you know, with a huge population of the country and the number of ICUs which are opening in every metros, and the second tier cities are getting populated with large intensive care. So there is no dearth of patients on which the research can be done. And as you know, the numbers are the most important. The sample size is very important in order to get a meaningful outcome. So that is, I think, one of our biggest strength, that if we take up a research, we will definitely get patient. One example is we did a Hermes study where we looked at fluid resuscitation on ICU admission in sepsis patient. And it was done a couple of years back. And, within a year's time, which was the time frame of the research, we got around 800 plus septic patients from about 60 or 70 intensive care units all over the country. So huge database of septic patients just over a period of 7-8 months. So that large patient population is our strength. Second, we have a lot of unanswered questions. You take any field of critical care, be it fluid resuscitation, vasopressors, nutrition, antibiotic, infections. We have very unique problems because of healthcare delivery, the sort of diseases, the tropical infections that we have because of the lack of a lot of medications and the cost constraints. It's very important that we need to have our own research. There are genetic variation, and our control arm mortality of sepsis, for example, is much higher than the West. So the same drug which did not work in the West, where the control arm mortality was much less, could it work at the present moment in our country? We do not know. So we need to do these researches in our own population. And as you are aware of studies done, like a FEAST study done in African children, where they found that fluid boluses causes more harm than good. So it's very important that many of the things which we take for granted from the guidelines and other which are published in the West need to be, at least some of the important ones, need to be tried in our country as a research agenda. The third opportunity we have is a networking of ICUs. We have, even in ISCCM, we have more than 100 ICUs and we have 13,000 members. So networking of like-minded ICUs, research-minded ICUs, which can collect data and do quality research is definitely possible. It has been done in countries like Brazil. The Brazilian network, as you know, has published recent trials on fluid resuscitation, which is a game changer. These will change the guidelines, will change the world guidelines, because they are able to produce clinically outcome relevant research, and their sample size is huge. And they have based their research on the networking of many ICUs in their country. So it is very important that we need to look into this and do our own ICU network. Fourthly is the international collaboration. Nowadays, as you know, in the COVID era, it was very evident. Even before COVID era, some of the investigators have started internationally collaborating the research. For example, this INFACT group, where major international societies have come together. The Brazilian, the Chinese societies from this part of the world has also are involved in order to produce data. So if you see, then we can collaborate with each other. We can take their know-how, their intelligentsia on scientific research. And then if we have the same kind of a methodology adopted here, and produce meaningful research, which will be very important for the entire world. And the numbers that we can contribute to this global collaboration would be very high. So I think this is another way and a big opportunity for collaboration internationally. This new trial designs, which have come in for during the COVID era, I think is a big opportunity. The adaptive trials, the platform designs, where we can try many drugs on multiple patients, because it decreases cost, just to try one drug first and then the others, and subsequently is a huge cost involved. So given the number of patients that we have, we can have, steroids, antibiotics, antifungals, and many other trial designs in the same kind of a patient population in the platform trial design, and also this adaptive trial designs, which will basically analyzes the results while the trial is going on, so that we have a meaningful outcome and we do not land up having futile clinical research. So I think it is very important we adopt this new trial designs, which will help us. And because of this big data and artificial intelligence, and if we have a huge sample size, which is possible, and high network volume of our ICUs, and even in observational studies, if we produce big data and apply AI to this data, we would be able to produce a meaningful clinical research agenda from these kind of. So basically, these are the opportunities which I think is so important. Newer trial designs, international collaborations, networking of ICUs, so many questions that we need to answer, and the large patient population that we have with us. These are all very big opportunities. Though we have barriers, but we also have opportunities. This is a study which was published in New England Journal, and this is I would say, milestone in critical care research in India. This is a fully Indian study with a problem that we face almost every day. The huge patient population, 800 plus patient population. We have international, we have a network of ICUs and network of other hospitals. In India, we have network of investigators in India. And we have international collaboration. Wellcome Foundation did fund this study. So you see, so all the opportunities that we spoke about came into this, and you see it was published in the most #1 important medical journal in India. So it shows that we can do it. So I think if we take up the opportunities, if we know the barriers and try to overcome our barriers, we should be able to produce quality research. It will take time. I think but we should strive towards that, and all the major societies, Indian societies for critical care, should devote more funding, more time towards research. And I think the private sector administrators need to look towards clinical research as an agenda for incentivizing their workforce will also become very important. So with this, I would like to thank you, and hopefully I've been able to give you my perspective of critical care research in India. Thanks a lot.
Thank you, Dr. Subhash Todi, sir. Next, we would move on to how to optimize outcomes in acute ischemic stroke. And this would be presented by Dr. Kapil Sirpe, sir, Head Neurotrauma Intensive Care Unit, Ruby Hall Clinic and Grant Medical Foundation, Pune. Over to you, sir.
Hi, friends, and thanks to organizing committee of the HICS for inviting me for such a very important topic, how to optimize the outcome in acute ischemic stroke. Now, the objective of my talk will be I will go through the stroke burden and the current issues, followed by the stroke awareness, then pre-hospital care, telestroke and stroke code. What is the current situation? How we can help it out in improving the outcome, and regarding the thrombolysis and the extended time windows with the mechanical thrombectomies and the rest of the indication. Now, to start with the stroke burden. All of us know that the stroke is a global issue. It is one of the major cause of the mortality, and not only mortality, it is a morbidity. And if you see the current statistics of the India, according to the Indian Stroke Association, incidence of the stroke has increased almost 100% in past decade, and almost estimated 1.8 million suffer from the stroke in India every year. 30% of the overall morbidity is attributed by the stroke, and approximately 1 Indian suffers from every 20 seconds with the stroke. So big problem, small awareness. That still in 2023, it's a big problem, small awareness. So what is the current situation? If you see in the stroke management, we talk a lot about the stroke treatment, availability of the advanced treatment, availability of the endovascular treatment, but what is the current ground reality in the stroke management? If you see, only 2 to 12% of the eligible acute ischemic stroke patients receive the thrombolysis with the thrombolytic agent. Out of that, 2/3 of the cases receives the thrombolytic treatment where the detain is more than 60 minutes, and our target is golden hour. It has to be the less than 60 minutes. So long way to go ahead in acute stroke management. And if someone wants to do the acute management in a better fashion, then we have to streamline the local guidelines, national guidelines, standard operating practices, procedures to reduce or shorten the door-to-needle time less than 60 minutes. Time is brain. All of us know that time is brain. Act fast. We promote it very aggressively because the time save at each junction means the brain save. And that's why we should have the aggressive measures should be taken not only inside the hospital, at the pre-hospital area, and even regarding the awareness. That's why the optimization is needed at every level. So which are these 3 levels? The levels are at the level of the awareness, levels are at the level of the pre-hospital care, during the pre-hospital care, then inside the hospital, and various measures to reduce those timelines for the better results. So we'll start one by one. When we talk about the awareness part, there are 8 Ds of the stroke care. That is the pre-arrival. There are the 4 Ds like detection, dispatch, door, and the delivery. Huge problem. Again, the recognition of the stroke signs and symptoms, calling the ambulance, emergency ambulance medical services. I will go into the detail. Then reaching to the hospital which has the facilities of the stroke care delivery, and then triaging at the emergency department. This was a very interesting study I came across regarding the awareness of the stroke symptoms in a layperson. This was from the Indonesia, very small group of the patient, but that correlates almost everything with our population, Indian population. Like in that study, almost more than 40% of the patients do not utilize the stroke facilities. The reason is very simple. Patients cannot identify the stroke signs. Believe me, in 2023 also, in my setting at Rubyhall in Pune also, patient comes on the day 2nd or day 3rd with the symptoms of the stroke, and they say that, okay, they never understand, they never recognize it is a stroke. It might be some slurring of the speech or weakness. They thought it is a post-viral weakness and patient lying in a bed. So almost 60% of the patient cannot identify the stroke sign. Very unfortunate story in 2023. Majority of the time, there is no one is accompanying them. Like most of in metropolitan cities, they are working families. Everyone is out at early morning. They come late in the evening, and those grandparents are staying at home. They are left attended, and when they came in the night, they realized that there is something wrong with the parents, and then the issue is we are losing those timelines for the acute stroke management. then patients are not willing for the hospitals. We all of us know there are a lot of misbeliefs or myth about the hospital that I go to the hospital, they will do my imaging, they will do my CT scan, unnecessarily they will do the blood test, unnecessarily they will give a treatment. So there are a lot of misbeliefs, and that's why patients deny to visit to the hospital. This is true in 2023 also, unfortunately. And then patient gets misdiagnosed at the hospital level also. Even physicians, if someone goes with some weakness with slurred speech, they do the CT scan. CT scan is normal. They do not understand it's early stroke. They give them symptomatic treatment. This may happen. This is happening. Another study, it was the largest study, it was the largest, in fact, the 30,000 patients arriving within 60 minutes. This was done by the Saver, and he found that only 18.4% of the patients who receives the thrombolytic therapy from onset of the symptoms. So onset of symptom to treatment is only 18.4%. And this is in USA, where the emergency system is well established, where the awareness is good, and still there is this. So what we found from his study, the onset to door time in 28.3% was less than 60 minutes. So they were within that window to get thrombolyzed, and out of that only 18% received the thrombolysis. So we need to think over it. We need to improve those timelines. We need to improve those awareness amongst the citizens, so that they can reach to the nearby stroke-ready hospitals and avail the stroke facility for the better outcome in the stroke patients. And that's what we confirm in the Indian study. This we published in 2015 from the My Hospital Rudyard data, almost more than 650 patients data, where we again conclude with the barriers of the thrombolysis in our study, where the lack of public awareness, there is a lack of accessibility to the emergency medical services, lack of the priorities in the triaging in the emergency department, and lack of the multidisciplinary stroke court team. And that's what we observe, and then we worked on those weaknesses and try to improve the timelines and outcome in stroke. The second most important part in a pre-hospital case is not only the awareness, where you reach to where you ship the patient, that there has to be the concept of the stroke-ready hospital. This concept was in 2013, almost decade ago. Albert et al. Had very clearly mentioned what is the difference in between the stroke-ready hospital and the primary stroke care versus standard hospitals and the standard stroke care, and what facilities should be there in a stroke-ready hospital. In short, the stroke-ready hospitals mean the hospitals which has the CT scan facility, at least CT scan facility, on-call neurologists. It's not necessarily they should physically sitting because the telemedicine, telestroke is now available. So any hospital which has the imaging facility and on-call neurologist, we are supposed to reach to that hospital rather than nearby any hospital. And this concept need to be spread through the lay person, citizens, and even the exerted person, that please ship the patient to the nearby stroke-ready hospital for the better treatment, for the early treatment, and to improve the outcomes in particularly acute ischemic stroke patients. The next part is the pre-hospital care. We'll not talk about the pre-hospital care. What is the current situation? Everyone knows. The moment you receive the stroke patient, you have to do the rapid assessment, you have to do the severity scoring, you have to take the vital parameters, you have to do the BSL, and go to the nearby stroke-ready hospitals. The most important thing, you should inform to that nearby stroke-ready hospital that you are arriving. That means you are coming with the suspected stroke patient, so that they will be geared up with their teams. They can inform to the neurointervention guy, they can inform to the neurophysician, they can inform to the imaging department that the stroke patient is coming. Might be you need to keep that gantry open, and once you have done that, even whether there is an available neurologist or a radiologist, you can take the help of the telemedicine, telestroke, and go ahead with the thrombolysis. So this is what we are expecting in a stroke pre-arrival or in an emergency system, and we all need to work a lot on that. Unfortunately, still we are in a very primitive emergency medical system regarding the stroke patient transport. All of us know that now the stroke ambulance is an established concept. In 2014, when the Ebinger in Berlin, Germany, has done the study on the stroke ambulance versus the standard care of ambulance, and he clearly shown the benefit of 25 minutes average reduction in the door to delivery time as compared to the standard care ambulances. And also the number of the patients who are thrombolized will be more with the stroke ambulance. So he did it in a 2014, almost decade ago. This was known as the Phantom S trial. And then followed by in 2021, again, he did the Be Proud trial, where again he compared the stroke ambulance versus the standard ambulance. Stroke ambulance means paramedic, radiology technician, and neurological, at least MD guy is available with the imaging facility. And he's shown the clear benefit of the golden hour RTPA, almost 12.8% versus 4% if we transport them with the usual care. This was a Be Proud trial. So when we summarize the importance of the mobile stroke units, because we always talk about the time is brain. We need to thrombolize the patient as early as possible. We need to target the acute ischemic patients as early as possible with the therapy. Then we have to move ahead fast. And if you try to reach to the nearby stroke rate hospital, it may sometimes take time. So you need to do a lot many things in an ambulance, and that's where the mobile stroke units will come into the picture. There are three major, now it is not the concept, it is a evidence-based concept in stroke. Mobile stroke units are in acute ischemic stroke. There are three major trials up till now published. First was already I discussed the Phantom S. Second was the Be Proud, the previous slide, we showed the Be Proud. And this one is the best MISU. And when we compare the Be Proud versus best MISU, we find that the mobile stroke unit definitely is an add-on into the reducing the timelines in the stroke and getting the better and better results in acute ischemic stroke. So when this particular article in 2022 published, they have discussed a lot regarding the importance of the mobile stroke unit. They discussed what is the evidence available. Already three major randomized major trials are available in favor of the mobile stroke unit. They discussed the gaps in this paper and what is the next step. If you see, if you compare the proven acute interventions like stroke unit, thrombolytic therapy within 3 hours, aspirin, RTP within 3 to 4 per hour, endovascular treatment, these are all proven stroke interventions which helps in improving the outcome in the stroke. And against that, mobile stroke unit has a better outcome as compared to the even proven. So mobile stroke unit is a future. We need to work on this. In India, unfortunately, it is still dream. Hardly there are 1 or 2 centers in India are having those facility, but they are facing also a lot many issues. And we are hoping in future this may be the solution over the current traffic situation in India and improving the timelines and the outcome in stroke. The gaps, the major gap, what they came across is the insurance cover. Unfortunately, even in Western countries, they are struggling to get the insurance cover for the treatment offered in these stroke ambulances. And I think that is a major gap in current situation for utilizing the mobile stroke units. And the next step is you need to now move ahead with this concept to reduce the timelines. Now, after the pre-hospital care, now you are reaching to the hospital. Now you need to really move fast. You should be on a toll to achieve those timelines and improve. The first step is the major change in the all stroke guidelines happen as well as the stroke management is the daily stroke concept. Before COVID, I agree in India 2019, before 19, it was very difficult legally to use the telemedicine. But I think after the COVID, now we are in a better situation to use the telemedicine because it is now legally well accepted intervention. And it is clearly evidence from the various trials. It is clearly evident that telestroke has a favorable outcomes in stroke management with the reduced complications. So if you see in terms of the age and the gender as well as the severity of the stroke, they are all favorable outcome in favor of the telestroke. And there will be the reduced complication, reduced mortality with the telestroke. So I suggest that wherever the possible, don't just wait that I don't have the radiologist to read the scan. I don't have the neurologist to give me the decision in a certain situation. We need to use this facility to avoid those hurdles and provide the best possible and in a short time relevant treatment advice to that patient in that particular center, which might be at the remote area, and they need help within that time. So telestroke, yes, now it is one of the major intervention in changing the outcome in stroke. And the next changing the outcome in stroke code is a stroke code. That means once you reach to those busy casualties where there are so many patients are waiting for receiving the treatment, out of that you need to pick up those stroke patients and then move to the imaging and the thrombolysis. So the very simple, cheap and easily available, and it can be implemented at every hospital is a stroke code. Just give a dedicated number, dedicated team, which is the form of the neuro residents and critical care residents and the imaging residents as well as the EMS guys. On admission, just they will alert that stroke code with the patient. Then you pose that patient, move along with that for the imaging as well as the rest of the formalities, communication till that patient receive the particular drug therapy. And we did that prospective study where we found that our overall percentage of thrombolysis increased from 6 to 12% with this easiest stroke code implementation, and we achieved the major drop in the timelines. Like our door to physician time was 30 plus, which was without stroke code, which dropped down to the 6 to 7 minutes. Imaging dropped down from 59 minutes to the something 35 minutes average, and door to needle from 104 minutes to the 70 minutes, and then later on 60 minutes. So stroke code is one of the major intervention which may help in reducing the timeline and achieving those goals in acute stroke, ischemic strokes, and improving their outcome. Okay, now you are in hospital and the next 4 Ds will come into the picture. Your data, you have to collect the whatever the data you are correct, like you have done the NIHS scoring, you have done the severity scoring, you have taken the history, detailed history, you have gone through the history, and now you are proceeding for the imaging. You did the imaging, and after that you have just discussed for whether this patient is eligible for thrombolysis or this patient is not eligible for thrombolysis, or this may go to the endovascular intervention. And then after that, you are offering the drugs. Now there is no confusion. There are 2 thrombolytic drugs are available for the thrombolysis, either tenecteplase or alteplase. Both are effective. Both are equal in therapy. No one is inferior to only the cost benefit goes in favor of the tenecteplase, and it's a bolus dose. So that is one of the advantage with the tenecteplase, where you can save the time and also save the cost. But there is no asset difference in between the thrombolytic drugs you are offering for the stroke, and then you can move to the critical care area. Now, the most important time, if you want to achieve the good outcome in a stroke patient, you have to move fast. And so earlier the better. If you thrombolize within 90 minutes, within 60 minutes is the gold standard, that is a golden hour, and within 90 minutes, you need hardly 5 patients to prove your benefits. And that's what this beautifully done trial in the Lancet in 2010 showed that if you do the thrombolysis within 90 minutes, you get the lesser and lesser morbid patients, and you get the more and more improvement. And the moment you go more than 90, you will land with the more and more morbidity. So in stroke, you should not see only the mortality. You should see the morbidity at what after 3 months, what is the modified ANSI score of the patient, whether he gone back to his routine or is still bedridden or liability or dependent on the family member. And if you want to achieve the maximum results, you need to thrombolize the patient as early as possible. There is no way you can waste the time. And that's what this registry shows. This is the HICS registry. This slide explains my talk. This slide is one of the best slides which explains what is the importance of the timing in a stroke management, offering them the thrombolytic therapy. This is the HICS registry, almost the 1600 patients of this when they studied. What they found very interesting, that those patients who are coming within 1 hour, they are maximally thrombolized, but after 1 hour. And those patients who are coming after the 1 hour, they are in less number, but they are thrombolizing within 1 hour. So please don't waste the time. This slide gives you the time that if the patient comes within 20 minutes, thrombolize within next 20 minutes. You should not say that there is a lot of time is available, I can take a decision, I can take the better decision. No, this registry is an eye-opener for everyone. This is the 1600 patients data, which suggests that doctor who have more time take more time, but the sooner thrombolysis is initiated with the greater benefit if they come late. I think That's we need to improve. If we talk about the outcome, how to improve the outcome in a stroke thrombolysis, we have to target this area. Those who are coming within 1 hour, they should be get thrombolysis within 1 hour. Otherwise, we are not getting that benefit what we are intended to get benefit from the thrombolysis. And sooner the onset to treatment, lesser will be the ICS, because one of the major complications of the thrombolytic therapy and the relatives will be of concern along with us will be the thrombolytic complication. And if there is a thrombolytic complication, thrombolysis complication, there is no major or specific treatment is available. So please, so if you are thrombolizing within 90 minutes, the chances of the intracranial hemorrhage will be less. Overall hemorrhage percentage is 2.5 to 3%. But if you thrombolyze with 90%, it will further drop down. So it is better for your patient. If there is no complication post thrombolysis, your patient will recover fast. They will move fast out of the ICU. They will move fast out of the stroke unit, and they might be discharged earlier. So it is directly related with the outcome of the stroke. And when we are managing the patient, at least we should know which patient has the chances of the more bleeding. Where from the history you can judge this patient is likely to be landed with the post thrombolysis complication. If there is a longer door to needle time, then the chances of the hemorrhage complication are more. So stroke severity is more, like NIH score is more than 12, 15, then chances of hemorrhage are more. Advanced age is more than 80, then chances might be more. History of the uncontrolled diabetes or elevated blood pressure or the cardiac failure. So these are not contraindication. Please don't take it in other way. These are not contraindication for thrombolysis, but you should be quite careful. Discuss with the family in detail, explain them. Definitely there is an advantage with the thrombolytic therapy, but there is some chance of more chance of the thrombolysis, the post thrombolysis complication in this patient. Take them in a confidence and go ahead with the thrombolysis. And that's what the same Lancet article says about the mortality. The mortality will be possibly more if you are delaying the treatment. If you delay after the 90 minutes, then you are going towards the more and more complications and might be the less benefits and the more mortality. And the last part, very important part, is now stroke treatment is where you are evolving. This starts with the NIMS and the HICS in 1995, where the thrombolysis time was 3 hours, then we extended to the 4.5 hours, then now we are having the concept of the time is the brain versus tissue is the brain. So no doubt time is the brain. We should thrombolyze the patient within 60 minutes whenever the possible. But unfortunately, patient comes late because of the whatever the problems we discussed. Then don't defer them from the thrombolysis. The tissue in the brain is still debatable. And if you see this slide displays the very nicely the overall evaluation of the timelines for the thrombolysis. Like NIMS and the HICS in 1995, 3 hours was your window period. We gone up to the 4.5 hours after the HICS 2 in 2008. Then 6 hours after the Hermes metastasis with the mechanical thrombectomy. Then 9 hours with the extend trial I will discuss. And then a wake-up stroke, there is no timeline. If you do your studies, MRI studies, you can find still eligible candidate. Diffuse and the Dawn, these two trials extended the thrombolysis timing up to 16 to 24 hours in very selected patients. And then witness trial up to 24 hours. And now we are coming to the more than 24 hours. But again, please, you have a time or you can go up to the 24 hours. That's why don't waste your time. If you want to be the better outcome in a stroke patient with the less complication, you need to thrombolyze them as early as possible or offer the treatment as early as possible. And these are the trials in favor of the endovascular treatment. The window period is up to 6 hours, which is the standard. But you may go up to the 16 hours to 24 hours. And your number treated will drop down if you go offer this treatment to your stroke patients. And this is what I was talking about, the diffusion mismatch, diffusion flare mismatch trial. It was published in 2018 in the New England Journal. And this trial is like a last seen well. If suppose the patient wake up from the sleep and he don't know when he developed the weakness, so no one knows when he was last seen well, then you do the complete MRI study from the diffusion to the flare. if there is an infarct on a diffusion, and if there is no infarct appear on a flare, that means still patient is within 4.5, and you can offer him the thrombolysis and the next treatment. The moment there is an infarct on the diffusion and there is an infarct on the flare, that means he crossed that 4.5 hours window. So he is probably not the ideal candidate for the thrombolysis. You can go for the further studies to just evaluate whether he is fit for the interventions up to 24 hours. So this gives you the major breakthrough in a stroke management. Those patients who are unfortunately coming in a late, those patients who are unfortunately don't know that their last seen well timing, you can go ahead with the diffusion and flare images, and this mismatch will give us a better idea about whether these patients can be still thrombolized and give a chance of improvement in terms of the improving the morbidity and mortality. This was the extend trial after the back-to-back from 2018-2019. They come up with the further extension of the stroke intervention, and this was based on the perfusion scan. So if suppose patient comes after the 4.5 hours, and within 9 hours you can do the CT perfusion or MRI perfusion study and find out the infusions infarct size and the rest of the calculations, will give us an idea whether still you can go ahead with the endovascular interventions and get some benefit in a stroke patients. These two landmark trials change the whole perspective of stroke management, and that's what we discuss again, the debate of the tissue time versus brain, and the tissue and the brain. So here you want to salvage the brain. So these two trials are Dawn and Diffuse, which extended your timelines to 16 hours and 24 hours. And if you see, they are based on the infarct size and your NHS score. So if there's a clinico-radiological mismatch and still you are in that particular indication of the thrombectomy, you can go ahead with that, and you may get benefit in certain patients. But again, this is very selected. These things should be go in a facility where all these imaging facilities, advanced imaging facilities like CT perfusion, MRI perfusions are available to measure the core size, infarct volume, and then we can have the expert neurological opinion, and you can go ahead with the endovascular treatment. So again, these are the things which are added into improving the outcome in the stroke. And now, not the last but the least is now we are trying to go beyond 24 hours. This was the Italian registry which suggests that even in very selected patients where the patient comes after the 24 hours, you do the CT perfusion mismatch study, see the infarct size, and you can still offer them the intervention. And they achieve almost 76% of the patients improvement, or recanalization rates were 76.5%, but at the cost of the fatality of 26.5%. But again, these are very selected patients where the whole team is available and the concept of the advanced neurointervention is available with the more expert. But that's what we are trying to achieve more and more in a ischemic stroke, not limiting to the 4.5 hours or 9 hours or 16 hours or 24 hours. Now we are trying to go beyond 24 hours. But again, please don't waste your time, because there is time is available. You have to have as early as possible, you have to thrombolize the patient. Last few slides, the benefit of the stroke unit. No doubt the stroke unit have changed the outcome. It is not only your thrombolysis or your endovascular treatment offers the better results. Post thrombectomy or post thrombolysis, you need to have the stroke units which can manage the blood pressure, sugar, your seizure management, your nutrition management, duty prophylaxis, and then earlier deterioration. Somebody need to pick up the earlier neurodeterioration, and it's clearly evidenced decade ago that the stroke units can improve your death, not only the morbidity, or also the mortality also. And that's what this slide is showing, the benefit of the stroke unit in all age group, both genders, and all severities like a mild, moderate, severe, and also the type, whether it is a ischemic stroke or whether it is hemorrhagic stroke, gives the benefit in terms of the better outcome in stroke management. So to summarize, the key variables that likely influence the post-stroke outcome based on the current understanding: before thrombolysis, after thrombolysis. If the before thrombolysis and EVT age will change the outcome. Pre-morbid function test may, like the patient's modified ANSI score, if it is low on admission, it may be the poor outcome. Stroke severity, if it is more the severe, like the moderate to severe, will have the bad outcome. Time from the onset, if they know, they don't know, if it is a delayed presentation. Ischemic changes on the imaging, that means the scoring, if they are more severe, the prognosis will be the bad. Presence and site of the vessel occlusion also gives you the idea about the prognostication of the stroke and the stroke outcome and the potential neuroprotective agents. So these are the before thrombolysis and post thrombolysis or the EVT imaging of the recanalization time, again door to needle time or door to balloon time, quality of the recanalization, then intracranial adverse events, that means the what complication happens post therapy, recurrent stroke, malignant cerebral edema, where the decompression connectomy will come into the picture. Extracranial adverse events will also add, like a post thrombolysis infection pneumonia, where the stroke unit will play a major important role to prevent all this complication and improve the outcome. And socioeconomic factors like family support, social support, everything, if you club together from the symptom to the stroke unit and to the ward, everything plays an important role in improving the outcome in the stroke management. So, to summarize my talk, I just try to summarize in one slide regarding the effective strategy to improve the outcome in acute ischemic stroke. Is the first thing is the public awareness. Still, we are very poor in this public awareness. We need to facilitate those campaigns to create awareness, like a fast. If anyone comes across the facial drooping or arm weakness or swelling of the please rush to your nearby stroke radio hospital. Then we need to work on the pre-hospital care in terms of the stroke ambulance if possible, or our EMS guys should be trained to receive those stroke patients and do certain basic NHS scoring, sugar, BP management in ambulance, and inform to the your receiving center that we are coming, so that they will be ready, and your response time will be the better, and you will avoid the delay in offering the treatment. Then one should know the stroke radio hospitals in nearby areas, so stroke network. Prioritizing these patients, when they reach to the hospital, they should be prioritized to the stroke code, and they should be moved fast and reach to your desired goal of the door to needle time less than 60 minutes. Act fast with the thrombolysis as early as possible. Already I told you that if the patient reaches within 20 minutes, he should be thrombolized within the next 20 minutes. To avoid delays in the thrombolysis, you have a time, that's why don't delay your thrombolysis for the those deserving patient. And then multidisciplinary stroke teams, like if the needed, they can go for the stroke intervention up to 24 hours or now beyond 24 hours. So earlier the treatment is the major factor which improves the outcome in acute ischemic stroke. Thank you.
Thank you so much, sir. Now we would head up to the lunch session. It would be around 20 minutes and we would be back by 1:15 p.m. Thank you.
is often provided in busy clinical scenarios where lives are at stake. Decisions are made in a rush. Reports are analyzed on the go. This is where we step in. We search for innovative solutions across clinical scenarios. By rebuilding connections between people, device, space,
Can we start the session, sir? Hello?
Yes, Sampath, please go ahead.
Sir. Welcome back after the lunch. Now we shall start with the next session. Topic is, when do I use steroids in my ICU? And the speaker, Dr. K. Subbareddy, sir, Senior Consultant and Head Critical Care Department and Medical Director, Apollo Health City, Hyderabad.
Yeah,
Over to
just
you,
Sampath, this is an unplugged session, so there will not be any PPTs.
Sir, okay.
Okay.
Thank you, sir.
Vedam sir, Dr. Ghanshyam, and entire HICS team for involving me in 8th edition of HICS. And this is a very successful conference in the country. And I'm sure this time also a lot of delegates are interested, and then they're watching HICS videos. Today, my topic is about steroids. When do I use steroids in the intensive care unit? Very interesting topic. And there are no slides. It is extempore talk. And please bear with me. And if you have any doubts, you can put it in the chat box. Steroids are very commonly misused drugs in the intensive unit. Without knowing proper evidence, we tried steroids in the drug chart. And instead of knowing a lot of side effects about steroids, we still sometimes, when you don't have the clear diagnosis and the patients are not improving, we try to use steroids. So to start, steroids are by the adrenal gland. Adrenal cortex basically these hormones are secreted corticoids. The mineralocorticoid mainly helps in water and electrolyte balance, and then the glucocorticoids, they help in anti-inflammatory action, immunosuppressive action, and then they have metabolic effects. So this Society of Critical Care Medicine and European Society of Intensive Care Medicine task force, they have given a word for the adrenal insufficiency, that is CIRC, that is corticosteroid deficiency in the critical illness related corticosteroid insufficiency. And they have given, this task force has given guidelines to diagnose CIRC and then how to manage CIRC. This critical illness related corticosteroid insufficiency quite commonly seen in septic shock patients, around 50% of the septic shock patients. And then we see in patients with HIV and critical, we see very commonly more than 70 to 80% of the people, and then these patients will require some steroid supplementation. And then we see in polytrauma patients, in traumatic brain injury patients, around 50% of the patients are associated with CIRC. So, and to diagnose CIRC, previously around 10 years when I started, when I was working in intensive care unit, so that time we used to do this ACTH stimulation test to see whether the patients are steroid responsive or steroids non-responsive. So the task force that time has given recommendations to do this co-syntropin or ACTH stimulation test. So we used to give around 250 micrograms of co-syntropin or ACTH and then see the response. If it is more than, and then when you measure the serum cortisols 30 minutes, 45 minutes, 60 minutes. If it is more than 20 micrograms per deciliter, then they are responders. They are responding to ACTH. If it is less than 10 micrograms per deciliter, then they are the non-responders. That's how you can find out the relative adrenal insufficiency. And otherwise, if you check random cortisols, and then if the random cortisols are less than 10 micrograms per deciliter at any given point of time, and then again, we can consider this as relative adrenal insufficiency. And then this relative adrenal insufficiency is quite commonly associated in a lot of critical care scenarios. Like we see commonly in the septic shock patients, we see in burns patients, and then we see very commonly in ARDS patients, and we see in severe acute bacterial pneumonia patients, major trauma, polytrauma patients, and then we see in bacterial meningitis. And then when you have a patient with a non-specific shock patients. Now we don't know the reason for shock, and then they're not responding, and then they're also associated with adrenal insufficiency. And then we see patients who are going on cardiopulmonary bypass. We see relative adrenal insufficiency in patients with cardiogenic shock, burns patients, and then even the post-cardiac arrest patients. So we will see the role of steroids in different scenarios, like how do you use, what are the indications of corticosteroids in the respiratory critical care, and what is the indication in the neurocritical care and the medical intensive care unit. So primarily, if you look at the respiratory critical care, that is mainly the ARDS, the most common respiratory problem what we face in our intensive care unit, and which is very challenging for intensivists, is ARDS management. And a lot of lectures about ARDS management, and then mechanical ventilation. How do you use mechanical ventilation? And how do you do recruitments? How do you manage the refractory hypoxemia? We never talk about steroids, and then the role of steroids, evidence of steroids in acute respiratory distress syndrome. And today I'm going to discuss the role of steroids in ARDS. So we have a latest study in 2020, the Lancet Spanish group published one good study, that is the role of dexamethasone in the treatment of acute respiratory distress syndrome. This is a multi-center randomized controlled trial, and they have done in 17 intensive care units, and they included patients with moderate to severe ARDS when the P/F ratio less than 200, and FiO2 requirement more than 0.5, and the PEEP requirement more than or equal to 10 for more than 24 hours, around 24 hours. They have given steroids in these patients. We know the ARDS, acute respiratory distress syndrome, we see intense systemic inflammatory response, and then we see inflammatory exudates leading into ARDS. So in this trial, they use dexamethasone. So we use dexamethasone even in COVID-19. I'll come to that later. Dexamethasone 20 milligrams they used in one arm. That is equal to 106 milligrams of methylprednisolone. And then they used it for 5 days, from day 1 to day 5. And from after 5 days, they decreased this to 10 milligrams once daily. That is equal to around 53 milligrams of methylprednisolone from they used up to 10 days, day 6 to day 10. In this study, they found significant difference in the ventilator-free days. It is a very positive trial. And then they found significant difference in the ventilator-free days. And then 60-day mortality is less in the dexamethasone group. And then serious adverse events, there's no much difference between two groups. And then there is, if you look at the complications, the increase in blood sugars, hyperglycemia, which is almost same in both the groups. And then new onset infections are also same in both the groups. And then the prone ventilation requirement was much lesser in patients with high dose dexamethasone, that is 20 milligrams when they used. And then the SOFA scores were better. And then the P/F ratio was getting better. So it is largely a positive trial, and then it showed benefit when you give high dose dexamethasone. And then even the patients who are going into multi-organ failure was less in the dexamethasone group, and there is less bias. Then it is one of the largest randomized control trials they have done in ARDS when it comes to steroids. And then next, we all know the MEDURI trial. Whenever we talk about steroids and ARDS, we talk about MEDURI trial. This was published in Chest Journal in 2007. So this is again a randomized control trial, the role of methylprednisolone infusion in any severe ARDS. Results of randomized control trial, they have done in nearly 5 hospital ICUs, and then they have taken nearly 90 patients, and the methylprednisolone was used within 72 hours of ARDS, and 66% of the patients were having sepsis in this study. And the primary endpoints were decrease in lung injury score, and then extubation within 7 days. So in the steroid, how much steroid they use? This study, MEDURI, methylprednisolone, 1 milligram per kg per day. They used it for 28 days, and then other arm is placebo. So in the methylprednisolone group, there is decrease in lung injury score, and then there is more patients they extubated around 53% of the patients, they extubated in the methylprednisolone group, whereas in the placebo, it is only 25%. And then there is a huge difference in mortality. There is significant decrease in the mortality in the methylprednisolone group, and ICU length of stay is less, and ventilator-free days are less, and then the infections are also not more in the methylprednisolone group when compared to the placebo. This is a very positive trial, but in the same trial, and very positive trial. So again, in the ARTS network, there is a ARTS network study about steroids in ARDS. This was published in NAGM in 2006. Again, this is efficacy and safety of corticosteroids in persistent acute respiratory syndrome. So what happens if we use steroids for longer durations? In this study, again, this is a randomized controlled trial. The primary endpoint is 60-day mortality, and then they looked at the secondary endpoint as the ventilator-free days and the organ failure, improvement in the organ function scores. So they have taken nearly 180 patients and then divided into methylprednisolone group and the placebo group. In this study, they have used high-dose methylprednisolone. In the MEDURI trial, they used 1 milligram per kg per day. In this study, they gave 2 milligrams per kg bolus, and then they have given 0.5 milligrams per kg 6th hourly for 14 days. That means if they have around 60 kg person, you are giving 30 milligrams methylprednisolone 6th hourly and for 14 days. And then later, they decrease it to 0.5 milligrams per kg 12th hourly, from 6th hourly to 12th hourly for next 7 days, and then they tapered it off. So in this study, they did not find much outcome benefits when you start high-dose methylprednisolone. But if you start methylprednisolone later, after 10 days or after 14 days, they found there is increase in mortality. So otherwise, there is no difference between 60-day mortality, there's no difference between 180-day mortality. And when they used corticosteroids in the later stage, that is, we know when there is a fibroproliferative stage, if we use beyond that, when the patient goes into fibroproliferative stage, there is no role of steroids and the mortality is increasing. So, if you look at the meta-analysis of cohort studies, a lot of they have taken nearly 5 cohort studies, and then they have taken the meta-analysis of, they have done the meta-analysis of control trials. Again, there is no difference in the mortality. And in both cohort studies and the randomized control trials, and then when they did meta-regression analysis, they found mortality benefit in the acute respiratory distress syndrome when they used steroids. So to conclude, the role of steroid in acute respiratory distress syndrome, definitely there is no role. If you give steroids at the later stage, the mortality is increasing. But if you give steroids in the early time, there is a possible benefit according to the new trials, like a Spanish trial. There is the possible benefit of corticosteroids in ARDS. Coming to the next common disease in respiratory critical care, that is severe acute bacterial pneumonia. This is also similar to ARDS. Severe acute bacterial pneumonia patient, there is intense inflammation, CRP is high. In these patients, when you give steroids, we see there is mortality benefit. There's a good Cochrane review they have done in around 2,000 patients, and then of 17 randomized control 2,200 patients, there is significantly reduced mortality and morbidity when you use steroids in the severe community acquired pneumonia. We know there is, in these patients, there is, whenever there is high systemic inflammatory response, the CRP is more than 50 on ventilator, or definitely when the patient is in sepsis and vasopressor, there is benefit when you use steroids. So that is almost similar to ARDS. We see benefit in severe bacterial pneumonia. Coming to viral pneumonias, we have seen COVID-19 patients, and we all know how to use steroids. In the recovery trial, it's one of the largest trials. They have used dexamethasone 6 milligrams in around 3,000 patients, and then they have seen mortality benefit in COVID-19. But when same thing, when we applied in H1N1 pneumonia or SARS, we didn't find mortality benefit. In contrary, mortality was more H1N1 group when we use steroids. The reason they were telling is because of viral shedding. So in COVID-19, the viral shedding is limited to first few days. In H1N1 and SARS, it will continue. So the steroids were increasing mortality in COVID-19 patients. So coming to severe after pneumonia, you see again in the respiratory critical care, chronic obstructive pulmonary disease, acute exacerbation of the COPD. When you see severe COPD exacerbation in the intensive care unit, we know we have to give IV steroids and then we have to give inhalational steroids. So when it comes to IV corticosteroids, which are helpful in the treatment of severe exacerbations, so corticosteroids, in the trials, in the studies, they found there is improvement in FEV1, and then there is improvement in the hypoxemia, and then the recovery period is also less, and then the ICU length of stay is less, and the cost of admissions are also less, and then these recurrent relapses also you can prevent. So what is the dose? We give 125 milligrams of methylprednisolone in severe exacerbation 6 hourly for only 3 days, and decrease it to 60 milligrams per day for 4 days, and decrease it to 40 milligrams for 4 days, and decrease further to 20 milligrams 4 days, and then you stop. And same thing, same doses we can apply in the bronchial asthma exacerbation. We give both intravenous and inhalational steroids, and then the patients will get better. Hypoxemia will settle, and then the ICU length of stay also will come down. Coming to pneumocystis jirovecii pneumonia. So whenever there is hypoxia, pneumocystis pneumonia, there is a role for steroids. We can give prednisolone 40 milligrams 12th hourly, and then we see benefit. So various types of pneumonias like cryptogenic organizing pneumonia, there is a benefit when you give steroids. And in lot of other conditions in pulmonary critical care, we use steroids. Like we see different types of pneumonia. If you look at the ILD, we know we have different types of ILD. We have usual interstitial pneumonia, generally corticosteroids. In the long-term treatment, they're not helpful. You have to go for antifibrotic medications like we all used in COVID-19, pirfenidone, nintedanib. But in acute exacerbation of usual interstitial pneumonia, you need to give steroids to control the acute exacerbation. And non-specific interstitial pneumonia. So these people, they respond very well with your corticosteroids. Again, there is a huge role in the NSIP. And then when it comes to pulmonary sarcoidosis, short-term steroids definitely improves outcome in the pulmonary sarcoidosis. Pulmonary tuberculosis, definitely there is no role for corticosteroids. But if you see in the pulmonary fibrosis, again, you have to give very high dose like pulse therapy of steroids, 1 gram steroid for 3 to 5 days. And then acute hypersensitive pneumonitis, acute eosinophilic pneumonia, or chronic eosinophilic pneumonia. So we give steroids, and then they are useful. And there is one more entity called drug-induced lung injury. So we see this drug-induced lung injury in patients with anti-epileptics. We see very rarely with anti-epileptics, but only with the chemotherapy drugs. And then we see this with sometimes we see with even antibiotics like minocycline, nitrofurantoin can cause drug-induced lung injury. And these patients, you have to give little higher doses of steroids to control this lung injury. We give around 500 milligrams per day, 250 milligrams per day. It is very, very tricky. You have a patient, chemotherapy patient, who is deteriorating. You don't know whether it is bacterial infection or it is drug-induced lung injury. Unless you diagnose properly, giving these corticosteroids, again, if it is infection related, then the mortality will increase significantly. So if you diagnose properly what kind of pneumonia it is, then there is a role for steroids, and these patients recover faster. So this is the role of corticosteroids in respiratory critical care. Coming to the neurocritical care, we use steroids very, very commonly in the neurocritical care. In the first, the traumatic brain injury, absolutely there is no role for steroid in traumatic brain injury. A large study called Crash 1 study, they have taken nearly 10,000 patients, and then the mortality was increasing. So there is a level 1 recommendation from Brain Trauma Foundation guidelines that we should never use steroids in traumatic brain injury. But if the patient has optic nerve injury, traumatic optic nerve injury, and lot of people even give referrals, and then the people will come and give corticosteroids at very high dose. But the ONTT trial, that optic nerve treatment trial, showed there is no benefit of corticosteroids even in traumatic optic neuropathy. But in the steroid group in this trial, they found rapid visual recovery. The patient's visual recovery within 2 weeks is very rapid in corticosteroid group, but in both the groups, patients' vision recovered. So there's no role for steroids. And then there is one more trial called International Optic Nerve Study trial. In this trial also, they did not find any benefit of corticosteroids. Coming to the non-penetrating spinal cord injury, and then when we all remember NASIS trial, and the NASIS 2 trial and NASIS 3 trial, they used a very high dose of methylprednisolone. In NASIS 2 trial, when they are getting less than 8 hours, they were giving again non-penetrating spinal cord injury, and then they were giving 30 milligrams per kg bolus, and then they were giving infusion of 5.4 milligrams per kg per hour for 23 hours when you get a patient within 8 hours, and after 8 hours they were not giving steroids. But they have not seen much benefit. There is a motor improvement, but there's no, at the end of the day, there is no functional recovery and good functional motor recovery. But in the patients with, again, they have done NASIS 3 trial, they compared again what happens if you give within 3 hours. And then they divided into 3 groups. Within 3 hours, 3 to 8 hours, and then there is one more group called tirilagid group. They use a tirilagid. So all these patients, they received 30 milligrams per kg bolus. But if the patient comes within 3 hours, they were giving methylprednisolone infusion only for 23 hours. In 3 to 8 hours group, they were extending this up to 48 hours. But they did not find any benefit, and the slight motor Asia scale improvement. But when you look at the wound infections were more, and then the hyperglycemia was more, and more patients were developing infections and going into sepsis. That's why there's no role for high dose corticosteroids, methylprednisolone, even in non-penetrating spinal cord injury. So American Association of the Neurosurgeons, so they do not recommend corticosteroids in spinal cord injury, and Canadian Association physicians, according to their guidelines, corticosteroids is one option, but it is not the standard of care. And again, if you see the consortium of spinal cord injury, they say there's no clinical evidence for giving high dose corticosteroids in patients with spinal cord injury. In various other neurological conditions, like when you have autoimmune encephalitis, or if you have acute disseminated encephalomyelitis, we give very high dose pulse therapy. In neuromyelitis optica, Devick's disease, we give 1 gram methylprednisolone for 3 to 5 days in these patients. And in myasthenia gravis, again, if you give high dose steroids, they cause myopathy, and then the patients will worsen. So we had to give very small dose, 40 to 60 milligrams methylprednisolone. Very carefully we need to give. And we know bacterial meningitis, there is a role for steroids. Dexamethasone 0.5 in bacterial meningitis, TB meningitis, cerebral edema, we use only dexamethasone, not methylprednisolone. In bacterial meningitis, we give 0.15 milligram per kg, like 6th hourly, and then we give just prior, around 10 to 20 minutes prior giving antibiotics. In tuberculous meningitis, in grade 2 and grade 3, definitely there is a role for steroids, dexamethasone, and then we give dexamethasone a very little high dose, 0.4 milligrams per kg first week, 0.3 milligrams per kg second week, 0.2 milligrams per kg third week, and 0.1 milligram per kg fourth week. So when it comes to cerebral edema, definitely there is no role of steroids in cytotoxic cerebral edema, where we see in traumatic brain injury. But in patients with vasogenic cerebral edema, there is a role for dexamethasone, and then we give 10 milligrams IV stat, and then we give 4 milligrams 6th hourly. And And this we see in patients with brain tumors very commonly. And we give steroids in other conditions like thyroid storm, endocrine disorders like thyroid storm, hydrocortisone we give around 300 milligrams IV, and 100 milligrams we give 8 hourly. In myxedema, we give around 100 milligrams IV, 8 hourly. And then in brain dead patients, as a hormone replacement, we have to give, along with the hormone replacement, other hormone replacement like thyroxine, you need to give methylprednisolone at little higher doses, 15 milligrams per kg IV we need to give in patients with brain, brain death patient, brainstem death. So again, patients like transverse myelitis, we give pulse dose like 1 gram methylprednisolone 3 to 5 days. So this is about the role of steroids in neurocritical care. And coming to septic shock, sepsis and septic shock, which is very, very common diagnosis in the medical intensive care unit, it is always controversy. And then if you look at the guidelines recommend steroids, but if you look at the studies, no study will show, very few studies are showing mortality benefit. There's equal number of studies showing no mortality benefit and then mortality benefit. So, and then if you look at the surviving sepsis guidelines, there is definitely recommendation for giving corticosteroids, hydrocortisone, 200 milligrams per day, 50 milligrams 6 hourly, intermittently, or infusion. So if you look at the evidence of steroids in septic shock, so very initial studies like 1976, the Schumer et al, they gave supraphysiological doses of methylprednisolone, that is 30 milligrams of methylprednisolone per kg for patients with septic shock, and then there is a significant difference between the placebo and high dose steroids. There is a mortality benefit. And then in 2002, Anane et al, they published steroid study in the septic shock. It's a randomized controlled trial, and then they have given, they have seen both ACTH responders and non-responders. So in they gave both hydrocortisone and fludrocortisone, and then they found mortality benefit in the Anane trial. Again, in 1980, if you look at the negative studies, 1980, in one study, they gave supraphysiological doses like 30 milligrams per kg methylprednisolone, but they did not find any mortality benefit. In this journey, they did a prospective observational study, and then with ACTH responders, non-responders, and then whenever there is, by doing ACTH stimulation test, and then whenever there is a relative adrenal insufficiency, they replaced with steroids, and then they did better. In mortality, they did meta-analysis. This was published in 1995, and again, COITUS trial in 2010, again they combined hydrocortisone with fludrocortisone, and then in this study there's no survival benefit. And then we got recently the large trial, that is adrenal trial. Dr. Venkatesh also participated. The Venkatesh et al did this trial, published in New England Journal of Medicine. This is a double-blind parallel RCT, randomized control trial. They've taken large number of patients, 3,800 patients with septic shock who are on mechanical ventilation, and then the other group is the placebo. And in this group, they wanted to check the mortality, the primary endpoint, 60-day mortality. They have taken both surgical and medical ICU patients. 69 ICUs participated. They have done this trial mainly in Australia and New Zealand, in Denmark and Saudi Arabia. And they have taken patients who are on vasopressors, on mechanical ventilation for more than 4 hours with the SVP to maintain SVP more than 90, to maintain MAP more than 60 by using vasopressors. They excluded patients who are on corticosteroids already, patients who received etomidate, or the malaria patients, or very sick patient where like there is imminent death, and they have seen bowel ischemias, and then they have seen abdominal wall dehiscence, they have seen myopathies, they find not maintenance and find any mechanical ventilator and other replacement therapy and new backgrounds and non-even. In the patients with septic shock, when they used hydrocortisone 200 milligrams, and then it did not decrease 60-day or 90-day mortality, but shock reversal was better in the steroid group, and then the mechanical ventilation free days is slightly better, and then the ICU length of stay is also better in corticosteroid group when compared to placebo. And the strengths of this study, adrenal trial, that they've taken large number of patients, nearly 3,800 patients, and then when compared to other studies like Ananas study, they have taken around 300 patients. Corticus study, they have taken 500 patients. And then another positive trial, very positive trial, is approach trial. And then they divided into 3 arms, all the patients. One is hydrocortisone and the hydrocortisone fluorocortisone group. And then they added even ditricogen alpha, that is activated protein C. And then after some time, when the activated protein C was increasing mortality, and then it has gone out of the guidelines, they stopped that arm, and then they continued with hydrocortisone and fluorocortisone, and then hydrocortisone, and then they have seen mortality benefit with hydrocortisone plus fluorocortisone in approach trial. So this is a positive trial, and then they found mortality benefit. And the recent trial, which got published in the Lancet, I think this is an American study, and there again they divided large number of patients. They've taken nearly 10,000 patients. They divided into hydrocortisone and hydrocortisone plus fluorocortisone, and they have seen mortality benefit, and then the vasopressor shock reversal is better, and ICU length of stay is better. It is a huge positive trial, came recently and got published last month from the they have taken all the retrospective data and then they published. So now the evidence is moving towards hydrocortisone plus fluorocortisone, adding fluorocortisone 50 milligrams orally along with hydrocortisone 200 milligrams per day, according to the new trials. One is approach trial, and the latest trial published last month in the Lancet. So this is about the septic shock. In other conditions like burns, there is absolutely no role for steroids. It increases mortality. In polytrauma, there is no role for mortality, no role for steroids, because this again, it may increase mortality. But one small study showed decrease in mortality, but this study strength number of patients are less. Definitely, there is no role for steroids in polytrauma at this presently. And then dengue patients, again, steroids, there are meta-analysis from Thailand, and then there is a large Vietnamese study. There is no benefit of giving steroids in patients with dengue shock syndrome or patients with hemorrhagic dengue patient. There is no improvement in thrombocytopenia, blood and blood products. Usage is also did not change. In anaphylaxis, we know the main drug is epinephrine, but in steroids we give to in anaphylaxis so that it will not recur again, they will not go into complications or shock. So the anaphylaxis, we use steroids, but again there is no major evidence to steroids are really helpful. In one condition where steroids are really useful is post-extubation stridor. But routinely, we don't give steroids for all the patients. But according to the evidence, if you look at the evidence, and then if you look at one meta-analysis of patients steroids for post-extubation stridor, the patients who are at high risk, the patient who required multiple attempts for intubation, where there is airway trauma, some trauma patients where you think this patient is going to have more stridor or extubation failure. In those patients, there is significant reduction in post-extubation stridor and reintubations, but significantly less. But you need to give steroids at least 4 hours before extubation to see that benefit. Otherwise, it is not useful if you give just before extubation. So this is the role of steroids in to prevent post-extubation stridor. And then I did not cover a few topics like the time is not sufficient, and like autoimmune hemolytic anemia, there is a role for steroids. For managing hypercalcemia, there is a role for steroid. And then we give steroids in the transplant units to manage transplant rejection. So these are other indications. And then we use in Crohn's disease in steroids in various patients to the intensive unit. Shall I take that question? There is one question in the chat box by Dhruv Chaudhary, sir.
Yes, please go ahead. But please read the question as well, if you can.
Yeah, the question is, what is the role of steroids in traumatic brain injury? Steroids for delayed cerebral edema, perilesional edema, post-traumatic brain injury. Which steroid and how long to give? And steroids for delayed cerebral edema in perilesional edema. Okay. In traumatic brain injury, there is no role for steroids. We know the steroids will increase mortality, but still in some patients, in some subset of patients where you have temporal lobe lesions, contusion, it is very tricky. And it is not like always, it is not cytotoxic edema. Sometimes, as Dhruv Chaudhary sir said, in the delayed cerebral edema, perilesional edema, sometimes you will have both vasogenic edema and cytotoxic. There, the steroids may be helpful, and the dose is dexamethasone. We use dexamethasone in mainly perilesional tumor edema, brain tumor edema. There, when you are treating tumor edema, the dose is 0.4 milligrams per kg. We give around 20 to 24 milligrams in a day, 8 milligrams 8th hourly, or 6 milligrams like 4th hourly we can give, and then till the edema comes down, and then slowly we have to taper and stop. But long-term steroids are not good. And then sometimes we see edema in the scans, but the patient is clinically fine. In those patients, we can avoid steroids. Dexamethasone mainly we use because long half-life, less mineralocorticoid effect, and then less psychogenicity we get with dexamethasone. That's why that is preferred in treating late cerebral edema.
Thank you so much, Subbareddy sir. With this, we will move to the next topic. Next topic is disease-specific fluid therapy a myth? And this would be taken up by Dr. Roop Kishan sir. He's a retired consultant, intensive care medicine, and retired honorable lecturer, translational medicine, neuroscience and anesthesia from Salford Royal NHS Trust, Manchester. Over to you, sir.
Worthy chairperson, ladies and gentlemen, friends and acquaintances, all greetings from Manchester in the United Kingdom. At the outset, I must express my gratitude to Dr. Srinivas, Dr. Ghanshyam, and the organizers of HICS2023 for inviting me to give this extempore talk. I don't know why they invited me, but here we are. I am still grateful for the honor. The topic that's been assigned to me is a question. And the question asks, is disease-specific fluid therapy a myth? A very simple answer to this complex question is no and yes, more of no, in the sense that no, disease-specific fluid therapy is not a myth. except in some instances, which I will hopefully point out. But the answer comes with a qualification. And the qualification is that we give fluid in disease situations. We only have a choice of just a few things, but we treat a variety of diseases. So let's get a little bit more into it. We've been using fluids for nearly 200 years now. It began with Thomas Latta of Leith, a small town near Edinburgh in Scotland, when in the December of 1831, he infused an alkalinated solution of sodium chloride into cholera victims with great success. Unfortunately, Thomas Latta died about 18 months after this, and his pioneering work was just forgotten. There was also a lot of opposition to it at that time. You must remember that he was trying to do something quite opposite to what was the current practice in those days, which was bloodletting. Yeah, that was the treatment for a lot of diseases. Latta was forgotten, Leith was forgotten. But Leith came back to be remembered for a completely different fluid. It's now part of Edinburgh City and also the headquarters of Scotch Malt Whisky Society. But I'm not going to talk about that fluid, we're going to talk about something else. Thomas Latta reported his findings in 1832, and nothing much seemed to have happened for the next 50 years when Sidney Ringer accidentally discovered his Ringer solution. Shortly after that, about 9 years later, Jartog Hamburger came up with his normal saline when he was working with red blood cells. And exactly 100 years after Thomas Latta's pioneering work, pioneering treatment, Alexis Hartmann came up with his Hartmann solution in 1932. We now have a whole lot. So that's the sort of short journey of fluids. We use them very often. We use them all the time. Come on, for God's sake, every hospitalized patient gets intravenous fluids at some point or other, which is what we mean by fluid therapy. It's not oral fluids, it is intravenous fluids. We do it all the time, we do it every day. And in this, it is easy to forget that fluids are drugs. They have their positive therapeutic effects because that's why we use them, otherwise we wouldn't use them. But they also have harmful effects which are dose dependent. And it is our responsibility, it behoves us that we not only prescribe fluids with care, but we also monitor the effect of these the fluids and prevent our patients from harm. Why do we use fluids? We use fluids for a variety of reasons, and the commonest I put to you is maintenance fluid therapy. It is giving fluids to people, patients who cannot take them by mouth for various reasons, which is a lot of our patients in ICU. And this is for maintenance of just hydration as well as electrolyte homeostasis. So we give them for maintaining electrolytes. We give them fluids, we use them as drug carriers, where drug compatibility is very important. Drug compatibility with the fluid is very important. We use them as intravenous nutrition, which may be disease specific, generally is a sort of a general thing. There is a specific use of albumin, for instance. We use it in cirrhosis, in paracentesis, in large volume paracentesis, in hepatorenal syndrome, and studies have shown that patients who are not hypoalbuminemic because of intermittent use of albumin, cirrhotic patients have a better mortality profile. And the last but not the least, we use fluids for resuscitation. In sepsis, trauma, all sorts of other conditions which cause a lot of dehydration. That's what we use the fluids for. What do we have? We have electrolytes, saline, which is 0.9% sodium chloride, as well as what we call balanced electrolyte solutions, Hartmann's, lactate Ringer, and of late plasma light, and stereofundin. All these are called balanced solutions because they are not like saline, which is quite different. Saline called normal saline, which is neither normal nor physiological. Along with that, we have colloids, as you all know, dextrans, gelatins, and starches. Dextrans have almost gone out of use. Gelatins are still lingering around and may well have some place, we don't know. Whereas starches came up with a promise. Unfortunately, the promise has not been lived. Right? Starches are said to be, and it has been shown by a lot of studies, especially the success study, that in septic patients, the starches cause a lot of problems, particularly increased mortality and acute kidney injury, needing increased renal replacement therapy. This has been proven by subsequent studies, including the latest CHEST study, where they did not show any difference in mortality, but the HICS group, the ones that received the third generation starch, pentaspan, 130 with substitution ratio of 0.4, still did cause increased requirement of RRT in patients. So right now, what's happened is that in 2014, the European Medicines Agency and its Therapeutic Vigilance Committee restricted the use and sale of starches and restricted its use in septic patients, burns, and other critically ill patients. And last year, in 2022, they have now banned the sale of starches, at least in Europe and in the United States. Also, it has happened, except under conditions of randomized controlled trials. Now, starches haven't completely died. It has been shown in many situations that when you use colloids, that you do actually require less fluid. Yes, that is there, but the mortality advantage hasn't been shown, as well as there has been a problem with kidney injury. But the starches haven't died. As I said, there are two trials going on at the moment, which are recruiting patients. One is the TET-HES, which is HES in trauma patients, as well as Phoenix trial, which is starches in perioperative period. We await the results. So, the question was disease-specific fluid therapy. Do we have disease-specific fluid therapy? Well, I did say yes, it was not a myth. But then I also said that we need to qualify the answer. Now, when Thomas Latta was using his fluid 200 years ago in cholera patient, was he treating cholera? Of course not. He was not. They knew it was infection. and it required specific therapy like antibiotics. The antibiotics didn't come on the market for another 110 years, 1942 to be exact. So what Thomas Luther was doing was actually treating a physiological disturbance caused by cholera. So he was treating cholera and saved patients, but he was not using a disease-specific therapy. I did say that fluids are drugs, and that's how we should treat them, but there is a difference. They are not specific drugs for specific diseases. Like we have antibiotics, we use to treat bacterial infections. We even have antibiotics for gram-positive bacteria, gram-negative bacteria, anaerobes, and a lot. We have antihypertensives to treat hypertension. We have hypoglycemics to treat diabetes. That's not how the fluids are. Fluids are adjunctive therapies. They are complementary therapies to various diseases, but are not specific therapies. So if we accept that there is no specific disease-specific fluid, but a condition-specific fluid, then we are all right. So the condition-specific fluid therapy is not a method, except there are exceptions. There are always exceptions that prove the rule. So before we get into the conditions as such, let's look at what we need to know certain things about fluid therapy when we give fluids to patients. We must try and remember three things about fluids. How, when we infuse fluids, how they affect the patient's physiology, pathophysiology. The best effect of fluid first is to improve the hemodynamics, improve the cardiac output, improve oxygen delivery to the tissue, stop anaerobic metabolism, and stop cell failure and organ failure. That's the primary objective of the fluids. While we are doing this, three things tend to happen, three major things. Depending on the composition of the fluid, there is an effect on the acid-base situation, at least in patients' blood. And this is best explained by Stewart approach. The common thing is that if we infuse saline, large quantities of saline, then there is a metabolic acidosis, erroneously called dilutional acidosis, hyperchloremic acidosis, dilutional hyperchloremic acidosis. It's not that at all. That's because people don't understand how the acid-base physiology works. Stewart explains this very well. According to Stewart, there are three independent variables that affect acid-base balance in the body. First one is carbon dioxide, and we all know what happens. CO2 goes up, the acidosis, CO2 goes down, it's acidosis. Second one is the difference between the strong cations and strong anions. Sodium, magnesium, potassium, they are cations. Chloride, sulfate, phosphate, lactate are anions. So the difference between the sum of cations and the sum of anions determines the pH. And this is what's called the strong ion difference. In practice, we only measure sodium and chloride because the others don't make difference. So if the rule of thumb is that sodium and chloride concentrations, relative concentrations, determine the pH. This third independent variable is the total weak acid, which in plasma is determined solely by albumin. So albumin is a weak acid. If it goes down as hypoalbuminemia, it causes mild but a reasonable metabolic alkalosis. So the end result is the effect of both. So the rule of thumb is SID narrows, the strong iron difference narrows, you get metabolic acidosis, strong iron difference widens, you get alkalosis. The second important thing we have to remember is the effect of chloride. And the number of studies have shown that the excess chloride does affect renal function. It may not affect mortality, but the renal function is affected. And the result is that there will be renal dysfunction, however you define it, and in certain groups of patients, there is increased requirement of renal replacement therapy. The third important factor we have to remember is that as we resuscitate the patients, we might over-resuscitate them and increase the total body fluid. And this is known as fluid creep. We have to take steps to avoid it because fluid creep does cause increased morbidity and mortality. So, having gone this far, now let's look at some of the conditions where we might have condition-specific fluid therapy. And the first thing where it is a myth comes to mind is bicarbonate for metabolic acidosis. It is a load of rubbish. All bicarbonate therapy does is actually it improves pH by widening strong iron difference and hides the metabolic acidosis, which is much like dressing a festering wound. It looks very nice, but the wound continues to be infected. So the pH gets better, everybody feels happy, but the acidosis is still there. The processes that cause acidosis are still there. Unfortunately, it's not gone away. There has been a trial called BICAR ICU trial recently that showed that bicarbonate infusion in acidosis reduced the need for RRT. Well, I really am not so sure because the indication for RRT in this study was the low bicarbonate and increased pH. So when you give sodium bicarbonate to these patients, you change that, and therefore there is no indication for RRT. I'm not sure what the investigators were thinking about. They were trying to prove a point, and I'm sorry, I'm not convinced. So I would say the best way to treat acidosis is to treat the patient and not use the bicarbonate. Okay, so that's the first myth. Second quasi-myth is the management of diabetic ketoacidosis. We have been told, and our brains have been stuffed with this notion that diabetic ketoacidosis, you can only use saline and not ringer lactate or in whatever form because there is lactic acidosis in diabetes. I'm sorry, I put it to you that the people who advocate that view do not actually understand what lactic acidosis is. But leave aside that. There have been a number of small number of studies where it's been shown that if you use balanced crystalloids, there is a quicker resolution of acidosis without increasing ketosis. The diabetic pundits have objected to use of balanced salt solution, saying it contains lactate and therefore worsens lactic acidosis nonsense. They have said that another objection is that lactated fluids are glycemic, inducing like increased blood sugar, but then we are giving insulin, so that's not a big problem. The third objection is that they may cause increased hyperkalemia because lactated ringer or Hartmann's contains 5 millimoles of potassium. That's another nonsense. If you give 5 millimoles of potassium to patients, the potassium isn't going to go up above that. Okay? And conversely, I would put it to these pundits that if you use saline, which then increases the acidosis, that will cause hyperkalemia. not the other way around. And there now have been quite a number of studies that have shown that there have been at least 2 studies to my knowledge which have shown plasmonite 148 does actually reduce the acidosis fairly rapidly. And the meta-analysis, I think it was published last year, meta-analysis of saline versus balanced electrolyte solutions in diabetic ketoacidosis has shown that there is a quicker resolution of the ketoacidosis without any other adverse effects. So that's that. Now, coming to sepsis, we all treat sepsis all the time. We are resuscitating patients. I don't need to tell you how to resuscitate a septic patient, but there are 1 or 2 points we have to sort of think about and remember. The recommended fluids are balanced electrolyte solutions and saline, yes. Colloids, starches were used till science came in our way and told us starches are bad. Yes, there is a fairly consistent signal showing that starches do actually have an adverse effect on sepsis as well as causing increased kidney injury. Somebody, a very good opinion leader in intensive care, recently sort of looked at the CHEST study, which showed that in starch group, in HICS group, there was a lesser incidence of kidney injury and risk, as defined by Aiken criteria. But there was, and so he picked on that and said there is less kidney injury. But what this gentleman forgot to mention, that there was an increased incidence of RRT in HICS group. So it's there. The Surviving Sepsis campaign says, yes, you use fluid, but in case you need to use excess fluid, then you should use albumin to resuscitate patients with sepsis, septic shock. What they don't do is define what is excess fluid. So it is left to the clinicians to decide that. Personally, I would use vasopressors early on, but I'll come to that in a minute. It is not very widely realized that it's only about 60% of septic patients are actually fluid responsive in the immediate start, in the beginning, within the first 6, 7, 8 hours. So if you give fluid to septic patient, they're not responding, go on choosing vasopressors. I have tried this very early on, about 30 odd years ago, and actually with great success. And I tried to publish this and could not publish those because there were also patients with trauma and hypovolemic patients who were not responding to large quantities of fluids, but they did respond with noradrenaline infusions. When I tried to publish it, they said, I thought if I published it, I would actually be the first one to patent the acronym RRR, Roop's Recipe for Rescue. But it did not happen. And it's now come to pass that, yes, you are encouraged to use vasopressors early in sepsis. And that is the latest guideline. And it just actually has better results. Trauma, European consensus, not guidelines, but European consensus opinion that's just been published in this year would suggest that they go on and on and on about all sorts of things. They have 39 recommendations, of which only 2 deal with fluids, which is use 1.5 liters of balanced fluid and hypotensive resuscitation, where you do not increase blood pressure beyond 60, 70 arterial pressure, systolic of about 80, before you actually control eating. So the algorithm, the ABC, the familiar algorithm ABC, in European parlance is now become C. ABC. C is the control of bleeding by either direct pressure, tourniquet, or damage control laparotomy. And there is a lot about coagulation and hypothermia, etc., and there's a lot about preventing coagulopathy. And they recommend, as had been recommended before, that after fluids, you do actually need blood. So packed red blood cells, as well as platelets and fresh frozen plasma in the ratio of 1:1:1. But the latest guidelines say that because red blood cells may not be available, so you use them in 1:1:2. So for every 2 packs of red blood cells, 1 of platelets and 1 of plasma. So the only other thing I need to mention is about traumatic brain injury, where balanced salt solutions have been shown to increase mortality in various randomized controlled trials as well as meta-analyses. So sodium chloride, 0.9% sodium chloride, is the fluid of choice for traumatic brain injury. There have been, we know from the SAFE study that albumin is a terrible thing, but for acute subarachnoid hemorrhages, 25% albumin has been shown to be reasonable, having some good resuscitative properties. Hypertonic saline has been used in traumatic brain injury, but it's not quite there yet. And in fact, there were some pre-hospital studies where traumatic brain injury and trauma, they were using hypertonic saline. All 3 studies, they had to be stopped prematurely for the futility. So it's also been, in one of the studies, it's been shown that hyperchloremia may well have a deleterious effect on cognitive function and recovery of total neurological function later on in life. Ladies and gentlemen, I think the time has run out and I must now conclude this. Thank you very much for actually inviting me. I have to tell you one thing, that no matter what you think about fluid therapy, or the guidelines and a whole lot of other things, fluid therapy has to be individualized for each patient. Remember, no 2 patients are alike. No septic patients are alike. No 2 trauma patients are alike. No 2 diabetic ketoacidosis patients are alike. They're all different. Yes, we can follow the basic physiological principles as well as the basic principles of the practice. But patients are different, and we need to tailor the fluid therapy to each patient according to what their problem is. My last 2 cents are that saline is not a bullet. You can use 2.5 liters of saline in an adult with impunity, but too much of it is not good. I personally would give saline to patients if that's what I had. I've used other solutions, but would give saline without any problem to an adult, but in restricted quantities, 2.5 liters. And after that, switch over to balanced solutions. That's one. And the second and the last and the most important thing I would suggest is that watch out for harmful effects on the patients, because fluids can do that. And while we are trying to resuscitate patients, we also need to make sure they do not come to any harm. Thank you very much. And I hope I have lived up to the expectations. Thank you again, organizers. Goodbye.
Thank you, Dr. Roop Kishan sir. That was a great
You're welcome.
lecture.
You're welcome.
There is a question to Dr. Subbareddy sir. Subbareddy sir. Hello, Subbareddy
Yes,
sir.
yes, I am available.
Sir, there is a question to you from Dr. Shravanti.
Yeah.
The query is role of steroids in septic shock and at what stage we should start it, and serum cortisol cutoff levels to start the steroids.
Yeah.
We generally check, there's no need to generally check random cortisol levels in septic shock. Like long time back, if you see the task force guidelines, Society of Critical Care Medicine, European Society of Intensive Care Medicine. So they were recommending ACTH stimulation tests to see the responders and non-responders. But now there is no requirement, no recommendation to do ACTH stimulation test. But when you check random cortisols, if it is less than 10, then that indicates there is adrenal insufficiency, as I told in my talk. But there's no need to check random cortisols. We need to give hydrocortisone. The recommendation is when after your fluid resuscitation, if still the patient is hypotensive, requiring vasopressors, and then you started noradrenaline, and then you are going to the next vasopressor like vasopressin. So and your vasopressor doses are increasing, then you start steroids, and the preferred steroid is hydrocortisone, and 200 milligrams. You can give it as 50 milligrams hourly, or you can give it as in continuous infusion in these patients.
Thank you so much, sir. So we'll move on to the next topic, the evolving role of artificial intelligence in critical care. This would be taken up by Dr. Peter John Victor, sir. He's a professor of critical care medicine, CMC Vellore. Over to you, sir.
I'd like to thank the organizers for giving me the opportunity to speak on the evolving role of artificial intelligence in critical care. I'll be giving a very broad overview, and it'll be the perspectives of an intensivist. I also have a disclaimer that I'll be using artificial intelligence designer tools to format the slides. Now, is artificial intelligence a misnomer? This quote says that artificial intelligence is not intelligent and machine learning is not learning. For this talk, I'll start with a brief introduction, moving on to some basic concepts, then talk about the spectrum of artificial intelligence, and then the AI applications in critical care, the limitations and pitfalls of artificial intelligence, and then I will conclude. Over the last century, there has been a massive increase in the ability to perform complex calculations. And this development has accelerated with silicon integrated circuits. Growth has been made possible by relentless downsizing of integrated circuits. And recently, there has been a move from silicon to other particles which can pack more circuits. This has resulted in an exponential growth of computing power. And as you can see in the slide, over the last few decades, there has been a quantum leap in the amount of computing that can be done. Now, if you look at and ask the question if AI has permeated society, it looks like every walk of society uses artificial intelligence. There is no escape. Transport system, there's so much of automation. There's digital security and threat monitoring. Criminal justice uses artificial intelligence. Artificial intelligence is used for crop and soil health monitoring, for financial fraud detection and creditworthiness, for marketing and advertisement, and data mining. So it's fair to say that data is the new oil, and there's a lot of data that is being generated worldwide every second. What about the healthcare space? Artificial intelligence has been used for better processes. There has been so much of automation that has happened over the last few decades. AI has also been used for better health in terms of diagnostics, AI-guided medication titration, for the detection of disease, preventive AI for treatment prioritization, and for prediction models. Let's look at some basic concepts
of artificial intelligence. What is artificial intelligence? There are two definitions that I came across. The first one says that AI is a system endowed with the intellectual process characteristic of humans, such as the ability to reason, discover meaning, generalize, or learn from past experience. The other definition says it is the theory and development of computer systems that are able to perform tasks normally requiring human intelligence, such as visual perception, speech recognition, decision-making, and translation between languages. There are several facets of artificial intelligence, and there are different ways of looking at it. The facets include machine learning, speech recognition, natural language processing, computer vision, fuzzy logic, and Bayesian belief networks. But if you want to look at AI in a very simplistic sense and look at the spectrum of artificial intelligence, the easiest way to think about it is AI, machine learning, neural networks, and deep learning as Russian nesting dolls. Each of them is essentially a component of the prior term that is exemplified by the cartoon that is displayed on the screen. Let's go a little bit deeper into the term machine learning. Now, when we look at machine learning can be supervised or unsupervised, and the supervised learning can be done using regression or classification. We'll look at these in a bit more detail. But before that, what is the process of creating a machine learning model? The first is to have good data or collect good data, a data bank. Create a hypothesis. Look at the various determinants or an output that you're looking at. Then split the data into training data where you look at 80% of the data which is used for that, and the remaining 20% is used as a validation data. You develop the model, check performance, feedback, and refine the algorithm such that the accuracy of this prediction model improves with each iteration. When we look at regression models, these are statistical techniques producing a mathematical expression relating one input variable to one or more variables. And the predictable variable or the predicted variable will change in concert with the input variable. And these are used to test causal relationships, and these are done very frequently in the field of medicine. If you look at the picture displayed on the right-hand side of the screen, the first depiction is that of a pattern which is predicted by linear regression analysis. And the one on the right side is something that is not predicted by logistic regression analysis. Moving on to classical or non-deep machine learning. This sort of learning is dependent on human intervention to learn, and the human experts determine the hierarchy of features that will differentiate, that will understand differences between data inputs, and the characteristics which distinguish each picture to streamline the learning process through supervised learning. So in this type of machine learning, a human interface needs to be present. Specific characteristics have to be chosen by the human, and the hierarchy also needs to be determined. And that is exemplified in the picture that is given there. If you want to input a car, there are certain features that are extracted, and these are classified. And then when a picture of a car is being presented to the machine, it can recognize based on the characteristics chosen and the hierarchy that it is a car. The classification model is a form of pattern recognition designed to predict a single non-numerical output or class from predefined probabilities. The classifier algorithms are trained with many lines of data, with each line having several input variables and one desired output. And the methods include supervised or reinforcement learning. Moving on to neural network. Neural networks, or more precisely artificial neural networks, mimic the brain through a set of algorithms. At the basic level, neural networks are comprised of inputs, weights, bias or threshold, and output. And this is sort of exemplified in the picture that is depicted on the screen. Now, what is the difference between neural network and regression? The main difference is the impact of change on a single weight. In a regression, a weight can be changed without affecting other outputs in a function. So as you can see, each of them are directly linked to the output. Whereas in a neural network, the output of one layer is passed on to the next layer of the network. One change can have a cascading effect on the other neurons in the network. And if you can see the slide there, a change in one parameter can cause a cascading effect of changes on subsequent parameters such that the output may get changed. What about deep learning? Deep learning is a subfield of neural networks. It's a number of nodes, layers, or depth of neural networks that distinguishes deep learning from a single neural network. Most deep neural networks are feed forward. That is, they flow only in one direction from input to output. So from the left-hand side, it moves on to the right-hand side. But these models can also be trained through back propagation, that is, move from output to input. And this allows to calculate an attribute error associated with each neuron. And this enables us to have a better fit algorithm in artificial intelligence. So what is the difference between deep learning and neural network? These terms are often used interchangeably, but they are slightly different. Neural networks make up the backbone of deep learning algorithms. It is a number of node layers or depth of neural networks that distinguishes single neural network from deep learning algorithm, which must have more than 3 nodes. Now, how does AI relate to ICU? We'll first look at the intensive care unit environment. The ICU setting is a setting where we have patients with complex physiology or pathophysiology and variability. There are multiple interventions that are being taken up on a single patient, and there is a lot of chance for errors. There's a lot of data, and the question that we need to ask is, can AI help in this environment? Let's look at the quantum of data that can be potentially collected from the intensive care unit. It is estimated that there are about 1,000 data points per patient per hour. So if you're managing 12 patients in an intensive care unit, there are about 12,000 data points that you are able to get and which you need to see every hour. And there is also evidence that the density of data is increasing by about 30% annually. It is no surprise that in 2007, the ICU checklist, which is similar to what the airlines people and the pilots do, was introduced into critical care to minimize errors. These have moved from being a manual check to electronic, and soon I believe machine learning will take on a lot of this manual checks and alert us to things that are going wrong. So there is too much of data. And what do we do with this data? It is observed that medical staff spend about 50% of the time on the computer. Now, let me take this example of driving on a fast lane at 120 kilometers per hour. The human eye may not perceive everything on the way when we are driving. Compare this with 20,000 data points hourly in the ICU. We just cannot perceive and understand and take in every single data point and analyze and give a proper output. Thus, cooperative assistance using artificial intelligence with the ability to intervene humanly may help minimize errors. And I think that's the way AI is moving forward to help us as intensivists. Now, as I said, there is a lot of data and there is a huge potential with big data. Informed decisions can be made based on data. We can factor multiple factors with AI tools. It is said that the human brain can synthesize only about 4 or 5 factors at one go, but AI tools can synthesize and factor in many factors. Now, this big data can be used to more reliably predict pathologies, propose therapeutic options, and response to treatment and outcomes. There is already some data on these domains. Innovation can happen faster, but it's very important to remember that the data quality is vital, because if you put in garbage into the AI, you will only get garbage out. But it's not just volume alone in the intensive care unit. We deal with a lot of variability and complexity. If you look at each and individual patient, they are so unique, genotypically and phenotypically. You have a unique case mix in the ICUs. Patients have different comorbidities, and no two patients are similar. The severity with which they present are so different. The time that they present to hospital and the time to intervention is different. And it's a very rapidly changing physiology. So this introduces a lot of variability, which makes it very challenging for us to analyze and give meaningful outputs using AI. There is also the huge amount of complexity because of the number and types of drugs that we use, the amount of organ dysfunction that the patient has, and the day of assessment. And if you can see on the left-hand side of the screen, there are 3 different patients with different SOFA scores, different presentations, different comorbidities, different age groups. And that is what I said, that there is so much of variability and complexity that we need to look at. Now, also, if you look at the outcomes may be different based on the type of drugs that you've given, the type of support, the time that you've intervened. So the complexity is huge. Now, how do we deal with such complexity? The rapidly changing physiological status poses special challenges for the development and deployment of artificial intelligence. We often apply ideal environmental data, real-world practice, and then we get into trouble. There is also the problem that our understanding as clinicians of artificial intelligence is limited. And so I want to again use the same term that I used a little while ago. We need cooperative assistance with artificial intelligence, and that may be the best way forward. And I believe there are some apps that can help detect ARDS, and there'll be more and more flooding the market where AI will help us make better diagnosis, treat better, and we'll come to that in a moment. So what are the applications of artificial intelligence in critical care? First, I would look at disease identification, evolution, and other factors related to disease. Now, AI tools are increasingly being used for disease identification. Now, finding the root cause of deterioration can be challenging in the intensive care unit environment due to insidious onset, progression, comorbidities, and multiple mimics of certain disease. And if you look at the classical example of pulmonary infiltrates, it may be anything from heart failure to pulmonary embolism to pulmonary infection to various other factors. And AI tools have already been used to differentiate infiltrates due to heart failure versus pulmonary disease using machine learning. It is also possible now to quantify the extent of pulmonary edema using semi-supervised machine learning using a variational autoencoder. And we know that during the COVID pandemic, images were processed through using artificial intelligence to diagnose COVID-19 and also to assess severity. Now, what about AI tools for disease evolution? This is a study which has looked at the risk for cardiorespiratory instability. What you have on the black line are control subjects, and the ones that are in orange start with a higher risk for cardiorespiratory instability and have a persistently higher risk. You have others who start off with a low risk, but over time may start to have some warning signs which will alert the clinician to the risk of cardiorespiratory instability. And if you look at the purple graph, it's about 90 minutes prior to the onset of cardiorespiratory instability that the AI is able to pick up these abnormalities. There are other situations where these may actually be picked up a little late, but nevertheless, artificial intelligence tools are able to help us pick up the type of patients who may be at risk for cardiorespiratory instability, and we may be able to intervene a bit earlier. What about AI tools for disease phenotyping? Now, there is a strong capability of pattern recognition from complex data that allows artificial intelligence to delineate distinctive phenotypes. And there are 2 examples that I would like to take. The one in sepsis, which is highly heterogeneous in presentation and etiology, and has been the favorite target of AI algorithms. A recent study has identified 4 different phenotypes by consensus k-means clustering, and they found that these phenotypes had very distinctive characteristics, biochemistry, host response, and outcome. And these may form the platform on which we can look at therapies that may work in certain phenotypes and may help move towards individualized and personalized critical care. In the ARDS spectrum also, 2 latent subtypes, latent class analysis has revealed 2 subtypes of hypo and hyperinflammatory syndromes, and hence these may again form the basis on which we may be able to determine therapy. AI tools are also used to guide clinical decision making. As we know, for complex problems, one size does not fit all. And reinforcement learning can be used with numerous variables in a given state. And there are models that are being developed and tested in the setting of septic shock and mechanical ventilation. We look forward eagerly to some tools that will help guide clinical decision making. The important thing is that many tools are developed, but it needs to be tested and validated in the clinical setting. And that's where we are lagging behind in AI. Moving on to prediction tools using machine learning, there is a lot of work that has been done over the past few decades. I just want to take some examples of prediction models. The first one is of COVID, 3,597 patients in the US, 486 patients were admitted to the ICU and 344 patients died. 18 machine learning algorithms in 9 broad categories were evaluated, and an ensemble-based model performed better for 5-day ICU admission and 28-day mortality. And they were able to find out that the mortality predictors were CRP, LDH, SpO2 at ICU admission. And the first one was the ICU admission predictors, and the mortality predictors were neutrophil and lymphocyte percentages. Now, machine learning prediction models have also been used in sepsis. It's a very large study of 16,688 sepsis patients. They used a huge number of predictor variables, 86 predictor variables. Not possible humanly for us to look at all these variables and then do a prediction, but AI can help with this. They use demographics, laboratories, comorbidities, and other physiological variables. And they looked at different models and developed area under the curves. They looked at least absolute shrinkage and selection operator, which had a very good AUC, random forest, again, which had a good AUC. The gradient boosting machine, again, had probably the best AUC, traditional logistic regression, and finally the SAPS2, which had the lowest area under the curve. Now, they found through the study that the random forest model underestimated high-risk patients, and SAPS2 had the poorest calibration. So different models are being developed for predicting survivors and non-survivors, or identifying high-risk patients who are likely to not do well. Moving on to mechanical ventilation, I think intelligent ventilation is the buzzword now. But what is intelligent ventilation? Dynamic and responsive machine that provides every patient with safe, efficient, synchronized, comfortable, and appropriate ventilatory support through continuous interactive process. Now, this intelligent ventilation utilizes 4 basic elements: online non-invasive respiratory function monitoring, initiation of most ideal ventilatory pattern for the current lung condition, automated closed-loop controlled adjustment of ventilatory support in response to any change in lung condition, timely weaning from ventilatory support in a safe and controlled fashion without inducing any clinical deterioration of lung function. Now, several ventilators are leading innovation, and different companies have looked at innovation in terms of geographic reach or application diversity. And I think we need both ends of the spectrum, and we look forward to more and more innovations coming into the market. But what is available presently for ventilation assistance? We know that there are tools that are available for assessing lung recruitability. We have machines which have integrated nebulizers which synchronize nebulization with a cycle of respiration. We have integrated an intelligent cough check, automatic cough check. We have integrated volumetric capnography and integrated non-invasive saturation measurements, which can help with automatic adjustment of ventilatory support for a patient. So what is possible in intelligent ventilation? I think there is now the newer Hamilton ventilators, for example. You can preset oxygenation and ventilation, and the machine will titrate both oxygenation and ventilation to adjust these two based on the settings, the parameters. We are also familiar with the adaptive support ventilation, which is being propagated as an auto wean mode, and automated spontaneous breathing trials are now possible with intelligent ventilation. What about cardiac critical care? We have plenty of studies looking at risk stratification, prediction of fatal and non-fatal events, as well as ECG and echo interpretation. Nowadays, we have ECGs which automatically diagnose what the problem and tell the clinician what is there. These are a bit problematic because sometimes machines don't pick up everything, and still the human interface is required to ensure that the machine interpretation is appropriate. But there are several things like QT, PR interval, all these are calculated automatically, so we don't need to waste time trying to interpret all these parameters. But more about echocardiography, which is now increasingly used in the ICU. POCUS is a big thing in ICU. And this is a small study which is done on 90 patients admitted to the ICU. 32% of the patients were mechanically ventilated, and a similar number had an ejection fraction of 50%. The images were taken by two groups, experts as well as novices, and the image was graded as being good quality, fair, or poor in the respective number of patients that I put down there. And the correlation of machine calculated EF, automated, that is machine learning, automated EF, the correlation was 0.86, pretty good, I should say. And the graphs, the regression graphs are very impressive across a range of ejection fractions. Now, more automation in echocardiography is likely in future, such that the clinician doesn't need to spend time calculating this. As long as he's able to get good images, the machine should be able to do all the job for us at the bedside. Now, AI is not without problems, AI are not without limitations, and we'll look at briefly the limitations. The limitations and the problems can be looked at in three compartments. First is data, second is AI development, and third is AI deployment. Let's look at the issues with data. The quantum of ICU data is huge, as we talked about earlier, but on the other hand, the computational ability has also vastly improved, such that modern data generators and computers can actually deal with a huge amount of data. But what is more important is the quality of data. Now, if the data is being collected digitally from monitoring systems, a seamless transfer of such data is possible, and this data can be of high quality. But we need to keep in mind that there can be some noise in the data due to interface issues. For example, a lead falling off or the lead not being properly in place, movement artifacts, all that can cause values outside the normal range that the patient was having at that moment and can cause problems with analysis. Now, the quality of data in paper is problematic because these have to be translated to digital format, and this can be time consuming. There can be problems with missing data, wrong entries, and this is one of the problems that we need to look at. Data cleaning and structuring is very time consuming and tedious, and we also need to keep in mind that data storage capacity would be required as well as safe storage. What are the issues with the AI development? Collaborative effort with all stakeholders, especially medical team, is often lacking, and sometimes there is disinchrony between the clinical question and the AI model that is being developed, making the whole AI process meaningless. The tools that are best suited for the AI development may not have been used for that particular question, and we are not experts in the medical field, and we need to learn a bit more about AI to be sure that the appropriate tools were used for AI development. Issues such as social justice and bias is often not considered in these AI models. What are the issues with implementation? Two factors are vital in implementation: their usability and trustworthiness. Now, complex models in AI are thought as black box. The black box models arrive at conclusions without providing any explanation on how it is reached. The inputs and operations are generally not visible to others, and it's an impregnable or impenetrable system, which causes a lot of concern for clinicians. But I think more and more AI is becoming transparent, and the algorithms that are used to develop these outputs are being more and more coming out in the open, which is a good thing for AI. Now, there are cultural differences and diversity limits that also limits decision processes for every single patient. So it becomes a problem in terms of generalizability or external validity when AI is developed using certain patient subsets. Spurious associations and interpretations are possible, but these can be overcome to a large extent by human oversight. There are also legal liabilities. For example, if the AI accurately predicts an adverse patient outcome, which is not acted upon, are we going to be legally liable? And there are also ethical concerns of privacy and data safety, which also need to be dialogued and debated before AI is rolled out in a huge fashion in the ICU. So what do we think is the future of AI in critical care? These are my perspectives. Machine learning models will become more and more common and more popular. They will provide a deeper understanding of the complexity behind ICU care. It may help us to individualize treatment better. What is happening in the cancer space is hugely inspiring and encouraging, that you can tailor therapy or tailor drugs to individual patients. And we probably are several decades away from that, but AI may help us get there. AI will certainly provide us with better warning systems and help us to prognosticate better. I also feel that the cardiorespiratory monitoring tools will become more comprehensive, and the titration of oxygenation, ventilation, and vasoactive agents may be possible through closed-loop systems with faster weaning from ventilation and vasoactive agents with less errors. If we factor in also prediction tools into this, it may also make this more robust. Clinicians may be able to use the time saved for better patient care and communication. However, I feel care may become more depersonalized, as it is already becoming more and more depersonalized with less human interface. I want to conclude by saying that artificial intelligence has advanced rapidly. It has actually become now integral to care in the intensive care unit. Technological advances have improved outcomes, but I also believe that human interface cannot be dispensed with. Thank you.
Thank you so much, Peter, sir. The next and the last topic for HICS8 would be practice changing studies in 2022 by Dr. Venkatraman Kola, sir, Clinical Director, Yashoda Hospitals. Over to you, sir.
Hi, friends. I will be talking about practice changes, changing papers in 22 and 23 for the next half an hour or so. I thank both HICS team and Samvedam sir for providing this opportunity to speak on this. So I will be trying to talk about around 10 trials, which actually I felt that they made a change in my practice, and they include the steroid use, that is hydrocortisone use in severe community acquired pneumonia, which is published in the last month in NECM by CAPCOD group. The other interesting trial, which actually has a common issues in this part of the world by severe scrub typhus, where the antimicrobials in the form of either IV doxycycline or IV azithromycin or a combination of therapy. And this is published in the NECM in the last month by the CMC team. So we will look at that paper as one of the pride for our this part of the world being published in such a journal. Then I will look at the fluids being another area of debate as a cumulative fluid balance in any of our ICU patient has had a role to play in the outcome So we will go through the Clover group trial in the same early and early resistive or restrictive versus a liberal one versus the previous trial in the last year classic Anesium trial. The oxygen targets has been an area of debate where the pilot group last year in Anesium published a trial giving the the intermediate group of targets of saturation to the higher group to a lower group. So we will see that. The trauma-related resuscitation trial, whether you need to give blood products as an early resuscitation module along with some plasma in the pre-hospital setting versus the regular normal saline or a crystalloid. So what will be the changes? That is actually published by this refill group in the Lancet. So we'll go through that. Vitamin C was a debate after that Paul Merrick trial. A series of trials came. So we will go through the last year's a large Lovett trial, which is published in NEGM. And then we will also go through this candy-sepsis, whether 1,3-beta-D-glucone as an antifungal guided therapy is used by this biomarker. And higher proteins, which has been a common area of nutritional supplements in this sick critical group, whether it is helping or not, which is published in Lancet. So that will be again one of my paper, which I will discuss. Early supplemental parental nutrition has been a big no for many years, and there was a lot of controversy. So we have a paper which actually published in JAMA last year. So we will look at that paper, whether that made any change in my practice. Tracheostomy done in early or late. Again, that's an area of debate for the last decade or so. So we see whether the last year's paper set point 2 published in JAMA. So whether that made any difference. Selective gut decontamination papers and its benefits has been shown in a very small group of countries like the country in Netherlands, and so whether this can be extrapolated in other parts of the world, that is published in JAMA in 22. So we'll see on that. So coming to the first trial, which I wanted to emphasize, the role of steroids, that's hydrocortisone in the severe community-acquired pneumonia, whether it has any mortality benefit at the 28 days. So we all were aware that the steroid use and the hydrocortisone use or methylprednisolone use in this kind of community-acquired pneumonia has gone through a pendulous of yes or no's. And there were different stands by ATS and IDSA versus ESICM and SCM guidelines, one saying yes, one saying no. And we have gone through many trials, including the recent Medori trial, which has not shown any 60-day mortality benefit by using methylprednisolone in them. So with this background, we wanted to see whether the hydrocortisone in the severe community-acquired pneumonia can be a role to play. And this group tried to see by a double-blind, multicentric randomized control trial by doing a randomization 1:1. And they initially thought of actually recruiting 1,146 patients, which will give them 80% of power, to see a 25% relative risk reduction in mortality by using this hydrocortisone. But later on, they could only recruit around 800 patients because this time period between October 2015 to March 2020, where we have seen the COVID wave started, they probably halted the trial at that point of time. And this is done in 31 French centers. What was the intervention? The intervention they did is a hydrocortisone was used in the intervention group, that is 200 mg per day, which is generally the stress dose of steroids, which we use in many septic patients for initial 4 days. And after that, they took a decision whether to give it 8 days or 14 days. The 8 days group where at the day 4, if the PF ratios were improved to 200, and the patient was given a trial of spontaneous breathing, and the SOFA score is better than the day 1. So this is the group where they received 8 days. The other group received 14 days. And this is in the intervention group. So inclusion criteria was a severe community-acquired pneumonia where they received the hydrocortisone group. Exclusion, very interestingly, the all patients with influenza being positive, or those who had actually aspiration pneumonia, or those who had already ventilated for 14 days or received multiple steroids, all were excluded. And obviously the pregnancy, tuberculosis, and immunocompromised situations were all excluded. Interestingly, the outcomes were the death by 28 days in hydrocortisone group was 6.2% versus a placebo of 11.9% with a p-value of 0.006. So this is an interesting finding where there is a significant mortality benefit in community-acquired pneumonia with the severity of that categories. Now, the secondary outcomes which they saw was the cumulative incident of hospital-acquired infection and GI bleed, which we are always concerned whenever we use a steroids. And both found to have no significant difference between the hydrocortisone group or those who actually were managed without any hydrocortisone. And there is a significant less in death by day 90 in the intervention group. The cumulative incidence of endotracheal intubation, cumulative incidence of vasopressor requirement, all were seen to be significantly low in the group where hydrocortisone was used. So in conclusion of this trial, the early treatment of hydrocortisone reduces the 28 days mortality in those who are admitted in the ICU. So there were strengths and weakness. In the interest of time, I will not go into the details of it. This trial has to be halted at 800 patients because they found the group at that point of time is enough with that. But there is a fragility index of 6 patients in this group, where if you have a 6-patient change in either side, you may have a change in the outcome. So with this, at this point of time, my practice change will be, I probably at this point of time will consider using hydrocortisone, that is in a stress dose of 200 mg in 24 hours time for around 8 to 14 days in severe community-acquired pneumonia. But I will keep a exception to the H1N1 and the groups which has been excluded. And we had an experience also with the COVID where there is a subgroup of population in early part, the steroids did useful in that. So this will be my practice change. And this is the second trial I wanted to discuss, that is about intravenous doxycycline, azithromycin, or combination of both for severe scrub typhus. Scrub typhus has been one of the commonest etiological factor for undifferentiated fever or one of the tropical fevers in this part of the world. And we have been given a conceptual text that either IV doxycycline or azithromycin can be used, but the practice in many situations were in combination of both of them, but we never had any good randomized controlled trial giving that information to us. So our CMC group, including our Verghese and the other Indian intensive care units, found this a topic to be interesting and did a randomized controlled trial, which is published in the NEGM, which is a pride for many of us in this part of the world. And they could actually do this double-blind randomized controlled trial comparing the efficacy of intravenous doxycycline, intravenous azithromycin alone or in combination in treating severe scrub typhus. And they actually assigned to receive a 7-day course. And how did they actually define the severe scrub typhus? Those who has at least one organ involvement at this point of time. And they tried to see a composite outcome of death and persistent complications and the persistent fever. So these are the 3 composite outcome of death in 28 days, persistent complications by day 7. They said it is in the form of organ dysfunction or persistent fever by day 5. And these are the outcome. What they realized is the patients with severe scrub typhus, when they received doxycycline alone or azithromycin alone, compared with those who actually received combination of therapy, the composite of death at 28 days or a complication in the form of organ dysfunction or a persistent fever at day 5 were significantly statistically higher in the group of IV doxycycline and IV azithromycin compared to when they used combination, and the p-value were considered to be significantly statistically significant with in doxycycline and comparative group in 0.002 and in azithromycin group as 0.001. That means in compared to single agent IV doxycycline or IV azithromycin, the combination of therapy had a better primary outcome compared to single ones. But when they compared with azithromycin with doxycycline, they could not find any difference. In the same way, when they looked at the secondary outcome, that is death, only death at 28 days or fever difference, they could not find any statistically significant differences. This is again the forest plot graph comparing the combination therapy with doxycycline, combination therapy with azithromycin, and the last one between azithromycin and doxycycline. You could clearly see that the combination therapy versus doxycycline and combination therapy versus azithromycin is suggesting that there is a favorable outcome in favor of combination therapy compared to alone in doxy and azithromycin. Whereas in azithromycin and doxycycline comparison, there is no favorable outcome on either of the side. It remained to be in the center. And there is again a Kaplan-Meier graph which is suggesting the doxy and azithromycin group had a probability of primary as a primary composite outcome has a higher deaths and the complications and the fever delay compared to the combination therapy. But these are the survival at 28 days when it is only the mortality is taken or persistent fever is taken, they could not find any significant difference. And PCR positivity, when actually they repeated the PCR positivity, they have also found a difference, but that was also not statistically significant. So what will be my practice change? Even though in the previous years also we used to try a combination of intravenous doxycycline and azithromycin in patients with severe scrub typhus group. Now we have a randomized control trial evidence in this part of the world where it is evaluated that the combination of doxycycline and azithromycin is probably a better therapeutic option to treat these severe scrub typhus patients than a monotherapy alone in the form of IV doxy or IV azithromycin. The third interesting area which I found, we have been, there is a kind of a trend towards using a restrictive fluid strategies in many of our septic patients right now. The reason is we have more and more evidence suggesting cumulative fluid balance has been significantly affecting the outcome and mortality. We have, but we have different guidelines which are suggesting that we probably initially resuscitate with a good amount of volume in the form of 30 ml per kilogram. And also there is a huge variation of practices swinging between 4 liters to 6 liters in the first 24 hours in different parts of the world. And the last year classic trial also given there is no difference in 90 days mortality between this comparison. So this is again a multicentric randomized unblinded trial of superiority trial where randomized 1:1. This is done in a 60 United States centers, and there was an estimate of 2,320 patients to give a 90% power, and this was done between 2018 to 2022. There is an inclusion where you have a patient who had a sepsis suspected or confirmed with a hypotension, that's a systolic pressure less than 100 or MAP less than 65, already received 1,000 ml of volume. So this is the inclusion criteria. Exclusion criteria is those who already received 3 liters of volume or were there in the hospital more than 24 hours. And there is also more than 4 hours after a hypertension. So these are all the exclusion criteria. And among them around, they actually evaluated 12,000 odd patients, but finally, they randomized 1,563 patients into 2 groups, one 782 in restricted group and 781 in the liberal group. What did they do? What is the difference they do? In restricted group, when they found the blood pressure is less than, the systolic pressure is less than 100, MAP is less than 60, after receiving 1 to 3 liters, up to 2 liters they allowed. These are the patients who went for a norepinephrine or a vasopressor addition to target a MAP of 65 after those initial 2 liters, up to 2 liters of volume. Then later on, these patients were given norepinephrine and vasopressin. Whereas in liberal group, after actually a liter or to 3 liters of crystalloid, if my blood pressure is still systolic is less than 100 or MAP is less than 65, there was a consideration of 2 liters of volume challenge again, considering after the initial a liter, there will be an assessment, and if required, there can be another liter at that point of time. And there will be additional boluses of 500 ml in both the groups when there is a refractory hypotension, the MAP below 70, or lactates are climbing up, or there is a tachycardia and all. In the control group also, they used vasopressors when after 5 liters of IV fluids are given and the patient is still hypotensive, or the lactates are more than 4, they try to give the vasopressor. So if you see the restricted group, they try to use vasopressors early and try to manage maintain the blood pressure. In the liberal group, they try to give a further volume after the initial resuscitation also, and use the vasopressor only in the circumstances where they could not maintain them. The primary outcome, they tried to see a death before the discharge home by day 19. They could not see any statistical difference. The restricted group had a 14% deaths at the time before discharge home, whereas the liberal group had 14.9. There is no significant difference in organ supports, free days from ventilator, days out of ICUs, no intubation, no ARDS, whereas we will consider ARDS being a common problem when there is a lot of logging of volume. But there could not be. And subgroup analysis also could not differentiate in different formats. Post-hoc analysis found that those patients in the restricted group required a higher rate of ICU admission compared to those who are volume. Probably the need of vasopressor sometimes prerequisites ICU admission. So there were different strengths and weaknesses. We will not go into that. There was a large number of eligible patients in this trial, but they only selected very few, and there was some overlap also. So what we can find is in this case, there was no statistical significant difference in outcome or organ dysfunction. If you can see this, the restrictive fluid group received 500 ml in the initial 6 hours, whereas the liberal group received a 2,300 ml in the initial 6 hours, and the difference was around 1,800 ml. In the 24 hours period, the restricted group received around 1,267, whereas liberal group received 3,400 ml. That is a gap of 2,134. And you can see the vasopressor requirement difference was there. The restricted group had a higher, almost 59% of patients required vasopressor, whereas a liberal group had only 37% of patients requiring a vasopressors. And if you see the conclusion which is derived from this trial, the sepsis-induced hypertension, the restricted fluid strategy used in this particular trial did not result in significant lower or higher mortality before discharge home by day 90. So it remained to be no difference in between them. So in my practice, what will I do? It almost actually mimicking the same classic trial. I will run through that. It appears that both the approaches are safe, and therefore I will continue to use a multimodal approach to assess my patient and their requirement for fluid. And probably I will use some form of volume responsiveness, dynamic volume responsiveness test, rather than either choosing a vasopressor or choosing a volume. If my patient is volume responsive, I will still give volume. And if my patient is not volume responsive, probably I will switch to a vasopressor in those situations. So not actually inclining towards a volume or a vasopressors alone. Same way, I actually had the previous year, in June 2022, we had classic trial, again, almost of the same, the restriction of IV fluids in ICU and septic patient, comparing a restricted group and they also could not find any death by 90 days in both the groups, and there is no significant difference in any adverse outcome. But what we find in this classic trial is the total difference in cumulative fluid balance by day 5
was only 2 liters, so which is and 800 ml by day 5, 2 liters by day 5, 800 ml by maybe in the later part. So there was not of much cumulative fluid balance in the cumulative fluid balance difference, and we all understand the cumulative fluid balance of higher grades like 10 liters or 15 liters or 20 liters is the main problem right now what we are facing. So classic trial in both the groups, if you see, the difference in cumulative fluid balance was not very high. So that's why probably we have not seen a significant difference. Next, I wanted to just focus on this pilot trial, which is published in last year, oxygen saturation targets. We all being very, very paranoid about keeping a lower FiO2s to target a lower oxygen saturation to avoid many hyperoxia related toxicities for a longer period of time. But this trial compared the 3 saturation targets. One target is between 88 to 92, mean of 90. The other one is between 92 to 96, mean of 94. The higher one is between 96 to 100. And this was done in a single center in US between 2018 to 2021. And the inclusion criteria were those who actually are in emergency and ICU require mechanical ventilation. They excluded pregnancy and COVID patient. There was actually equal amount of COPD, CAD patients. So in this, so they targeted, the intervention group had lower oxygen targets between 88 to 92, and intermediate had 92, and the higher oxygen targets were 96. And the rest all management remained to be the same. And you could see actually from day 0 to day 8, they could actually manage with a very good range between them in all these 3 groups. And they actually tried to see what happened, how many of these patients survived and came out. The primary outcome is the 20 days, the outcome of how many of them are alive and free of mechanical ventilation in the 3 group. And they could not find any difference, any significant difference in these 3 groups. Secondary outcome, they tried to see in these 2 groups where they tried to find out what is the difference between these 2 at a 28 days mortality. They could not find any difference in them. So among critically ill patients receiving mechanical ventilation, days alive, days free, free of mechanical ventilator did not differ among these 3 groups, whether I target lower, intermediate or higher. There are different strengths and weaknesses. I'll not go into those details. What will be my practice change? So this was one of the excellent trial which actually challenged my prior inclination towards having a lower oxygen saturation targets and lower FiO2 targets, pushing saying ki higher FiO2 probably are harmful when I use for a longer period of time. So probably this is an eye-opener for me where I will not push myself for a lower targets, which may also always sometimes may go into a quicker hypoxemia whenever there is a acute change in any of those clinical condition. But I will try to continue to probably look for some intermediate oxygen targets at this point of time. And I will wait for this MegaRox, which is a further larger trial which will answer these questions at this point of time. But I will not be paranoid of keeping my FiO2 or saturations on the lower targets. Probably I will now keep my targets in 92 to 96, keeping a mean of 94 or so. This is another trial which actually was done on a pre-hospital settings, comparing the normal saline versus a packed cells along with a lyophilized plasma to see whether when a patient in a pre-hospital trauma setting is hypotensive and whether to give them normal saline or a O negative blood, which they tried to see, giving a O negative blood with the lyoplasma group. And they tried to see what is happening to the outcomes. When one group they compared with giving a saline of 1 liter to maintain the blood pressure, the other group they tried to give a packed cells along with the lyoplasma group. And they see the outcome, primary outcome as a mortality. They didn't find any difference in the primary outcome. or they didn't find any outcome of lactate clearance, vital stability, or any coagulation profile differences. Only difference they found was hemoglobin on arrival to the ED was higher in the group where the packed cells were received. So this probably suggests that at this point of time, we cannot generalize a situation where we will use packed cells and lyophilized plasma in all pre-hospital trauma hypotensive patients. Probably we may need to subgroup them a specific setting or a specific group of patients who probably are hypotensive and may land up into a massive transfusion because of some serious injuries inside, may get benefited by this. But at this point of time with this trial, we cannot come to a conclusion that the O negative packed cells combination with plasma may be a preferred choice over a saline in a pre-hospital hypotensive trauma patient. Both of them seems to be equally effective. This was again another interesting trial regarding vitamin C after the Paul Mauric trial, which suggested a huge amount of mortality benefit. There is a series of trials done on the vitamin C. And this is one of the largest trials done in a single center after those two meta-analysis and citrus ALI trial, which actually concluded after so much of debates in the 35 adult medical surgical ICUs in Canada, France, and New Zealand, where the intervention group was given around 3 grams, that is 50 milligrams per kg, 3 grams of IV vitamin C every 6th hourly. That comes around 3, 4, or 12 grams in a day of vitamin C, comparing with those who actually have a placebo infusion in septic patients, and try to see the benefits out of this and the composite death and persistent organ dysfunction, which has been shown, and mechanical ventilation days. Interestingly, they found the group which received a high dose of vitamin C, that is around 12 grams, they had a persistent organ dysfunction or a death higher than comparative to those who were received placebo, and the AKI was also higher in the group with vitamin C. So probably this is one of the largest trial which actually talks about the role of vitamin C. And after this trial, I will not use high dose vitamin C in patients with sepsis or vasopressor, as a number of trials and the recent meta-analysis have shown no benefit with high dose vitamin C. And this trial should end the debate regarding the use of vitamin C in septic patients. 1,3-beta-D-glucan guided antifungal, that was a candice which is recently published in Intensive Care Medicine Journal, which suggests that this trial concludes that the use of 1,3-beta-D-glucan guided empiric antifungal therapy has not shown any benefit. So early antifungal therapy guided by beta-D-glucan at this point of time has not improved 28 days mortality. So until further evidence comes, I will not use 1,3-beta-D-glucan. Even though the cutoff was 80, there were suggestions of using higher cutoffs, but at this point of time, it probably will not. There is another interesting debate related to the early or late supplement parenteral nutrition. SPAN, ISPAN, SCCM, everybody had a different stand. Some ISPAN said 3 days to 7 days, SPAN said 7 days or so. But this is the trial which actually looked at early supplemental versus late supplemental parenteral nutrition. The early ones, they commenced within the 3 days of post-surgery. The late ones, they commenced in 8 days of post-surgery. And they found early supplemental parenteral nutrition had reduced nosocomial infection in patient undergoing abdominal surgery. The bottom line is, if I have a patient who is nutritionally deprived, catabolic, and lost a lot of muscle mass and needs a supplemental parenteral nutrition, I will not probably hesitate to add a supplemental parenteral nutrition if I'm not able to achieve my enteral nutrition adequately in early. Probably because of improvement in infection control practices and glycemic control, the problems or the adverse outcomes of the enteral parenteral nutrition has gone down. And set to point randomized clinical trial again confirms that not just in ICU patient, but even in stroke patient, early tracheostomy has not shown to be beneficial both in MRS scoring or in any mortality benefit. So that is again suggesting that early tracheostomy has not shown to be beneficial even in stroke patient. This is done in only stroke patient. compared to TrackMan trial, which is done in ICU patient. Selective gut decontamination trials were confined to Netherlands. This is another trial which is done in the Australia and New Zealand. And this trial suggests that there may be a trend towards decrease in number of hospital-acquired infections which are drug resistant. But it's need further evaluation in the context of that. So I will not probably change my practice and start this. High protein diet. This is again a pragmatic registered trial which actually showed that high protein diet in patients who are highly catabolic may not have a positive effect, and they have shown to have a negative effect, most likely in a patient who had an renal issues or AKI. So they compared between the protein of 1.2 to 1.2 to 1.5 grams per kilogram versus higher proteins, and they found the higher protein group had more harmful effects on acute kidney injury, higher organ failure scores compared to those who actually received 1.2 to 1.5 gram per kilogram of protein. That indicates, suggests that early probably normal protein supplementation, which we say 1 or 1.2 grams per kilogram in initial phase of this catabolic sick critically ill patients is quite good enough. Higher protein may have a harmful effect. This is again another interesting trial which actually compared colistin versus a combination of colistin plus carbapenem and published in NAGM. And this suggests that the combination therapy is not superior to colistin alone. So in the situation with carbapenem resistant organisms in the form of Klebsiella pneumoniae or Acinetobacter, probably we are in a situation where combining colistin with meropenem probably is not superior to the colistin. These are my practice changing trials. I will probably use hydrocortisone in severe community acquired pneumonia if I don't have any contraindication. I will probably use IV doxycycline plus azithromycin in severe scrub typhus. I will not either use restrictive or liberal, but I will use appropriate fluid management in septic induced hypertensive patient, keeping a watch on volume responsiveness and replacing volume if they are volume deficit. And once the patient is not responsive, probably using a vasopressor. Oxygen targets in mechanically ventilated patients, I will go into the intermediate rather than to a lower side and not worry much or paranoid much about keeping a low FiO2 and low saturation target. In pre-hospital setting, probably saline will be as good as a blood product as long as I'm not subgrouping them. No vitamin C for septic patient. 1,3-beta-D-glucan at this point of time cannot guide me to start an antifungal. Higher protein for a critically ill patients with high nutritional risk has shown to be harmful for AKI and organ dysfunction. So I'll stick to normal protein diet in the early phase of critical ill. I will initiate early supplemental parenteral nutrition in high risk group, not worried about the infections or glycemic issues, taking care of them. Set point 2 says in even stroke patient, I will continue to do tracheostomy as the patient's need, not early or not late. Selective decontamination still remains to be an area of controversy. I will not conclude at this point of time. I give my best wishes from my institute. Thank you.
Thank you so much, sir.
Thank you, Dr. Venkatramana.
I hand over to Dr. Mithilesh for vote of thanks.
Yeah, thank you. I'm Dr. Mithilesh. Good afternoon all. It's my privilege to propose a vote of thanks on behalf of HICS team. And all good things come to an end, and so has HICS 8. But the good thing is that the video lectures will be accessible on HICS website in a due time. And I would like to thank all the faculties, distinguished faculties, for enriching the academic content of this program and also taking off their valuable time from their busy schedule. I would also like to thank all the delegates for having faith in our program and attending it year by year. Now, I would also like to thank the industry people like Cipla, Mindray, Pfizer, Fresenius Kabi, Converge Biotech, Wokhard, and Abbott for helping us to conduct this program. I would also like to thank the event partners, meetings, and more for seamless conduction of the event. And in the end, I'm also thankful to all HICS team members, including Srinivas sir and Samvedam sir and Ghansham sir, who have shown us the way and led to the successful conclusion of this program. And next year, we are going to come back on the month of June, 14 to 16 June, for the next event of the HICS9. And all the certificates have been uploaded in the system, and they can be downloaded by all the participants. And I wish you a great year ahead, and see you next HICS. Thank you.